can see in the image here, the stem of the lateral septum.
Very good afternoon, guys. I'm Dr. Preeti Sharma, and along with all the educators at Prepladder, we welcome you to this analysis session for the recently conducted INI CET May 2025. But before we dive into this ocean of recalls and analysis and so on, first, all of you need to take a sigh of relief. Well done and dusted, at least for the time being. And secondly, a pat on your back, because the situation and the circumstances in which you've gone in for this exam has not been easy, not just for you, but for everyone around you. As a nation, it's been a very testing time for everyone. And in this, if you had the grit and determination to study and to sail through this, of course, it's something which not everyone can do. So you deserve all the applaud for it. And now, of course, we are here to discuss the analysis for the exam that happened. I've spoken to a few students, and moderate to slightly difficult is the review that we've got. Even the questions which were easy, if you say so, they are saying that the options were definitely twisted in a manner that the easy questions were also not so easy as they say. But yes, we would want to hear a lot from you also. This is a session where I believe that till the exam is conducted, you are dependent on us for a lot of things like the video lectures, the LRRs. But once the exam is done and dusted, the tables turn, and we become dependent on you guys to know about the feedback. And trust me, every educator, ever since the exam starts, they are just looking out, and they are also seeing the clock again and again. They are waiting for all of you to get back and to tell them that the exam went well, because that's the only answer that we all wish to listen to. But of course, everyone is going to have a mixed bag of review, because this is not just any other exam. This is an exam that is to do with the medical profession. So it can't be all easy. It is going to be difficult at some level. So yes, we are here to listen to all of you, and I can see many of you have joined in, which is great. And you've also started giving in a lot of questions regarding pinworm, etc., which is amazing. But we will discuss all of that. Before that, do join in and do remain with us till the very end, because we have a lot of giveaways for all of you. Now that you've come post exam, you're not just here to study. You also want to win a few things. So maybe if you contribute to the questions and the options, we have a few giveaways for you that you can see on the screen. So you can just contribute on the Google sheet, and the more number of answers, options that you give us, we would be able to help you with a lot of giveaways also. Secondly, adding on to this and adding on to the excitement, we have an additional 15% off on all the Elite version X plans for the 6-month and 12-month subscription. And in case you wish to buy that, then there is a code for it, that is INI CET 15, that you can use, and you can get that discount. All the other details are also on the screen. Before I hand it over to the panel of judges, we also have the toppers from the previous years of INI CET. We have Dr. Akhil, we have Dr. Abhilash, and we have Dr. Mayank, who've all scored amazing ranks under 20, if I can just generalize, in the previous year INI CET. We are also going to see and listen to their insight into this. But before we go to them, I would want to put it across to all the educators of Prepladder and know from them that how the exam has been as per them. So let's get going and transfer this to the panel.
Thank you so much, Dr. Preeti. Now that the exam is over, I'm sure a lot of anxiety and a lot of feelings do creep into all of you. But we here have with you our educators with us who are going to give you a little bit of analysis on how the exam was. And we've got the questions from you. So based on that, we'll try to come up with what actually the paper turned out to be. Now, as I take PSM, so for me, I would just like to say that PSM was moderate. We had a couple of PYTs being repeated, and I think that you would have been able to do. However, we will be having a recall session for that. But before that, let me move on to our amazing educators, and I'm just going to ask them quickly about the paper and stuff. So let's start with Marwa sir. So sir, according to you, how do you think was this year's INI CET paper compared to previous years in terms of difficulty?
Hi guys, hope you're doing great. So first of all, I think you can chill, relax. The paper is over. And before I get into my bit about how the paper went, I would like to congratulate you about the fact that you were able to study in this last, I would say, stormy week which happened. I mean, you can, after a couple of years, I think you will be telling your children and grandchildren that there was a war going on and you were focusing on books. So, I mean, hats off to your dedication. I was in touch with a lot of you. I understand all those bombings, all those drone attacks and all those things take a toll on everybody's, mental well-being, and everybody is thinking, I mean, kal kya hoga? We never knew. And in that setting of uncertainty, I mean, you guys are like, I would say, resolve of steel, I would say, for the grit and the determination that you have shown. Now coming to like, I have my esteemed panel of Prepladder with us, so I think most of us would agree that this was more of a conceptual paper. I agree there was no ECG, there was no ABG, that's what people go in with, that there's going to be loaded with ECGs and ABGs, but yeah, sometimes they may not ask that. But I'll be discussing those questions as they come across, whether it's mitral stenosis murmur, whether it's that skull X-ray with follicular cancer as a possible answer. I'll be looking at, the options that you guys would be coming up in the chat. But at this moment, I think that you can treat this session as a match practice, because after all, I mean, 1 month down the line, we are staring at the barrel of the gun again. It's going to be NEET PG. So this recall, I think, would be beneficial for you. This exam analysis will be beneficial for you, because just like, in a game of cricket, you need to analyze what went wrong, how things went, how was your mental aptitude during the exam, first hour exam versus second hour of the exam, third, like, mostly what I see is that when the mental stress builds up, by the second hour, the performance tends to, some people tend to peak in that, some people revel in that pressure, and some people tend to have a slight dip in the performance. So aati hui cheeze bhi galat ho jati hain. So I think that this was a real match practice for you to know, I mean, what are your strengths, what are your weaknesses, and you can work on those weaknesses in the next 1 month, especially the subjects which you think were not optimal. I know you're brilliant people and you've done great, but then there would always be small chinks that we need to fix. And more importantly, like, we will come out with the exam analysis from the perspective of answers to the questions as well. I know you are eagerly waiting for that, and you're commenting in the chat box with respect to, okay, what is going to be an answer to our questions. So yes, be patient, stay with us till the very end, and we have a couple of giveaways as well. And this would be my take, guys, moderate to hard paper, and a conceptual one. And one needs to put mind focused for 1 minute on the screen to get to the correct answer, and this has to be done repeatedly till you get to the last question. So the stamina that you exhibit in the first question has to be identical in the stamina that you show in the last question, and this has to be replicated again in NEET PG as well. So I think, ma'am, that would be my input for the same.
Thank you so much, sir. Very rightly put. The exam is obviously a time when your patience is tested. And now, as we can see in the comments section as well, a lot of you are wanting the answers to the questions. So we will get to that. But before that, like sir says, we have a lot of giveaways also. So stay tuned for this session. Moving ahead, now I have with me Shanali ma'am. So ma'am, according to you, did you notice any major change in the question trends or formats this year?
INI CET exam trend has been as expected from INI CET. If you look at it, like previous year topics, I would emphasize on topics rather than PYQs, because all of us do prepare, the PYQs here and there in the lectures also, even in the Q banks, many times the PYQs are anyways covered. And like it was mentioned earlier, that even if there were, straight rip-off PYQs, the language was maybe a slightly different, or the options were maybe slightly closer, as you expect from INI CET any which ways, right? Like you close calls between two options. There were many questions like that. And even if you look at the previous year topics, right, more or less we've not seen any off the chart, any out of the blue question or out of the blue topic being asked. And to summarize it with the context of obs and gynae, for example, The topics that have been asked are very basic, like for example, from the gynae perspective, infertility was asked, or PCOS was asked, or PPH in obstetrics was asked. So these are all very basics, hardcore gynae obstetric topics, right? Which you do anyways in your final year, and then you build on it for your NEET PG and INI CET exams. So again, focus has been on previous year topics, and that is the takeaway from this exam as well, that you stick to the PYQs and previous year topics. And conceptual, yes, of course, even with NEET PG examination, we are expecting them to follow the same pattern of being conceptual, because in the end, mugging up with lists is something that everybody can do, and concepts is something that helps you answer as many questions as possible. Yes. So that's my takeaway from the exam.
Yeah, thank you so much, ma'am. So like we've always been stressing that you cannot ignore your PYTs and PYQs. They actually form the base of any exams, but at the same time, we are helping you strengthen your concepts. Now we know that in the exams, we have a lot of images, the pattern keeps changing, integrated questions. So let's ask Pratish sir. Sir, according to you, what do you think dominated? Clinical questions, image-based, or were there one-liners? How would you want to put it?
So in this paper, discussing with the students, the feedback we got that most of the questions were clinical and one-liners. Image-based questions percentage was not that much. The amount of question we expect in INI CET in the form of image-based question, that much was not there this year. So this year, one-liner questions were there and clinical questions. Obviously in surgery, you are going to expect integrated questions, clinical questions. So there were predictable questions, like there was breast cancer staging, there was BRCA mutation, there was appendicitis, Alvarado or Manton score, tension pneumothorax, Z-plasty, and staging of carcinoma colon, means colorectal cancer. So these predictable topics were there, predictable questions were there. And if you see surgery per se, it was not very difficult. So I would say that it would be, moderate paper. And 2-3 questions were repeat with options also, means there were previous year questions also and previous year topics also. So if you see my opinion, the paper was moderate, and in surgery, one-liner questions were also there and clinical questions were also there. So that's my opinion.
Okay, thank you, sir. Yes, so we had a mixed kind of questions. So now moving ahead, let's ask Thamar sir. Sir, again, like we stress on PYQs, concept-based questions. What do you think is your take on PYQs, PYTs versus the new concepts?
Hello guys, best wishes for this exam. Now there are 3 things. Actually, my answer is already been given by ma'am, Sonali ma'am. There are 3 things: PYQs, PYTs and concept based. 10 to 20% question are PYQ based, but little confusion in options. PYTs are 30 to 40%, and the concept based questions are almost remaining questions. So if you see the pattern in this exam, the PYTs are more important than PYQs if we compare with these. So just concentrate on PYT, previous year topics and new concept building. That is all from my side. Thank you.
Okay, thank you, sir. Also now we have so many subjects. So let's ask Ankit sir, so what do you think, which subject carried the most weight this year? Since we've received the questions from students and you've had a look, what do you think according to you were the most important subjects this year?
Thank you, ma'am, and very hi to everyone. So take a sigh of relief, the paper is done and dusted. And coming to the weightage of subjects, again from the students' feedback which we have got, the weightage has been similar to what we have been seeing in the previous trend. So pre and paraclinical subjects have been asked quite a lot in this exam as well. So first prof and second prof, especially if you ask me, second prof slightly more number of questions were there than the first prof. And of course there were questions which were clinically integrated with some of the clinical subjects. And if you ask me about psychiatry, I would say there were more number of questions this time. Previously there was just 1, but this time we could get 6 questions. And again, the topics were very similar, which they've been asked previously. Substance question was asked. Psychopharmacology again, which they integrate, that has been asked. So I'll say again, the options were a bit tricky. So moderate level of, if you ask me, the severity for psychiatry.
Okay, so sir has put out a very important point that psychiatry, this time the questions were more in number. So basically when you appear for any exam, you cannot tend to, leave out any subject. All subjects hold equal importance. So moving ahead, one more thing, now we have these days theory, clinical. So let's ask Ankit sir, sir, how do you tackle subjects that lean heavily on theory or clinical cases according to you?
So first of all, I hope you all are relaxed now. So remember one thing, theory and clinical scenario are never binary to each other, they are rather always complementary. So first you need to understand theory always so that you can take your ship into a sea. But if you are not applying or integrating it clinically, your ship will be sailing in an uncharted way. So always pre and para subject, as INI CET has again lived up to its reputation, pre and para was the major chunk of this exam and the questions were twisted. Theoretical knowledge was imperative in this case, and most of the questions in first and second year subjects, they were very much integrated with the clinical cases. So we have to have an holistic, or you can say a comprehensive understanding of the topics as well. Only then INI CET is a doable exam for us. So this is my take on this.
Okay, and we'll just have one more question. Pratisha, what
presents, what is the clinical feature, how we are going to investigate the patient, and how we are going to manage. So if you remember this sequence, very soon or slowly you understand the trick, and you have seen all these things during your posting. In final year you have attended the clinical rounds or wards, you have seen. In internship you have attended, your postings everywhere, and you learn all these things. So no need to put too much of stress. If you are going to study the subjects, whenever sufficient amount of data will collect in your brain will start doing the logic, or your brain will start integrating itself. So that's why lots of questions are asked in integrated fashion. So that question can belong to pharmacology also, to surgery also, like it's related to BPH, alpha blockers. It's related to pathology also, related to surgery also, like papillary carcinoma. We discussed intestinal obstruction, volvulus, related to surgery and radiology. So you are not supposed to worry a lot about the clinical focus. Whenever you are going to study the subjects on your own only, you can integrate the subjects. So that's my view.
Okay, so I'm sure you guys did benefit from the short session that we had on the analysis of the exam. However, the exam is over now, so please don't stress out too much. We would now be moving on to our recall segment, but before that, I again want to remind you, everybody, that we have a lot of giveaways. Whoever contributes maximum questions for recall will get amazing giveaways. And we also have an amazing offer, which is 15% off for our viewers on version X Elite plan for 6 months and 12 months duration. All you need to do is use code in INI CET 15 to get this amazing offer. So now everybody, I know you've been waiting eagerly, so we'll be starting with our recall segment, and the first session that we're going to have is on microbiology and pathology, followed by the rest of the subjects. So do join us.
If you know, this is not a proper recall session, which we will have eventually on the YouTube channel itself for all of you, because this, I believe, is a very short time to actually gather the questions. But I still want to credit all the students who've helped us in doing so, and to the best that we could, we have got questions for you. So I'll quickly, in let's say 15 minutes, run you through all the questions that came in pathology and in microbiology, starting with the very first one that we have over here. This, I believe, I'm starting first with micro because I know that that was a little heavy in the exam in comparison to pathology. And of course, this is a session where I'm heavily dependent on you guys, because you are going to give me the answers to these, and that is exactly how we would know what I need to change. Also, there is a Google sheet that is circulated, which means that anything you feel later on that I should be changing in the options, that will help me also, and then I'll be able to give you a better and a more accurate recall on Monday when we meet again for the actual recall session. But I hope overall, I think all of you have been comfortable with micro. I mean, I hope I'm not speaking over and above, but I think all of you have been comfortable with micro at least. That is the preliminary feedback that I've got from all of you on Telegram and other social media platforms. So starting with this was a question, and I'm not discussing theory. This is just a very quick run through so that you just get your basic answers and you're able to sleep at peace tonight that you've done things right. So the first thing over here is satellitism. I hope for satellitism you ended up marking Haemophilus influenza, which was the answer. That is the organism organism that shows us satellitism. Moving on to the next one is this question where there was something asked about Vagat-Suma agar and the Kanagawa phenomena that is shown by the salt-loving organism that is Vibrio parahemolyticus. So yes, I can see a few answers coming in which I think is amazing. Perfect. Streak was asked. Perfect. I think a lot of you are suggesting some changes, which I think is good, and I'm going to replay this entire chat later on and I'm going to add these changes, but this is something very basic that we've received as of now and we're just going to rush through them one by one. So I hope you got this right. That is the Kanagawa phenomena. Moving on to the next one that we had. This was a patient with a lesion over here. I hope all of you made this as secondary syphilis, reason being that there's a history of sexual intercourse also that has been given, and that you were told that there is going to be a sexual intercourse. They didn't give you the genital ulcer, they gave you this hand lesion, probably secondary syphilis, that is condylometalata. And for this, I think we would want to do serology, because for syphilis, this is exactly what you're going to do. So I think, yes, meanwhile I've started getting some great answers, which is good. So you guys are still in the exam mode. Many of you saying Zank smear, which I don't think, because that would have gone more in favor of herpes. We had a different question for herpes, which I'll come to. This was an immunoglobulin given. You can see immunoglobulin Y shape, but this is a dimer. The dimeric immunoglobulin is going to be IgA. I had to have a question on immunoglobulins per se, and that has come up. So I think we are good to go on that. Anything else that you want to add on? Trust me, I'll be reading the chat again once I'm done with this. So I will obviously incorporate. Which of the following helminths shown over here shows auto-infection? Now, there's a famous mnemonic called CHEST, which all of you had read in your notes. Mostly, and I said I'm not trying to oversay it, but there have been a lot of questions from rapid revision that have come as it is. It was just about micro recalling. So coming here, we have, as per the CHEST mnemonic, H. nana shows you auto-infection, and also strongyloid stercoralis can show you auto-infection. So now over here, I don't know how the question came, whether it was a multiple answer question or whether it was, the single best answer. You had 1 and 4. That I'll have to work out on. But as per the options I've got, both of them can show auto-infection. Moving on to the next one. Which of the following is not a dimorphic fungus? I think I've shouted out 1,000,000 times earlier that dimorphic fungus ka 2 questions have to come. Maybe they had only 1 this time, which is not. Not of these will be Cryptococcus, because that's a yeast. But all these others are dimorphic because there was a mnemonic, body heat probably changes shape. All of them are fitting into it. Cryptococcus does not. Moving on to the next one over here. So here you have a patient, this had to come guys, perianal pruritus. Remember the only life cycle that we study and the story that we've always studied about the male-female mating? Perianal pruritus with this kind of a D-shape egg that you have. I don't think anyone's getting this wrong. If enterobius was mentioned or if it was pinworm or threadworm, chalega, that all means the same. So that's pretty much the answer over here. I don't think you're messing up on this either. Coming on to the next question, where there has been a little bit of a controversy till now, but I'm still reading it out. I'll add on to it. There's a 28-year-old lactating mother coming to us with a painful lump. I mean, when lactating mother and painful lump comes, I do start thinking of Staph aureus. But when they say there is no fever, weight loss, night sweats, they are trying to rule out something. On examination, the lump is firm, irregular. Ultrasound shows hypoechoic lesion. Core needle biopsy over here shows a granulomatous inflammation with necrosis. So what have you answered over here? Most of you are now shifting your base towards Mycobacterium TB. So okay. One option was Corynebacterium minutissimum. Thank you for adding that. I will certainly add that in the final recall. So this is something where we are still a little doubtful about how this came. Although granuloma with necrosis goes well with MTB, but lactating mother and painful lump goes well with Staph aureus. So I think we can. TB was not there. So I think we'll give it another day. We'll gather more options and then we'll come back to this. We're not going to spend too much of time on this once this is not done. Second, this is another controversial question, probably not so controversial, but because we've not received the answers or the options. There's an immunocompromised patient, HIV/AIDS immunocompromised, presents with dysphagia or dinophagia, and there are white plaques that are seen over the esophagus. Microscopic examination, was there a photo given? Again, I do not know. If there would have been a photo given, I would have been able to tell you what exactly are they trying to ask you. I mean, individually we know the answers, but was there a picture given? So I don't know as of now, and I'm waiting for that No photo was given. Okay, so now in an immunocompromised individual, I will think of candida, especially when esophagus is what they've mentioned. Could be candidal esophagitis. If candidal esophagitis, I will think of yeast cells with pseudohyphae. Do you all agree with me on that? I think yes. Perfect. Great. We can move forward. I don't think such an easy question should have come, but why not? Most common HPV serotype associated with cervical carcinoma. When they say cervical cancer, it has to be high risk, so it has to be the big numbers, but the most common we'll go in for 16 and 18. Was there any twist and turn in this? I hope not. Okay, moving on to the next one. This is a question that came from PSM micro, wherever you want to fit it, as long as you know it. So when you're talking about louse, if you remember even one day before the videos that we were posting on Instagram telling you about the last minute topics to do, typhus fever was in them. And you have to get a question on one of these vectors, whether in PSM or in micro. So when we are talking about pox virus, that we know is molluscum contagiosum, then mite is going to transmit scrub typhus, and scrub typhus is caused by Orientia susugamushi. Sorry for the annotation which has gone wrong. Then tick is going to cause Rocky Mountain spotted fever, and then we have louse, which is going to go and cause epidemic typhus. So this is pretty much okay. You're saying pox was not there, right? And if you're saying endemic typhus was there, then the vector should have been a flea. So we'll work on it as long as you got it right. Chalo, if rat flea was there, then it should have been endemic typhus. I mean, there's no doubt about it. Moving on to the next question. This I would want you to tell me, what did you mark? You have a post-renal transplant patient, there's an infection. They are saying that which of the stain is least useful in identifying the organism. I cannot zoom in out here, but I hope you could see this kind of acute angle branching. I think this is aspergillus, 45-degree branching. Now the question is that they are talking about a fungus, least useful. Ideally, all can be used. As a pathologist, as a microbiologist, all can be used. Least useful, if I had to mark one, I would go in for Congo red. I mean, again, that is what you're asking Mason Fontana. See, I'm not using Mason Fontana either. I'm either using PASS or GMS most of the times. But over here, I was stuck in a situation. So now Mason Fontana can be used because what does it stain? Melanin, right? And there are some fungal organisms that do produce pigment. So maybe that can. Least useful asked over here, answer will be Congo red. Moving on to the next question. Which of the following is the most common? I think we're starting with pathology now. Which of the following is the most common inherited bleeding disorder? What did you mark on that? Because if you tell me the answer, it gives me break, because I think this is something which is very easy. Von Willebrand disease versus factor V deficiency is what everyone is marking. No, factor V deficiency happens. Okay, so A, fine, von Willebrand disease. I think that was of a previous one that we were getting a lag. This is a match the following that we have of the different genes and the different tumors. Now let me go by what I know, because these kind of questions do come. I hope you remember that 10-10-DEN thing. So P10, chromosome 10, Cowden syndrome, that is for thyroid cancer. STK11, although you study for Peutz-Jeghers, but in breast cancer, you know it also causes. BRCA2 mutation, yes, with prostate cancer. So which of them is incorrect will be TP53, because mucosal neuromas are very commonly seen with MEN syndromes, MEN2 syndrome. So I would not go for TP53 for mucosal neuroma. That is why answer C would be incorrect over here. Moving on. I think this is a repeat because this has come in path and micro both, which can be put up in even gynae and then later on in every subject. HPV serotypes most commonly causing cancer, we've discussed, that is 16 and 18, so no need to discuss that further. Okay, this is a question which I think Shanali ma'am will also be covering. A female patient presents with an adnexal mass and abdominal caking. Now when they talk about abdominal caking, probably a lot of mucin has gone on the peritoneal cavity. So I would go in for mucinous carcinoma of the ovary. Okay, a lot of you said serous. See, serous carcinoma of the ovary can spread, I mean no doubt about it. But when you're talking about abdominal caking, I would go more in favor of perfect. Most of you are giving the answer. Okay, if picture was there, sorry, that I have not received as of now, so I cannot comment on it, but give me some time. Multiple cysts. No, I think CA 125 that you're mentioning was a different question, guys. That was granulosa cell tumor, which I'll come to in a while. In that CA125 is not raised. That's totally different. Coming to the next, we have caspase 1. I hope you didn't read only caspase and didn't mark apoptosis, because caspase 1 particularly is going to be elevated in pyroptosis. So yes, so the annotations are not going with us, but nonetheless, also this smart board has made me right-handed for the day, but chalega. Okay, anyway, moving on to the next one is this. Also gets me back to my ambidextrous skills, which I had once upon a time when I was under 10 years of age. But anyway, coming back to this is the last question that we have. Based on the image given below, which of the following is most likely? I have come to know that the question was not framed this way. But what I can tell you right now is that this is the coffee bean appearance, and this coffee bean appearance is seen in granulosa cell tumor. So on the basis of that, they were talking about a sex cord stromal tumor, which does not show you elevated CA125. What it does show you is going to be inhibin. It is inhibin positive. But okay. ये question नहीं था. I agree with you, Dr. Akash. This was not the framing of the question. It was multiple correct, which means that either you had it's a sex cord stromal tumor, it is inhibin positive, it is not CA125 elevated, it is going to show you Cole-Exner bodies. But by the time I got those options, we were already live. So I had to project it this way, but I've understood. You're saying, why is this not Brenner's? That's a very good question, because yes, this can be. But students told me that all the other options were going in favor of Cole-Exner and granulosa. I think it is granulosa, but still we'll work on it. Diabetic retinopathy. Retinopathy, I think ophthalme deal hoga. That is something I don't want to, get into. Okay, there were two questions with CA125. Okay, we'll work on this. I mean, this is a very preliminary thing, guys. Right now, I have no idea what is exactly happening with the real options, but I will work on it. And 19th, that is Monday, we have another session. And on Monday, we will go through a proper recall. Of course, till then, I'll be in touch with you over Telegram and social media, because I'll be gathering a lot of options from you, but you also have a Google Sheet on which you can put it up, and I will definitely, put it across to you. So anything else before we move on to the next subject, which is pharmacology, where Ankit sir is going to help you with all the questions. There was a question on herpes. If you have seen it, there have been vesicles. So I think Ankit sir will talk more about acyclovir and how herpes can be treated. So that was another micro-pharma correlation. Okay, Google Sheet will be there in the link in the pin and in the description, so you can fill it up. Inhibin was there, perfect. I'll include.
Hello guys, I feel now you are a bit relaxed, and again I would like to say the INI CET people have lived up to their reputation. The paper was moderate to difficult, but again what we have seen is no new question or a new topic has come. The topics were previous, but they have again asked in a great depth. So let's talk about the recall of pharma. So the first question which students have told me is that which of the following statement regarding thalidomide is incorrect? So remember thalidomide, just a moment. Yeah. So thalidomide, remember it is not an anti-metabolite. Anti-metabolite drugs, remember we have discussed were methotrexate, 5-fluorouracil. Rest every other statement is true, we have already discussed. So go with the correct answer of B, C and D. So thalidomide is not an anti-metabolite. Anti-metabolite we have discussed in cancer chapter like methotrexate. So let's move on to the next question. So which of the following statement regarding bempedoic acid is correct? Remember bempedoic acid, a newly approved drug 3 years back. We have written in the last part of the hypolipidemic chapter. So bempedoic acid, it is a citrate lyase inhibitor, absolutely true. It is given with statin to reduce cholesterol level. Yes, it reduces cholesterol synthesis, but we have written in notes, it is not a non-competitive inhibitor. Remember, it's a competitive inhibitor. So if you'll go with the best answer, even if we don't know, what about the third statement, some dicarboxylic, even if we don't know, we can correctly mark the answer as B, C and D. So again, the answer should be B, C and D. It's an inhibitor of ATP citrate lyase, but remember it's a competitive inhibitor, okay? A new hypolipidemic drug which got approved. So any modification, if you students see that probably it's a very active recall. These recalled were done within just 2 to 2.5 hours. So there might be some language change or spelling mistake or some improper statement. So I need your help to contribute for your fellow students in future. So which of the following respond to schedules of the drugs and their cosmetic role? We have very well discussed. So schedule X, I have told you X is always addictive. So can you tell me which is an addictive drug? I think morphine is an addictive drug. Schedule G means which are given under medical supervision. So yes, all vaccines are given under medical supervision. While H are prescription drug. So yes, you will go to the chemist. Chemist will always give you insulin after prescription. So what is left is veterinary drug, Z. So H, so we can go with the correct answer that insulin is H, 1, veterinary is 2. So go with the option number B. I hope the option number B is correct. So bempedoic acid, Shagun, it is a drug to reduce cholesterol level. So we discussed that statins, they reduce HMG-CoA reductase enzyme, which is the rate limiting step in cholesterol synthesis. Before that step of HMG-CoA reductase, there is an enzyme ATP citrate lies in liver. Bempedoic acid inhibit that enzyme, one enzyme before where statins act. Okay. So what is the treatment of choice for complicated gonorrhea caused by penicillin resistant Neisseria gonorrhea? So gonorrhea always the drug of choice is ceftriaxone, which is given along with azithromycin. Okay. So amoxicillin tetra and vanco is never effective against gonorrhea. Okay. So the answer here is ceftriaxone. Let's come to the next question. What is the most appropriate for a patient with complicated urinary tract infection presenting with septic shock? Although it's a question of medicine, Marva sir will also be discussing. But remember, UTI, most of the time it is gram-negative organism. Septic shock, the very commonly caused organism is hospital-acquired bacterial infection like Pseudomonas, Klebsiella. Agreed? Which can lead to all these conditions, and among them only one drug is effective against Pseudomonas and Klebsiella, the drug of last resort, that is carbapenem or meropenem. Okay, so meropenem is always a very famous question, so we have discussed in our notes as well. Let's move on to the next question. So which of the following anti-malarial is a commonly used in clinical treatment or clinical cure? It's a question straight from LRR. So we made a beautiful diagram of malaria or various stages. So remember, artemisinin, sulfadoxine, they are given for clinical cure in P. falciparum, while chloroquine is given for clinical cure in P. vivax and ovale. While primaquine is the only drug which is only not effective in which stage of malaria? That is erythrocytic schizogony, which is the clinical cure stage. So the answer here is primaquine. So A, B, C, they are given in clinical cure. So go with the option number A, B, C. Okay. So next question is, a patient develops ataxia. So we all know ataxia occurs because of cerebellar damage, and very well we know carbamazepine causes cerebellar damage, which can lead to cerebellar neurotoxicity like ataxia, diplopia, slurred speech. So what should be the answer? And erythromycin is given. Erythromycin is given to confuse you. Okay. So what is the cause of this ataxia? The answer should be carbamazepine toxicity. Erythromycin is given to confuse you in this question. So ignore erythromycin like you have ignored your ABC, XYZ during your exam. So what is the mechanism of action of phenoldapam? We have discussed a straight one-liner question. So phenoldapam, DA means it is a dopamine 1 receptor agonist which causes vasodilation and increases blood flow to the kidney. That is why it is given for treatment of oliguria during hypertensive crisis. Go with the option number A, phenoldapam, DA word, dopamine wala. A straight away question. I hope everyone has marked. Great. So I'm getting very funny comments. That's great. I think you're a bit relaxed. Your tension level has reduced. That's very good to see. So which of the following are appropriate for scabies in infant? So we discussed the only oral drug in scabies was ivermectin, and ivermectin is contraindicated in pregnancy and children less than 5 years of age. So can we say in infant or children we can apply topical drugs? So what are the topical cream? Apply logic. Okay, so the only drug which is contraindicated should be ivermectin. It is a highly teratogenic drug. Don't give in children less than 5 years of age. So ABD is coming in option number B. Agreed? So that's great. So there was one option of only one A and B. So if there is an option of A and B, but the options were same. See, the overall drug of choice, beta, the overall drug of choice is always permethrin, okay? Whether it is pregnancy, whether it is children, whether there is no other problem, everywhere the drug of choice is permethrin. The only oral drug is ivermectin. Other drugs can be given, but they are avoided in pregnancy, okay? So some students are saying only A and D are in the option, some are saying A, B and D are in the option. So right now we will go with A, B and D, okay. So day after tomorrow again we will be having an active recall where we will discuss all these questions in a very correct manner also. So which of the following are involved in calculating loading dose? Again a straight away question, loading, D word is coming, go with volume of distribution multiplied by target concentration. So this is a formula of IV loading dose, but suppose you are giving a drug by any other route, let's say oral route, which factor you have to take into consideration? That is systemic bioavailability. So go with the answer A, B, C. So even you can see only A and B are not given in any other option. So let's go with the best answer. Possible answer is A, B and C. Fine? Great. So I hope this was an easy one and all of you students have marked it correct. Let's go to the next question. Which of the following drug is known to cause cholestasis without portal inflammation? So cholestatic jaundice we have discussed was an absolute contraindication of using oral contraceptive pills or hormone replacement therapy. Both of them, they contain steroidal molecules like estrogen and androgens. So go with the answer estrogen and androgen was the correct answer. Okay. But all other drugs, remember, they produce more of an inflammatory pattern, hepatitis type of a pattern. So cholestatic pattern, estrogen and androgens. Next question is, which of the following is new psychoactive drug which works as rapidly acting antidepressant? So we discussed ketamine. Here ketamine is given in the option. So I would say it is not a perfect, it was not a perfect answer, because ketamine is not approved for acute attack of depression, it is rather S-ketamine. So we discussed S-ketamine, which is available as a nasal spray, for acute treatment of depression. It was a new drug, recently got approved some 2-3 years back. So go with the answer ketamine. No beta, cannabinoids are not approved for depression, they are rather approved for epilepsy, they are approved for anti-emetic drug and they are given to promote weight gain. Cannabinoids are right now not approved for depression. Last year INI CET question was that cannabinoids, they are approved in which type of epilepsy. This was a previous year INI CET question, but here the question is about antidepressant. Antidepressant is ketamine. Okay, antidepressant is ketamine. Okay. If ketamine is not given, but students, what I have gone with recall is that ketamine was given in the option. If ketamine is not given in the option, yes, Roshanji is saying that ketamine was in the option, then go with ketamine. So I know there is a lot of stress and anxiety, sometimes we are not able to recall them properly, but don't worry, we will be having a very proper recall session. So this is a session where we can just see what was the correct answer in a very rapid way. So all of the following are the clinical uses of magnesium sulfate. So this is mainly a question of obs and gynae, which I have enroshed intentionally or non-intentionally, but let's see what is the correct answer. Magnesium sulfate improves blood flow to the kidney. Yes. Renal blood flow. Yes. It has a vasodilatory action. It has a neuroprotective effect. Yes. It is given in preeclampsia and eclampsia scissor. Yes. It decreases the incidence of abruptio or placental abruption. I think this is the incorrect answer, but obs gynae people will tell you in a better way because they deal more with abruptions. And so let's go to the next question. Which of the following drug is used to reverse the effect of weak uronium? So weak uronium, curare wale drugs are always skeletal muscle relaxant, and the antidote is neostigmine. Another drug which was asked previous year was Sugamadex, but this time Sugamadex is not given. Remember, atropine can also be an option, but atropine does not reverse the effect. Atropine reduces the adverse effect produced by neostigmine. So for reversal you give neostigmine. Neostigmine produce its own adverse effect. For that you give atropine. So don't go with atropine, go with the correct answer, neostigmine. So now let's talk about what is the drug interaction between imipramine, which is a tricyclic antidepressant, and diphenhydramine, which is an antihistaminic drug. So we have discussed that antihistaminic and tricyclic antidepressant, they both have anticholinergic action. So they both block muscarinic receptor, they both have atropine-like side effect. Go with the correct answer, option number 1. Next question is, erythropoietin is used in which type of anemia? Remember, in aplastic anemia, we don't give erythropoietin because already the bone marrow cells are not responding, EPO levels are very high. Nutritional anemia, again, because erythropoietin level is already very high in the body. So we discussed that erythropoietin is given in CKD. Why CKD? Kidney is not producing erythropoietin, there will be deficiency. Now this is a very controversial statement which is there. Can we give erythropoietin in myeloproliferative neoplasm? In certain myeloproliferative neoplasm, when the level of erythropoietin is less, yes, you can give. But most of them we don't give. So here we will go with the option, in certain cancer patient we can give erythropoietin to increase or to improve anemia. So go with the correct answer, C. But C is the definitive indication of using, that is erythropoietin. Okay. So it was myelofibrosis. If myelofibrosis is given, then go with only option number C. If only myelofibrosis is given. Because in myelofibrosis, again, the bone marrow is not responding, erythropoietin level will be high. If myelofibrosis is given, yes, then go with the only answer, I would say, anemia due to CKD. So now let's talk about a young boy presented with platelet count of 10,000, which is very low. A bone marrow aspirate reveals normal cellularity, increased number of megakaryocyte. The most appropriate initial treatment for this condition, yes, I think it's a picture of ITP. So ITP, autoimmune disease, go with intravenous immunoglobulin, although steroid should be started first. So I think this question will be discussed in medicine also, because pharma has lot of integration with medicine. So now let's talk about the last question. Which of the following are recognized as a side effect of topical corticosteroid? Again, it will be taken in derma. So the first, hypertrichosis, acneiform eruption and skin atrophy are very well noted side effect of topical or skin application of corticosteroid. So I think you should go with option number A. So this is all about pharma recall. So for the moment, relax, don't worry, we will be coming with the proper one, the proper recall. As we get a little bit of time, we will interact with more students, we will connect with more students, and we will have a proper authentic recall. So before I'll call the next faculty, remember there are a lot of giveaways for the student who are participating and giving us the maximum number of recall, and the student who are interested in version X Elite plan, there is a special 15% discount. You can opt for, you can use a code INI CET 15%. Thank you very much. Best wishes. Relax for the moment now, because this INI CET will help you to prepare for your next upcoming exam, that is NEET PG exam. So don't worry, relax. Best wishes.
A very big hello to all my dear students. So how was the exam? What about ophthalmology? Whatever recall questions that I have got, I think if I want to comment on it, I would say it was simple and smart. If you had really attended the lectures, the LRR series, it was 100% strike rate, isn't it? Okay, let's discuss. So I am not going to discuss in detail. Here I know nobody is in a mood to study. We just will have a quick look at the questions that has been asked in your exams, right? And the detailed recall, as already mentioned by earlier faculty, we will be doing it later on 19th and 20th. Okay, so let's start. So this was, I think, a very important, this was a PYQ, so many times discussed in the class. The image was given, we know at the baseline both the eyes were in primary position. When there is right-sided gaze, everything was fine. On the left-sided gaze, what did you see? No adduction on the right eye and the abducting eye is showing nystagmus. So was this the image here? And if yes, then what would you answer? Very quick here, of course we know internuclear ophthalmoplegia. So which side MLF lesion? We all know this is your, wherever there is no adduction. That would be the side of MLF lesion. So it has to be right MLF lesion in this image if this was the question asked, right? Okay, we come to the next one. Okay, so which of the following is not a treatment option? So this was little smart question. We had to go back to our concepts here. So which of the following is not a treatment option for amblyopia? So when you talk about amblyopia, I hope we all know what is amblyopia, isn't it? And what is the mainstay of treatment you have learned? It was occlusion, but look at this one. It is saying not a treatment. Let's take one by one. So, you know, there's one surprise always there in the INI CET exam. I think this was the one. So, we all should know video games are the new modality of treatment for amblyopia. So, actually this is correct. Patching you all know is correct. Now, there is a confusion. What about refraction and strabismus surgery? If it is a strabismic amblyopia, of course, you would want to quickly correct the strabismus. Refraction, it is only after refraction that you diagnose an amblyopia, isn't it? When you are doing a refraction and you see that the patient's vision is not coming 6 by 6, then only we mention it's an amblyopia. It is not a treatment, isn't it? So I think here we have to answer refraction. Right, guys? Okay, we come to the next one. This was a simple, I think there's a clash between anatomy question or an ophtha question. We were asking you the sensory supply of the orbit, and very obvious we are going to answer trigeminal, isn't it? Okay, we come to the next one. Which of the following best defines blindness? Now, I was discussing with Dr. Neha about this. We are getting two types of recall. Is it according to WHO classification or is according to NPCB? What do you say? What was the question? Can you all tell me? Was it according to WHO or according to NPCB? Okay, if you feel it's a wrong recall, we will again come back to you. Please send the questions. We are going to discuss as per you all say, okay? So this purpose of the session here is not for a detailed discussion. Wrong question, it was a WHO? Okay. So if it was a WHO, it becomes a very simple question here. According to WHO, we know it is the best corrected vision of in the better eye of less than 3 by 60. But let me also tell you, if it was NPCB, then we would not, because in NPCB it says it is best available correction, isn't it? In that case, the field criteria has to be marked. So it's up, you all have to decide which one is the correct option, right? What were the options given and whether the question was according to WHO or NPCB, isn't it? Yeah. Okay, was it an LR palsy image? Yes. Let's see the next one. In keratoplasty, so commonly used corneal storage medium and suture material. Was this the question? Tell me. I'm waiting. Yes, yes. So, yeah, very good. Yes, in this case, we all know we are using 10-0 nylon. And was there any timing also given in the question that, because storage media are all we are going to answer according to whether we have a short-term storage, intermediate or long-term storage. So was there any timing given that, okay, the keratoplasty has to be done in so many days or so? So just look into that as well. But of course, if these were the options and nylon was only in one option, then of course this is the answer, MK media. If this is the format, this is the answer, right? Yeah. Okay. Okay, okay. Polyethylene glycol was there, but again, we will have to see that both options should be correct. And please let me know if the time of surgery was mentioned or not. Say that when is the keratoplasty planned and for how long we have to store. That is very important. Okay? Okay, we come to the next one here. Yeah. So, let's look at this question. Which investigation? I think again it was a very, very simple question. Which investigation is used for visualizing the individual layers of the retina? Batao? I think this is very, very obvious. We will mark optical coherence tomography. In OCT, we can delineate the different layers of the retina. We have seen the findings in OCT, in CME, CSR, ARMD. We have discussed so much in the class, isn't it? Yeah, very good. Nice. So, we total had, this one is the, I think this one is the, next question is, yeah, total we had 7 questions. If you all can recall more, you can send. So, a patient is presenting with decreased vision 2 weeks after undergoing a cataract surgery. So, on examination, signs suggest delayed onset endophthalmitis, such a predictable question. We have learnt it for so many times, revised it so many times. So, late onset endophthalmitis, of course, is propionobacterium acne, isn't it? And what is the second option? It can be fungal, but here we will answer propionobacterium acne. Okay. Even then, if it is a late onset, we will not answer staph, no? We will answer propionobacterium. Okay. Right. So, anything different that you are able to recall, you can please connect and please message me these questions. Just share the questions. We are going to discuss more in detail in your further recall session. Right? Okay, shall we end it? Yeah. So, that's it. Thank you so much. Stay blessed and keep smiling.
So hello dear students, welcome back, and now we're going to have a quick recall of the PSM questions. Now to be a little this thing, you know, I know that the exam has just got over, so we are just going to have an overview of the PSM questions. Looking at the questions that I received from all of you, the questions are not, I would not say very difficult, but yeah, they were moderate. The options were tricky, and 1 or 2 questions we did have that always, you know, are sometimes a bouncer. So we'll discuss all of that. However, the elaborate session for PSM recall will happen on Monday. And before I start discussing, please remember about the giveaways, guys, that we are having. So do stick with this session and you get an amazing opportunity to win a lot of giveaways. Okay? Chalo, so let us start moving to the first MCQ that I received from all of you. Now there couldn't have been a more beautiful question than this one. Just have a look at this question, guys. The RMN-CH+A strategy by the Ministry of Health and Family Welfare, Government of India, aims to provide comprehensive health care across various life stages. Which of the following population groups is not a target of RMN-CH+A strategy? Now, I'm not very sure was it RMN-CH+A, because now, you know, this is now RMN-CH+A plus N. I hope you remember we have added an additional component to this, which is nutrition, right? So R stands for reproductive, M stands for maternal, N stands for neonatal, C stands for child health, okay, A stands for adolescent health. So RMN-CAH plus N. So what was the component that you did not get over here? Infant, of course, will come under child health. Family planning, of course, does come over here. Geriatric population is not included in this one. So the answer to the first one, I hope you all got it correct, is geriatric. Okay? All right, moving ahead to the next question, guys. So the next question is, let's see what it was. Okay, now as Ruchi ma'am just discussed, we did get a question on the definition of blindness. Now we are not very sure whether it was WHO criteria or was it according to the National Program for Prevention of Control of Blindness and Visual Impairment. Okay, so over here the correct answer would be, here it is written according to WHO. So WHO ke according, you all know, visual acuity less than 3/60, all right, visual acuity less than 3/60 in better eye. Okay, so over here if you have to go for it, best corrected vision, all right, visual acuity less than 3/60 and better eye, all right, with best possible correction. If it was according to the program, it would have been with available correction. Okay, all right, moving to the next question, guys. So let's go to the next question. All right, if it was MPCB, don't worry, I will write it over here. So if it was according to, we will have a detailed discussion. So if it was according to National Program for Control of Blindness and Visual Impairment, it is always visual acuity less than 3/60 in better eye with available correction, not best possible correction. Okay, it will be better eye with available correction, sorry for that, but the answer to this one right now is according to WHO, best possible correction. All right, okay, now is the question visible? Can we go to the next one, guys? So the next question was, now again, it is INI CET, we would be expecting biostats in the exam, okay? We would be expecting biostats in the exam. So over here at a PHC, a medical officer provides treatment and counseling to a diabetic patients. Their body weights are recorded before the intervention and again 6 months later using the health register. Which of the following statistical tests is most appropriate to analyze the change in weight in this group? Now for questions like this, which are based on test of statistical significance, guys, you knew the approach that we have discussed in our LRR also. What is the word over here? Weight. Now is weight a quantitative or qualitative term? We all know weight is a quantitative variable. Weight is a quantitative variable. What do I mean by quantitative? It can be measured, it has a unit, right? So when you have a quantitative variable, you will be using a parametric test. You will be using a parametric test. Now over here, look at the options. Chi-square is a non-parametric test. It was out of the box. Now these three, out of this, which one would you select? So you have to look at one group, two groups, or more than two groups. So here it was clearly written, the body weights are recorded before the intervention and again 6 months later. So in a single group, you are checking for weight before and after intervention. So what is your answer over here? Single group before and after intervention. So your answer is paired t-test. Were you able to do this, everybody? Were you able to do this? Okay. Arpita, don't worry, I will be discussing this in detail when we have a detailed recall. Just have a look at the question, relax it with a cup of coffee and just keep going through this. All right, so this was paired t-test. Let's move to the next question, guys. So a couple of questions have turned up from PSM this time, and biostats is one of INI CET's favorite that I've always been stressing. Now look at this. Tell me honestly, how many of you found this question difficult? Guys, look at this question. It was not difficult. Why? Because they asked you to mark the incorrect option. And when you look at this question, you see an option where it is clearly written. Forget about all the other options. Just look at one of the options. Mean and median. Dispersion. No. What are mean and median? Mean and median are measures of central tendency. Even if you were getting confused about option A, B, D, forget about all those, you know that mean and median are measures of what, everybody? Mean and median are measures of central tendency. What are the measures of dispersion? The measures of dispersion are standard deviation, standard errors, variance, coefficient of variation. Yes? Acha tha ye question, good tha, I am sure everybody marked it. Just to tell you, standard error is variability. The other term for variability, guys, is dispersion. Okay, so you don't have to worry. This is correct. Correlation coefficient, you know, it tells us the relationship between two variables and the direction of association. Now, you might have got confused in the term moments. So, moments is a term to denote skewness. It's correct. It's a new term for you. But you could still have got the answer from that. Mean and median are measures of central tendency, not dispersion. Okay? Okay, let's go to the next MCQ. Alright, so again, INI CET, A numerical is expected. These days numericals are turning up in NEET PG also, in FMG exam also. So now both the exams are coming up. We have to be ready with the numericals. Look at this question. Did you all try this question? What is written? In a village of 100 children, 10 children have a past history of measles. Now I'm not saying that we've got the exact replica of the question, but we're trying to get near to the question. So you know there's a total population of 100 children, okay? 10 children have a past history of measles. That means they have suffered from measles. 20 new cases of measles were reported this year. New cases. New cases is incidence, right? Now you had to find out about the incidence of measles. Now guys, जब भी epidemiology पढ़ते हैं, whenever we study epid, we do this, incidence and prevalence. All of you know incidence is number of new cases. Prevalence is existing cases, alright? In prevalence you have new plus old. So in incidence you have the total number of new cases. What is the denominator guys? The denominator is the total population at risk. The total population at risk. The total population at risk. Who is at risk? The total population at risk. Now just to be clear, here there are 100 children, out of them 10 have suffered measles. So now how many are at risk? It is not 100, it is 100 minus 10. And how many are new cases? 20 divided by 90. Now ideally when you ask incidence, the multiplier should be 1000, okay? But since the student sent us, it was in percentage, so we will multiply with 100 and that gives us the answer 22.22%. Did you, I hope you did not forget to, you know, subtract 10 from 100 because they were past cases. Alright, so this is what is incidence. Moving to the next question, anybody has any queries, doubts, please keep it for Monday, we will discuss it. And if you get another way the question was asked, do drop in, we will make the required changes, alright. But don't worry, just have a look at this. Now this again is expected entomology, one of the favorite topics. So we all know Laos पूछते हैं, Laos PERT was the pneumonic epidemic typhus, right? Rickettsia, obviously Rocky Mountain spotted fever. The rickettsial disease ka table is very important for last minute revision with NEET PG FMG coming up. Don't forget to revise rickettsial diseases. Mite, you all know, is trombiculid mite is scrub typhus transmitting rickettsia aurantia shutshugamushi. Pox virus molluscum contagiosum. So what was the answer over here? 1A, 2 ka B, okay, 3 ka C and 4 ka D. In case we had this question, then this was it. Okay? Alright, so let's move to the next MCQ. Was this a question guys? I'm sure vaccines was meant to be asked. Contraindication. Which of the following vaccines is contraindicated in a child with immunodeficiency? Which vaccines do we contraindicate? Which one do we not give? We don't give the live vaccines. So you had to figure out which was the SCID. Okay, let's write that, no problem. Okay, so you just had to figure out which was the live vaccines. Hepatitis B recombinant, you can give it. DBT, you can give it. IPV is a killed polio vaccine, not a live one. OPV is a live one. So what is your answer over here? MMR. Everyone should have got this question correct, I'm sure. Everyone should have got this question correct. Okay, live vaccines are contraindicated. Let's move to the next one, guys. The next one is, did we have this question? We received it at the last moment. So yesterday, before the class, I had shared a post on the diseases that are transmitted at different trimesters. If you check out, first trimester, second and third trimester, exactly the same question got replicated. Rubella is in the first trimester, parvovirus B19 in the second trimester, toxo is our answer over here, third trimester, herpes, of course, more chances during delivery. Okay? चलो ये नहीं था तो कोई बात नहीं, skip कर देते, था तो अच्छी बात है. Alright, now again, dependency ratio. Dependency ratio is now become the Bible of demography. What do I mean by Bible? Whatever exam you are appearing for, NEET, PG, FMG, INI CET, you will get a question on dependency ratio. Now I know many of you messaged me कि ma'am, हम लोग बोलते हैं, we say children below 14 years, right? According to your definition, and elderly beyond 65 years. That's the definition. I am absolutely okay with that. Elderly beyond 65 are dependent on 15 to 64 years. We know this is the definition, right? Now over here 0 to 14 कोई problem नहीं था, 6,000 was given. 15 to 59 दिया हुआ था. Guys, in many countries 60 years can be taken as a cutoff for elderlies, okay? In India also we consider 60 years as an elderly. So don't get into too much this thing over here. 60 years and above was 2,000, and over here we'll just take 15 to this one, 12,000 if this was the question. If this was 65 years, no problem at all. Any which ways your answer would come out to be 0.66. Okay? Okay. Moving to the next one. Sorry, ये तो answer है. What was this? Now this was a bouncer question, but you could still have tried to guess over here. Question was primarily the act primarily concerned with protection of personal medical data and privacy in India. Now MTP Act पता नहीं ऑप्शन में था कि नहीं. It is not. PNDT of course is not the answer. HIPAA is an act which is followed in US. The answer to this is DPDP Act. Okay, now let me just show you the slide. It is nothing but Digital Personal Data Protection Act, which keeps all your came into existence 2023. It keeps all your personalized data safe, but at the same time it can be used for legal this thing. All right, and this was improvised again in 2025. ठीक है. GDRP भी था, तो I don't think वो आंसर है. तुक्का लगा है तो ठीक है, सही बात है. DP Act is the one which is the correct answer. All right, just a couple of more questions now. This is kind of a PYQ which has been replicated. The categories of high risk for HIV. We all know MSM, men having sex with men. They won't give you the full forms, guys. We've just written it out for you. Commercial sex workers, of course, they are high risk groups. Intravenous drug users, yes, they are the core groups. When I mean by high risk groups, core groups. What are truck drivers and migrants? They are the bridge populations. They are not the core groups. So if you have to mark from this, and one more is the high risk group, which is the transgenders. So there are 4 high risk groups. Over here the correct answer was truck drivers. I hope you got this correct, everybody. Okay. Biostat बहुत आया है इस time, which we expect in EPID again, but not very difficult, I would say. In a hospital, patients are classified into 3 groups based on disease severity: mild, moderate, severe. One patient is randomly selected from each group for a study. Now, there was your buzzword lying then and there in front of your eyes, 3 groups. We have stratified them into 3 different groups, selecting the people from there. Stratified random sampling. ठीक है? चलो. Okay, and all right, statistics. What do centiles and quartiles measure? Guys, if you open your lecture, we've discussed a very small portion. Measures of position are quartiles and centiles and deciles, okay? They are all measures of, position, which divide your data into equal part. आपको पता है central tendency, mean, median, mode. That's not the answer. Dispersion is again standard deviation, standard error. Correlation is correlation coefficient. The correct answer to this was position. Okay, any more questions? Yeah, this OBG may be discussed hoga. MTP Act, 2 doctors, 20 to 24 weeks. A Bible question, a Bible topic, MTP Act. Last question of the day, look at this. During the Mahakumbh Mela, mobile health units and medical bases were set up along with multiple surveillance units for monitoring cases of fever, diarrhea, respiratory illnesses. What was the primary purpose of setting up the surveillance unit? So, jitne bhi bade events hote hain, we always have a surveillance unit. Now, what is it? Is it the need for medical professionals? They're not getting jobs, so we are setting up surveillance unit? No. Is it for immediate quarantine? No, we can't do that. Is it to provide curative treatment? No. What are we trying to do? Early diagnosis and detect potential outbreak warning signs. Buzzword tha yahan pe. What was the buzzword? Surveillance. We have to immediately go and find the cases and report it. Okay guys, so I hope you were able to do PSM. I would again say was not very tough, guys, but it was a pretty moderate paper. Matlab acha tha PSM, not that. But before I take a leave, please remember we have amazing giveaways. So do stay with us through the end and win an opportunity to get the amazing giveaways. Also, you can use the code INI CET 15 to get an exclusive offer for 6 months and 12 months on our elite plan. And do join us again for the detailed recall session. I hope you enjoyed.
A very good afternoon all of you, and welcome back to this recall session. So till now we have discussed so many subjects and I'm sure you have been able to perform to the best of your potential in this exam. So now we will be quickly going over the topics that were asked in pediatrics. So as you know, a detailed recall session will again be held for all the subjects. So we will be keeping it brief and simple. So we will be seeing what all topics have been asked in pediatrics this time. So overall, you know, there were clinical case scenarios and there were some previously asked topics were repeated like as is expected. Some of the questions though were a little bit out of box. So let us see what all we have been able to gather till now, and I would ask all of you to contribute as many questions, as many options. Apart from this also, if you can recall, it will be a great help and you can win so many goodies. So let's start. So the first question that we have here is a newborn baby delivered at 36 weeks of gestation. So 36 weeks gestation means the baby was born preterm, right? So a preterm baby was brought to the OPD with complaints of shortness of breath. So preterm baby with respiratory distress, the first thing that should come in our mind is respiratory distress syndrome or hyaline membrane disease, which is due to the deficiency of surfactant. And what more, this question also gave us an X-ray picture. We all know in respiratory distress syndrome, due to the deficiency of surfactant, there is ground glass haziness of lungs. Look at the, can you appreciate the ground glass haziness of the lungs? The lungs, instead of appearing black, are appearing grayish here. So no doubt about the diagnosis here. Our most probable diagnosis is A, respiratory distress syndrome, also known as hyaline membrane disease. We will not be considering transient tachypnea of newborn, where you know the X-ray is grossly normal or you can get features of fluid overload. Meconium aspiration syndrome, again we don't have a history of meconium stain liquor here. Neonatal pneumonia of course might have other features of sepsis can be there like hypothermia, poor feeding, and on investigation you can get features suggestive of infection. So we are sorted here, respiratory distress syndrome, a clear-cut case scenario and an often repeated question. So moving on to the next one. Which of the following statements regarding breastfeeding technique is or are incorrect? Okay. So please read the question very, very carefully whether it is asking correct or incorrect. Again, a very, very basic topic asked n number of times in various exams. So breastfeeding, the technique is very, very important. Very simple, very scoring and very important. So which of the following are incorrect? So the infant's lower lip should be inverted during latching. So should the infant's lower lip be inverted? No, it should be everted or turned out. So it is incorrect. The infant's cheek should appear full during effective suckling. Yes, if the baby is able to suckle properly and hold the milk in the cheeks will appear full during suckling. That is correct. A greater portion of areola should be covered above the breast than below. So we know the entire areola should be in baby's mouth except a small upper part. So a greater portion should be covered above is incorrect, right? The infant's chin should make contact with the breast during feeding. Yes, we know chin touching mother's breast is one of the signs of good attachment while breastfeeding. So this is correct. So the incorrect options about the breastfeeding technique are A and C, which is there in option A here. So here you have to combine various options to come to your answer, right? A very, very basic, often repeated question. So next, so this was a little bit out of box. So this question here guys is about lupus nephritis, okay, in children. So what we have here is a 12-year-old child who is diagnosed with systemic lupus erythematosus and presents with nephrotic range proteinuria, right? Renal biopsy is revealing wire loop lesions. So we know these wire loop lesions can be seen in stages 3, 4 as well as 5, but typically associated with stage 4 of lupus nephritis, and this condition has got a very poor prognosis. So what we would want is we would want to give aggressive treatment, okay, to prevent or to manage the child going into rapidly progressive glomerulonephritis, AKI, and eventually into CKD. So we would like to give a very, very aggressive treatment. So IV steroids only might not suffice, but IV steroid along with cyclophosphamide pulses is what we would prefer. Again, MMF and cyclophosphamide only might not suffice. As we said, it is an aggressive disease. So right, was this the question? Yes. So please keep on commenting whether this option, whether any other options do you remember or any other details that were mentioned in the question. That will help us analyze the question better. Now next question, a 6-week-old infant presents with a history of Non-bilious, non-projectile. So mind you, what we have been able to gather till now is the students are telling it was non-bilious, non-projectile vomiting. Because you know, if projectile vomiting is there, the scenario totally changes, right? So projectile vomiting, non-bilious projectile vomiting, so many times we've got a question where you know the diagnosis is congenital hypertrophic pyloric stenosis. But here what is mentioned is non-bilious and non-projectile vomiting starting at 3 weeks of age. The infant's abdominal examination is normal, so you do not get any lump, no visible peristalsis, so we are not probably dealing with hypertrophic pyloric stenosis this time, right? So which of the following is the most likely diagnosis? So pyloric stenosis does not appear to be the case. Gastroesophageal reflux disease could be a possibility. So you know the babies normally have a lot of regurgitation of feeds you know, during the infancy, especially the early part, and if it becomes problematic, if it causes respiratory symptoms or failure to thrive, baby is not gaining weight, it becomes the disease. So this remains a possibility. For cow milk protein allergy, we would need some more information on the question. We are not sure whether you know a history of feeding cow milk was there or not, any other manifestations were mentioned. So this question can, you know, we can improvise on this question based on your inputs, so that we can come with a better version when we do the detailed discussion once again, right? So this would remain a question mark. Intestinal obstruction does not seem to be the case because the baby does not have any features like, you know, abdominal distension, bilious, vomiting, right, constipation and so on. So as per the given information that we have currently, gastroesophageal reflux disease appears to be the most reasonable choice. But of course, having said that, the choices would vary depending on what exact question was. Moving ahead, a straightforward question. So this is so many times repeated previously. So a 3-year-old child is brought to the clinic, so with history of cyanosis since infancy. So cyanosis since infancy, we are dealing with probably a congenital cyanotic heart disease. Which of the following is a component of tetralogy of Fallot? So the question is straight away asking you about what are the components of tetralogy of Fallot. So is interatrial septal defect a component of tetralogy of Fallot? No, right? We know a large ventricular septal defect is there instead. Atrial septal defect as such is not a part of tetralogy of Fallot, but it is a component of pentalogy of Fallot. In fundibular pulmonary stenosis, yes, that is very much a component of tetralogy of Fallot, and because of the right ventricular outflow tract obstruction, we have cyanosis, the murmur and the various features. Left ventricular hypertrophy is not seen, we get right ventricular hypertrophy, and transposition of great arteries is a different disease altogether. So this question was a cakewalk. I am sure all of you have done it correctly, right? Okay. So moving ahead, we have a 9-month-old infant. So a 9-month-old infant who is brought to the pediatrician due to the concerns that the child cannot sit without support. So we know sitting with support. So we know sitting with support usually comes at around 6 months of age. Sitting without support usually comes at around 8 months of age, right? But 9-month-old, so in some babies it can appear around 9 months also. So a 9-month-old is, you know, not able to sit without support, might ring some bells, but the child is otherwise able to roll over, says mama, dada, and, you know, demonstrates stranger anxiety. So the other domain milestones, like, you know, speaking bisyllables comes at 9 months of age, and which is up to the mark here. So which of the following is the most appropriate next step in management? So most appropriate next step in management is the question. The options that we've been able to gather till now are, so the options are refer for developmental assessment, okay. So it is not a bad idea to get developmental assessment done whenever you are in doubt, okay, because that is a non-invasive thing. You can do it easily. Order an immediate MRI, no, for God's sake. So here we are, you know, doubtful. The child can come in the range of normal only. So we are not going to order an immediate MRI. Reassure the parents as this is normal for age. Yes, that can be done and we can wait for some more time. Okay, and no further action needed at this time also appears to be correct. So here, you know, these 3 options closely mimic the correct answer. So it will depend upon what exactly was the language used in the question and in the options, right? So based on that, so probably, you know, which is the most inappropriate step or which of the following is not done might have been the question, or, you know, the options would have been worded differently. So we'll wait on more inputs on this question to come to a final better answer. Okay, moving ahead. So which of the following best explains the mechanism of breast milk jaundice. So we know breast milk jaundice is, so it is a clear-cut, very, very easy question. Again, a repeated question, okay, which has come multiple times. So breast milk jaundice, we all know, is due to some substances present in breast milk which inhibit the conjugation of bilirubin. So what will happen? So increased bilirubin production due to RBC breakdown? No. So breast milk jaundice is not because of that, we know that. Inhibition of bilirubin conjugation by substances such as non-esterified fatty acids and glucuronidase? Yes, that is the correct answer. Hepatocellular injury caused by maternal hormones? No. Decreased intestinal absorption of bilirubin? No, that is not the correct answer. So again, a very, very easy and a very, very simple question. So this time in the INI CET exam, especially from pediatrics, most of the questions were very, very simple and very, very doable apart from one or two. So which of the following vaccines is contraindicated in a patient with severe combined immunodeficiency? This I believe has been discussed in PSM also. So we know in SCID it is a severe immunodeficiency. So we are going to avoid live vaccines, okay? So out of these, hepatitis B, Tdap, inactivated polio vaccine, MR, so which one we'll be avoiding? So we know the live vaccine MMR is to be avoided here, right? So that was an easy one. A couple of more questions to go. A 5-year-old child presents with hepatosplenomegaly and cherry red spots on the retina. So cherry red spots on the retina are there. The child exhibits a normal startle reflex. So you know, cherry red spot we can get in conditions like Tay-Sachs disease, GM1 gangliosidosis, Niemann-Pick disease. Now hepatosplenomegaly rules out Tay-Sachs disease because in Tay-Sachs disease we do not get hepatosplenomegaly usually. Normal startle reflex again is against Tay-Sachs disease, right? But shows developmental regression is there. Based on these clinical features, which of the following enzymes is deficient? So our probable diagnosis here would be Niemann-Pick disease. So hexosaminidase A, sphingomyelinase, glucocerebrosidase, aryl sulfatase A. So the best answer would be sphingomyelinase, which is deficient in Niemann-Pick disease, right? Hexosaminidase A we know is deficient in Tay-Sachs disease, but hepatosplenomegaly and normal startle reflex goes against it. Glucocerebrosidase we know is deficient in Gaucher disease, but Gaucher disease cherry red spot is usually not seen. And aryl sulfatase A, metachromatic leukodystrophy, MLD, again does not appear to be the case here. So this was slightly tricky one, but if you remember the pointers, the organomegaly and cherry red spot, the simplified approach to IEMs that we've discussed, it is sorted. The last question I believe from pediatrics which I have been able to get in the recalls, if you have any more you can share please. So a child presents with petechiae, purpura and a platelet count of 10,000 per microliter. So there is thrombocytopenia, okay? Bone marrow examination reveals increased megakaryocytes. So megakaryocytes are increased in number, but there is no mention of increase in abnormal cells or blasts or anything like that. So most probably we are dealing with ITP here, okay? So which of the following is the drug of choice for this condition? So acute ITP if we are dealing with, we will not straight away go to bone marrow transplant. Many of the cases of acute ITP would be self-limited and will resolve spontaneously. So in fact, the first line of therapy could be wait and watch if you have good facilities available. Methotrexate again is not the preferred drug. If you have to give a drug, you can give IVIG or oral steroids, right? So IVIG can be given. Aspirin, of course, would cause more harm, more bleeding. So in a patient with thrombocytopenia, aspirin is a strict no-no, right? So the best answer out of these options is C, IVIG. So please message me if some other questions are there, or you know, if there are some different options for some of the other questions. So I believe pediatrics would have been very, very easy for you in this paper, barring one or two questions. But yes, as always, the questions have remained simple and the clinical questions are there. Image-based question, I could get only one this time, but otherwise most of the questions were there from the important areas which we have discussed so many times. So I hope you have given the best here. So all the very best for your results. We'll come back with a refined version of, you know, this recall session soon. All the best.
Hello friends, hi. So welcome back with the recall, and due to certain technical glitches, unfortunately the radiology session has been shifted a little later, so we'll resume with the obs-gynae recall, right? Now before I quickly move on the recall, I'm taking this opportunity to present to you Dr. Akhil here with me. He is doing his PG residency from AIMS New Delhi, and he is AIMS Jodhpur, sorry, and he is a subscriber, an avid subscriber of Prepladder. So Dr. Akhil, tell me, क्या लगता है आपको एग्जाम पैटर्न इस बार INI CET का? आपने देखा आप मॉर्निंग से you are seeing our recall sessions, right? And for the rest of the recall also you've been a good part of our team as well. So how is it different this time or from the exam that you gave last year?
So actually from last year, May and November, if I compare, so the paper was a bit on the easier side than the last May, and it was similar to the last November paper. Last May paper was quite tough. This time they mainly focused on the clinical questions, but they didn't ask what is the next step kind of question in the clinical question also, or some two-stem questions. If the clinical question was there, so the answer was also direct. It was not like some twisting was there. It was just that two options were confusing. Matlab in obs-gynae paper or medicine questions, there was confusion between two options. And if you have read well, if you have revised well, then you will be able to mark. Otherwise, you will get confused in the paper and you can mark the wrong one.
So basically, you had to read the question a little bit more carefully so that you don't get confused between the last two options that you are left with. Right? So we'll talk more on this, but we'll also have a look at certain questions along. And I'm sure now, after 1 year of residency, you still may be recalling some of them, right?
Yeah.
Right. So for medical termination of pregnancy, that is MTP, the opinion of 2 doctors is required at which gestational age? I think this has been taken up by Dr. Neha, the PSM faculty as well. So the answer is 20 to 24 weeks. That is when opinion of 2 doctors is required. I'm sure none of you have attempted this incorrectly, right? Now the next question, which of the following is not used in the treatment of postpartum hemorrhage, right? So the key to this question is sometimes we get confused between prevention of PPH, AMTSL vis-a-vis treatment of postpartum hemorrhage, right? So misoprostol, PGE1, carboprost, PGF2 alpha and oxytocin, obviously that is used, but dinoprostone is not recommended for treatment of postpartum hemorrhage. It is neither recommended for AMTSL any which ways. Dinoprostone, PGE2 analog, that is used for induction of labor. That is where we use it, right? Next question, arrange the steps for pap smear. I think you and I were discussing just this question outside, right? Arrange the steps for pap smear. So this is a straightforward question where maybe, you know, if you've seen the pap smear being done or have done it once or even seen it being done, you would be able to answer this question. So what do you think is the answer for us here?
Ma'am, actually I also got confused whether we will do per speculum or per vaginal examination.
Yeah.
But then I thought that, and there was option in which per speculum, per vaginal, both were also given.
Option there, yeah.
So yeah, it was a bit confusing, but definitely per vaginal we will not do because it will lead to contamination of sample.
See, it is straightforward, simple logic. I mean, the radiologist is telling me logically that we don't need to do a per vaginal examination because otherwise it will just, you know, contaminate our sample, or maybe we will not be able to extract anything out of the ectocervix where we have to take the sample from. So obviously you need to position the patient, put in the speculum and take the sample, and if as a part of your examination you need to do a PV, you will do it later. Otherwise, plain and simple logic, you put in a speculum and then do a PV again, remove the speculum to do the PV, and then put the speculum again to take a sample. Makes no sense, right? So the answer to this question is option number A, lithotomy per speculum and take the sample. Now let's move on with the next question. I think this is the question that those of you who had joined earlier may have seen Dr. Preeti ma'am in pathology talking about this question. So these are the sort of integrated questions that are asked. Now, which of the following statements are true, right? And they had given you a slide and you had to identify first of all what the slide was, and again, when you have 2 images you can always work out, even if you don't know one image, you will probably be more you can have an idea about the second image. So these are Call-Exner bodies are present. So yes, Call-Exner bodies, these are the coffee bean Call-Exner bodies are present here in this question. In this slide you're also seeing coffee bean nuclei, but nonetheless it's a sex cord stromal cell tumor. Yes, it is a granulosa cell tumor which presents with Call-Exner bodies, right? So that is also sex-cord stromal tumor, and inhibin is the marker because inhibin B comes from granulosa cells, and CA125 is a specific marker for epithelial ovarian cancer. Now they're saying it's a sex-cord stromal cell tumor, so the correct answer would have been A, B and C instead, right? That it is a sex-cord stromal cell tumor, call Exner bodies are present, and inhibin is positive, right? Let's have a look at another question before we talk further. What are the correct timings for intrauterine device insertion?
Ma'am, actually in this exam, like you said, there were multiple correct options.
Yeah.
So in these questions, you
What
just
is the
need
strategy that you use to answer such questions quickly? Because
Yes.
what is the strategy?
In these questions, you should, if they are asking you correct, then multiple answers are correct. You should first try to find which is the wrong one, because that will be easier. Because correct, there may be some other twist also, and you might be not having sufficient information to find the correct thing. But you must be having the information to find the incorrect one. So like correct timings was asked, so 5 to 7 days before the next menstrual cycle, this is absolutely wrong. And if you see A, B and C, they are seeming correct. If you are not even sure, then you can easily say, A, B and C are seeming correct, and D is definitely wrong. So A, B and C must be the answer.
Yeah, because D is definitely wrong. D is definitely wrong because there's no point inserting it right before the next menstrual cycle, all right? We introduce it after the periods are, or after the, within the first few days of the cycle, that is when we insert. So rightly said, logically said, 1 and 3 are eliminated, only A and B, and then now you have to choose between A, B and C. Right? So immediate postpartum, yes, it can be introduced. Post-placental insertion is done up to 48 hours postpartum. It is allowed till then, and within the first, within 5 to 7 days of menstrual cycle. So your answer becomes option number 2. So the good thing that we have a topper with us here is that we get to have a look at some nice
these
tricks
two are
and strategies as
controversial
well.
options also. Like within 5 to 7 days of the menstrual cycle and 5 to 7 days before.
Before
so
the next menstrual cycle.
One has to be correct.
One has to be correct. Both options cannot be correct at the same time. That's also the trick, right? So we discussed this as well. Now next question, which of the following is not a benefit of magnesium sulfate? Now see, going ahead with this question, I want to tell you that I am not entirely sure if these were the exact options that were given in the question, right? And what was the entire context, or was this the exact language of magnesium sulfate? So we use magnesium sulfate in obstetric patients when we give it for eclampsia and when we give it for severe preeclampsia. So it does reduce the incidence of seizures because we give it as prophylactic magnesium sulfate also. So that is one benefit definitely. Neuroprotective benefit, because when we give it in a patient with eclampsia, it prevents further convulsions. That way is neuroprotective. Other way that it is has a neuroprotective role is when we give it for the extreme prematurity, for prevention of cerebral palsy and there. So that way is neuroprotective, yes. So yes, B and C are definitely the benefits. Now, does it decrease the incidence of placental abruption? Because it does improve the renal blood flow, however, is this too much of a benefit to us, especially in obstetrics, is kind of controversial. But yes, it does not decrease the incidence of placental abruption, right? Placental abruption incidence would be decreased in a patient with, let's say, preeclampsia if we were to happen to control the blood pressure.
Yes,
that is why we read up, okay, one should control blood pressure or control hypertension in patients with preeclampsia, prevent acute hypertensive crisis from happening because that can precipitate placental abruption. So I would say all the benefits except this one. This would not be a benefit. However, more will come in this question once we have full options and once we have, the entire stem of the question. So maybe this could be a question where we might review the answer as well.
In first instinct, I also might mark this improves renal flow because we have read it has side effects and to drain.
Now see, that's a very valid thing that you're asking. That the side effect is, see, you could say that it does. The side effect is not to decrease the urine output.
We measure urine output.
When we give magnesium sulfate. because anyways urine output could be low because the pathophysiology that is operating in preeclampsia, right? So you are right there. So one could think like that, that we are measuring urine output, so it must be decreasing the renal flow, but it doesn't, right? So definitely not a benefit is that it decreases the incidence of placental abruption. Now, next question, Rotterdam's criteria, I mean, no need to discuss this as well. Hirsutism is there, delayed cycles are there. So your answer is B and C. Obesity, insulin resistance, not part of the Rotterdam's criteria. I'll move ahead. Which of the following drugs are associated with an increased risk of neural tube defects? Well, valproate is the most associated with neural tube defects. I mean, it is the most teratogenic of all the anti-epileptic agents. So that is your answer right there. Next question. Now, I think this is the question which also created some stir when we were talking about the path recall here. Now, a patient presents with ascites and omental caking. Imaging shows solid components in their neck cell mass, and there's a long history of symptoms. Yes, long history of non-specific symptoms, CA125 positive, most likely diagnosis. Now, I think from this recall that maybe some information in the actual stem is missing. Maybe they had mentioned some long history of symptoms, what sort of non-specific symptoms were there. Ascites and omental caking are good enough clues for me, but maybe they had given you some information about whether there was a unilateral adnexal mass or a bilateral adnexal mass. Solid components is a good enough clue for me, but maybe they had said solid, cystic, whatever, but solid components is a big enough clue. Say 125 is positive. It is an ovarian malignancy for sure. Now, which one most common is?
Serous
ovarian tumor. It is the most common. But what is your doubt?
But ma'am, omental caking and
no. Omental caking is when there are deposits on the omentum.
So that
description of a thick omentum, a thickened omentum with deposits in the omentum, that is what is called as omentum caking. So it can happen whenever there is peritoneal or omental spread of metastasis. So that can happen with either. And also if they had to really ask you about mucinous histology, they would give you more clear-cut features, right? There's a unilateral mass or big size and filled with mucinous fluid, something of that. So maybe they would have given you that the peritoneal lining is covered with mucinous substance and gelatinous substance, something like that, and they would have given you marker which was other than CA125.
So you have to just think straightforward.
You have
most
to think straightforward. Why do you have
serous.
to think anything other than that? Most common histological type, serous, responsible for 75% of ovarian cancer histology. So this becomes the most likely answer. Now, moving on. Most commonly associated 16-18. I don't want to discuss this any further. Okay, 29-year-old woman in her first trimester is diagnosed with asymptomatic bacteriuria due to E. coli. Now, what is the most common complication associated with this condition if left untreated? Now, we had a discussion on this question also. I'm so glad, I'm so wonderfully surprised that after a year of being into radiology, you still remember so much of Ops Gynae.
Yeah, remember, but that is the difference. I have not revised, so I am getting confused in certain questions.
So maybe that is the way, I think you are really helping me with this recall also. So let's attempt this question. So asymptomatic bacteria in the first trimester, we know that we are supposed to treat asymptomatic bacteria in pregnancy, right? Now you would say, okay, chorioamnionitis is a potential complication, could happen, but I would say that the infection is in the urine first. So before it causes chorioamnitis, it should cause something else. Before the bacteria can gain access to the intrauterine cavity, right? Now, preterm labor, yes. Now, before preterm labor gets precipitated in women with asymptomatic bacteriuria, something else should occur. Something else should occur to precipitate it, right? And again, preterm labor could precipitate with a low birth weight newborn as well, right? Now, pyelonephritis, on the other hand, makes a reasonable choice. See, the incidence of, if you look at the percentages wide given in textbooks, right? The percentage of pyelonephritis to happen in asymptomatic bacterial cases is in the range of 25 to 30%. Especially when left untreated. Why? Because in pregnancy, all those renal tract dilatation occurs, and therefore ascending infection can get precipitated. So it could become, right now it is asymptomatic bacteria, it can cause symptomatic UTI. And symptomatic UTI in pregnant patients could have 25% incidence of ascending infection into the renal tract and cause pyelonephritis. And once pyelonephritis happens, it becomes a surgical emergency in itself, and it can then precipitate preterm labor, it can then precipitate chorioamnitis. So that's the best choice answer right there. So there were questions, yes, that made you think. Right? And again, like we attempted that question based on what? Based on our basic understanding of what? changes in the physiology of the reproductive tract and changes in the physiology of the renal tract in pregnancy.
Yes, ma'am. Actually,
You do not even need to read pyelonephritis
Yes, ma'am.
to attempt this question. So I always keep driving the very, very important fact is that you have to have conceptual clarity, and your basic chapters are what are going to help you attempt, especially when in the context of INI CET, when they ask you questions from medical disorders in pregnancy, because that's a whole big unit which you do not necessarily read up, right? Now, which of the following is false about Turner syndrome? Prominent occiput is false. The rest of the stigmata can be seen. Now, 31-year-old presents with infertility, delayed menses, lap reveals normal uterus, chromoperturbation shows free spill of dye. So this is what infertility workup looks like. We take a history, right? We try to determine if she is ovulating or not ovulating. We try to determine if the tubes are open or not. As a part of the workup, this much of information has been achieved. What is the most likely diagnosis with this image? Yes, radiologist. Oh, sorry, this is not a radiology image, but let's just say, what is this image?
Actually, when I first saw this question, laparoscopic chromoperturbation and all, they are given with endometriosis question only, but there was no chocolate cyst or something.
Yeah, and see this is a recall image, right? So don't just disregard this fluid here, okay? Disregard it. Why? Because this is reddish in color, so you may think endometriosis. But see, this was not the exact image in the question. It was a chromoperturbation, so maybe a blue dye coming out of the fallopian tubes was given to you in this question. So disregard this. Please continue.
So, ma'am, there was no complaint of pain or something that, so endometriosis is a less likely possibility.
Yeah.
So, since she has infertility and delayed menses, so most probably it is looking bulky, ovaries are there.
Obviously, heart block, fetal bradycardia, right? Will be there. If there's fetal head compression, it causes decelerations, it causes fetal bradycardia, it can cause, right? So, fine. Now you choose between maternal fever and abruptio. In cases of abruption also, you read fetal distress happens.
Fetal distress.
Fetal heart rate falls down, right? So anything that leads to uteroplacental insufficiency, it could be acute. And the precipitating event could be some acute scenario which is decreasing the uteroplacental blood flow. That would be enough, if severe enough, to cause fetal bradycardia possibility. Yes, maternal fever, maternal tachycardia, fetal tachycardia. And that you read up in chorioamnionitis also.
Yes.
The first thing to happen is fetal tachycardia. So I think we are done with the recall questions from OBS and Gynae. And just on a parting note, I had a very amazing time recalling these questions with you, right? And tell me now, what is the biggest takeaway that you would like to give the students from the perspective of कि अब INI CET एग्जाम हो गया, ठीक है, आपने कर लिया जो करना था, आपने तैयारी भी कर ली, अब कैसा ट्रेंड रहता है? क्या आपको लगता है कि ये जो टॉपिक्स अब हमारे जो प्रीवियस ईयर टॉपिक्स में इजाफा हो गया इन द सेंस दैट हमारे और भी ये सारे टॉपिक्स अब एड अप हो गए, राइट? सो कितना वो रहता है, कन्वर्जन रेट रहता है फ्रॉम INI CET टू NEET PG? व्हाट डू यू थिंक टॉपिक वाइज, सिंस यू हैव गिवन द एग्जाम लास्ट ईयर?
So topics are almost same in NEET PG and INI CET. Now there are certain topics which are asked in INI CET specifically, but this time paper I don't see those kind of things being asked in INI CET, any out of the box questions or like that. There were 4 or 5 questions that were out of the box, and these questions, although they were seeming easy, but you can mark them wrong while attempting the paper.
Exactly.
So the most important takeaway for NEET PG will also be the same. In the last year NEET PG also, the knowledge that you have, that matters, but that almost a basic level of knowledge is there, then that's sufficient. You don't need to have much higher level of knowledge. In these questions also, if you have more knowledge and you think more, then you will mark wrong.
Probably.
You have to just stick to the question, just see the question and see the 4 options and choose by not your knowledge, choose according to what is given in the question and by eliminating the options. If you will think that I have read this in this condition, then you will tend to mark the wrong answer.
Yes.
And you will think कि ऐसा तो कभी पढ़ा ही नहीं, fetal bradycardia का maternal fever, but you have to apply the logic at the same time.
Yes, you have to apply the logic at the same time, and like we saw in that infertility and that laparoscopy,
Laparoscopy,
chromoperturbations. Like
perturb-
you all
all
have
the
read that
questions were like
laparoscopy,
that.
chromoperturbation is test gold standard for tubal patency. But then you have to also think that in a patient with infertility, if these are the findings, then what? And polycystic ovaries, many people, many times students think that there are multiple cysts in the ovary. It's a misnomer. There are multiple follicles in the ovary, and this is how those polycystic ovaries actually look like. They just look bulky and larger in size, and nobody counts the bulk on laparoscopy. Actually, you know, you can measure it as an ovarian volume. आप लोग measure करते होंगे ultrasound में, वो आप measure कर सकते हो. But so this is the take home, that even seemingly previous year topics, उन्हीं topics में से आपसे question पूछे गए हैं, लेकिन वो पूछे इस तरीके से गए हैं कि आपको थोड़ा सा एक्स्ट्रा सोचना पड़ता है क्वेश्चन अटेम्प्ट करने के लिए. सो दैट इज द क्रक्स एंड दैट इज वेयर
आपको क्वेश्चन के थ्रू ही सोचना है, क्वेश्चन के अंदर ही सोचना है. आप जितना ज्यादा सोचोगे अपनी नॉलेज इसमें पुट इन करने का, उतना ज्यादा आप गलत जाओगे. जो क्वेश्चन में जितना दे रखा है बस सिर्फ उतना ही देखना है, अपना नहीं सोचना है इसमें ये भी हो सकता है या फिर ये भी हो सकता था तो अपन ये भी ऑप्शन कर देते हैं. आपको एकदम बेसिक के साथ स्टिक करना है. इवन आपको अगर 1 साल भी हो जाएगा पढ़े हुए और आपके अगर बेसिक्स क्लियर हैं तो कुछ ऐसे एक्स्ट्रा इन्फॉर्मेशन की जरूरत नहीं है आपको. क्वेश्चंस वर बेस्ड ऑन द इन्फॉर्मेशन दैट यू हैव, बट यू हैव टू ट्वीक अ बिट टू अप्लाई दैट इन द क्वेश्चन.
True. Thank you, Dr. Akhil, so much. Thank you for your
lovely
insight, and I had a great time in this recall session.
I too had
lovely meeting.
Thank you so much, ma'am.
All the best.
Thank you, ma'am.
Hello everyone, happy evening and welcome back. So I'm here again. Hopefully everything is fine now, right? So with some initial hiccups, some more bumps, but we are back now. And quickly we are going to discuss radiology questions. Radiology had good number of questions this time, right? And the questions were very much doable is what I would say. They were not very eccentric. And if you watched the Prepladder videos, definitely you would have been able to answer all of them, right? And overall, if you would ask me, the INI CET paper is definitely on the easier side, in the sense that this is definitely going to make the cutoff high. The competition is going to be high, right? I can understand that the questions look easy, but it is options that make it confusing. And how you approach that in the exam hall is what really matters at the end. And that's why, as we always say, right, in the attitude in your exam hall is of the prime importance, right? Those 3 hours and 3.5 hours, they are the ones which are the most important, right? So quickly diving into radiology questions, right? So based on the X-ray image, what type of thyroid malignancy is this? So when you are seeing these lytic lesions in the skull and you are given the thyroid cancer and the bone lesions, you are thinking of metastasis. So basically they are asking you that which type of thyroid cancer will cause these bone metastasis, osteolytic lesions. It's going to be follicular, right? So integration question, radiology, surgery, patho, integrated question. So if you remember, papillary has lymph node wala metastasis and follicular has hematogenous metastasis. So these bone lesions are going to be, right? These bone lesions are going to be seen in follicular carcinoma. Remember, follicular carcinoma, RCC, they have the expansile osteolytic metastasis. Which imaging modality is contraindicated in pregnancy? A very easy question. Pregnancy means no radiation there. No radiation means CT scan, which has radiation, will be avoided. MRI, ultrasound, Doppler, these are the ones which have no radiation. This is always one of the frequently asked question in exam. Which investigations have radiation, which do not have radiation? Has been asked in an applied manner. What will you not do in pregnancy? Correct? So it's definitely going to be CT scan. Identify the condition associated with the MRI finding shown below. So the MRI finding that is given here is the eye of tiger sign that we are seeing here. Eye of tiger sign. This is going to be, we have discussed this. Halloward-Spatz disease, also called as PCAN, pantothenate kinase associated neurodegeneration, right? So Halloward-Spatz or PCAN. I've told you the trick to remember that. Halloween is scary animal, right? Scary like the tiger is scary. So remember, eye of tiger and Halloween go together, and that is PCAN. Okay, that is going to be PCAN. Going to the next one, investigation of choice for spinal TB. That's going to be MRI. Because whenever it's a spinal pathology, you also want to see the cord compression, the altered signal intensity in the cord, right? MRI helps there, right? So when you want to see that, MRI definitely helps there. So remember that MRI helps in spinal TB, in quad spine. It helps you to see the cord, compressive myelopathy, altered signal intensity in the cord as well. Okay. MRI was not an option here. So if MRI was not the option, then what was the option there? Okay, so many of you are saying it was according to WHO. What is the recommended investigation of choice for spinal TB? MRI was not there. Okay, so instead of MRI, culture sensitivity was there. Okay, so culture sensitivity was there instead of MRI, right? So then we need to look into that question. Right, as far as I have seen practically, right, when we used to get patients of spinal TB, definitely, you know, we take a sample from there and we send for the investigation further, right? So yeah, either it has to be culture sensitivity there or it has to be CB0. Ultrasound and CT are not going to help much there. Okay, yes. Instead of USG also, it was X-ray. Okay, so I'll correct the options here. It was X-ray, culture sensitivity, CT scan, and CB0. Okay, so more than radiology, it looks like a question of PSM from a TB and a WHO perspective. Okay, going to the next one, there is the image of CT abdomen given, and look at the options. From the options, you are trying to remember in image-based questions, always you try to rule out the option, try to fit the option and the image together. So where you have this pancolitis with the ahostral pattern, right? The right-sided colon was also shown. Ahostral colitis, loss of hostra, ahostral along with the lead pipe appearance, that is going to be ulcerative colitis. You know that it involves the entire colon in a retrospective fashion, right? In a continuous fashion, lead pipe colon, ahostral colon. Okay. All right. Identify the condition associated with the image given below. So yes, I want to know whether the Honda sign was directly mentioned in the question. Was the Honda sign directly mentioned in the question? And it was a stir MRI image which was given rather than the classical, you know, the Honda sign that we talk about in the nuclear scan, in the bone scan. Right? So if the Honda sign was mentioned, then it becomes very easy and you can answer that even without looking at the image. Honda sign again has been discussed in nuclear medicine, musculoskeletal radiology. It is sacral insufficiency fracture, right? Which is a type of stress fracture. X-ray will not show anything. Remember, for stress fracture, MRI is better. It might show these, it will show these fracture lines with the surrounding bone marrow edema. Remember, stir sequence helps to pick up the bone marrow edema, right? So parallel to the SI joint, you are seeing the fracture lines here, the dark fracture lines with the adjacent marrow edema. Okay. All right. So this is Honda sign, is straight ahead, a sacral insufficiency fracture. Going to next one, which imaging modality is being used? See, so think logically. Don't just get confused and baffled when you look at the options or you look at the image. Oh my God, I've not seen this image anytime. Think very logically. Is it a X-ray? Is it a CT? Is it a MRI? So remember that here you are seeing the X-ray which is shown, right? This is the lateral view which is shown. You are seeing the contrast in the rectum. So this is not a MRI. This is not a CT. This is not an X-ray abdomen, X-ray difficography. Okay, X-ray difficography is what going to be there. It's not X-ray abdomen. Right, but X-ray difficography is what going to be the answer there. One of the option, because of course, if they give you X-ray difficography and barium minima in the same question, they are going to be confusing. Because दोनों में same ही दिखेगा. If you're just looking at a still image, it's not a video which is shown where the patient is actually straining and defecating. So the option given was barium swallow. And you know that in barium swallow, it's going to be esophagus and not rectum that you are going to see. So definitely that is also out. MRI mein, the bone cortex will be black. CT will have a much better resolution. This is X-ray difficogram. Okay, so the option here was barium swallow and not barium enema. Okay, corrected there. Thank you for all the inputs, guys. That's what we are here for, to learn from you as well, you know, what exactly you had in the exam. Okay. Going to next one, based on the CT finding, what is the most likely diagnosis? Was the CT image this, something like this given? Or was the CT image something like this given? right? So many of you said that it was a ring enhancing lesion with a scolex that was seen inside. So remember the cyst with a dot appearance, cyst with a dot appearance. Cyst in the brain is neurocyst. The scolex is the sarcosis. So neurocysticercosis, a ring enhancing lesion with a dot inside. That's the scolex there. That is going to be neurocysticercosis. Okay, both of these was not there. Only a single lesion image was given, which was ring enhancing lesion with the scolex inside. Okay, with the scolex inside. Okay. Right. Any other history was given, clinical history or anything which helps you to differentiate whether it's a tuberculoma, it's a brain abscess, it's a neurocysticercosis? Because only single lesion was there. 15-year-old was given. Okay. So many of you did mention that scolex dikh raha tha. Right? So then you will go for neurocysticercosis. A 15-year-old with seizures. Okay, that is what you are saying, many of you. 15-year-old with recurrent seizures is what was given. Right? So no other history was given. So we will go with okay. So we will go with neurocysticercosis. Okay, neurocysticercosis, because generally if it's a TB brain or something like that, they'll give you the meningitis features also, which are generally given along with that. Okay. Right. Going to the next one, which of the following is the best investigation for detecting ureteric calculi? It is non-contrast CT. This has always been a favorite question, right? They ask you time and again. Last time also it was asked. For ureteric stones, they are calcified stones, so we go for CT. For gallbladder stone, they are generally not calcified, so we go for USG, right? So it is non-contrast CT, which is going to be the answer there. The other option was CECT. Okay, so rather than here, I'll make it CECT. One was NCCT, ureteroscopy, and X-ray. So it's non-contrast CT because it is calcified. Remember, for acute hemorrhage and for calcification, non-contrast CT is enough. So calcified ureteric stones, it's going to be non-contrast, right? So that was about the quick radiology recall, guys. Not taking much of your time because I know that you are in no moods to listen to the details of the discussion. But I hope you've got an idea into what were the questions and what images were asked, right? Especially for the students giving the NEET PG exam as well. You always want to see that what questions have been asked in the recent INI CET to see that whether if any repeat comes in your NEET PG exam. Okay? Yes. Cysta maybe, the parathyroid localization, that's going to be cysta maybe, the answer there. Previous INI CET exam question, cysta maybe SPECT versus cysta maybe scintigraphy, it's going to be cysta maybe SPECT if that was there. Okay, USD KUB is not a better option. It is a CT for ureteric stones because ureter is, it requires a lot of skill to be seen in the entire extent on USD. So for ureteric calculi, it is CT. Calcification, it is CT. Okay. All right. Thank you so much, everyone, for joining in and wishing you all the best for your results. And we'll be waiting to hear from you post results as well. Right. And for any other, if you have any inputs for the recalls, please do let us know. Always there. Right. Okay. So that was from my end, guys. No, remember, best always means you will first go for non-invasive and not an invasive investigation. It's going to be CT. Okay. All right.
So Mayank, you saw the surgery questions. How was the exam?
I think the surgery paper was pretty easy and was comparable to November NICT. Most of the questions were repeat from previous year questions.
So it was previous year questions, guys. Most of the questions were repeated from previous year topics and 2-3 questions were exactly repeated in the same manner. Let's see the questions. So see the first one. You can see here, this is Z plasty. Can you see this image? This is Z plasty. So identify the procedure given below in the image. This is Z plasty. So Mayank, we are doing this Z plasty for what?
This procedure has been done for transposition flap used for scar revision.
So guys, it is done for scar revision. You know that if it is 60 degrees Z-plasty, it is going to increase the length for 75%. Got it? So what is the correct answer? Correct answer is transposition flap used for scar revision. Let's see the second one. Which of the following is not component of TNM stage 4B? Breast cancer. You know that breast cancer image staging is most important topic out of 19 subjects. This topic is very important. Every year you are going to find the question. So it is T4B. So can you tell me what is the correct answer?
My correct answer is inflammatory carcinoma, as it has asked except, which
Very
is
good.
of the following not a component of stage 4B.
It's not a component of stage 4B. So guys, T4B, you know that ulceration is the part of T4B, Pude orange is the part of T4B, satellite nodules, all these changes are confined to the same breast, means ipsilateral breast, these are included in T4B. What is T4A? T4A का मतलब है अंदर, अंदर मतलब chest wall का involvement है, that is अंदर. So whenever there is involvement of chest wall, it is T4A. And whenever there is बाहर, बाहर मतलब breast skin का involvement, so whenever there is ulceration, edema, Pude orange, satellite nodules confined to the same breast, that is T4B. और आपको पता होगा, you must be knowing that what is the stage for inflammatory breast cancer? This is T4D. So this is T4D. So what is the correct answer? Correct answer is C. Okay, see this question. Patient presents with breast lump. Guys, I'm telling you, almost same question was repeated previously. So breast lump and imaging along with histopathology confirm diagnosis of what? You can see here, patient is having breast cancer. She has family history also. So there is positive family history of breast cancer involving 2 relatives and has a 29-year-old daughter. Which gene should be tested to assess hereditary breast cancer? So you know that in hereditary breast cancer, which mutations we expect? BRCA1, BRCA2, BRCA1, it is mainly responsible for breast cancer in females, BRCA2 mainly in males. So Mayank, which answer?
BRCA1.
Okay, so this is BRCA1 guys, because it's a previous question, yearly, it was previously asked in INI CET only. So here what is the correct answer? It is BRCA1. Now see the next question. Okay, only one BRCA was there, so it is BRCA1. Now guys, can you see here, this patient is having cleft lip. See the question, child presented with following finding is planned to undergo surgery. Which muscle will be repaired during the surgery? The main muscle is, yes, you tell me, main muscle?
Orbicularis oris.
It is guys, it is orbicularis oris, because it is going to form a sphincter around oral cavity. So what is the correct answer here? Correct answer is option A. This is orbicularis oris. Next. A bit lengthy question, but it's very easy question guys. See, 22 years old male. Let me first tell you, this question is in relation to Mantrel score, so that it's easy for you to mark the correct answer. Mantrel score, let's discuss. 22 years old male presents to emergency department with a history of abdominal pain started around the umbilicus, localized to right lower quadrant. What kind of pain? Migratory pain. So how much is the score? 1. Next, he also reports nausea, loss of appetite. So there is anorexia, score is 1. Nausea, vomiting, score is 1. On examination, he has tenderness, obviously the score is 1. And tenderness is there in right iliac fossa, rebound tenderness. So guys, you must be knowing that for tenderness, the score is 2. How to remember? It is LT2. For leukocytosis and tenderness, we add 2. You can see here rebound tenderness, so here the score is 1. Temperature is 38.2, patient is having fever, so elevated temperature, score is 1. Laboratory investigation reveals white blood cell count 14,000, leukocytosis 2, and there is shift to left, guys 1. So obviously all parameters are there, and you know total 8 parameters are there, 2 parameters are having score of 2, so obviously what is the score? Guys, here the score is 10. So what is the correct answer here? Obviously 10. So it's very important, very easy, and I hope all of you mark this question correctly. Okay. Okay, somebody says that sir, option mein 7 wala maximum tha, so you can calculate easily, right? In recall session we will discuss, so you can easily calculate, it is so easy, right? Next. See guys, 65 years old patient undergoes colonoscopy, right? For evaluation of altered bowel habits. 6 centimeter colonic mass is identified and biopsied, histopathology confirms adenocarcinoma that is confined to the mucosal layer. It is confined to the mucosal layer with no evidence of invasion into submucosa or beyond. Imaging studies show no lymph node involvement, no distant metastasis. So guys, here you can see here it is N0, M0. Here in colorectal cancer, size of tumor doesn't matter. Here which layer is involved, that's is going to matter. So if there is involvement up to submucosa, the stage will be T1, and if stage is T1, it is stage 1. So obviously what is the correct answer here? Guys, the correct answer is stage 1. Okay, next question. Now you have to tell me, Mayank, 30 years old female presents to emergency department, burn injury sustained from stove explosion, has burns involving face. First, there is involvement of face. Second, singeing of eyelashes, both upper limb. So involvement of bilateral upper limb. What else? Involving anterior chest also. So there is involvement of chest also. Right, based on the rule of 9, what is the approximate total body surface area? Let's discuss the easy one. Bilateral upper limb, obviously
9 plus 9.
9 plus 9, 18%. Anterior chest, how much? 9, 27. In face specifically, it is not mentioned that there is involvement of whole head and neck or face only. Let's assume there is involvement of face, right? At least 4.5. Clear? But see the options, guys. If you see the options here, 33 to 36. So I think they have taken the whole head and neck. So here also we are going to include 9. So obviously range would be somewhere
33 to 36%.
So the range would be somewhere 33 to 36%. Guys, if you want to improve the language of question, please, your Google form has been shared with you, and please mention the options and improvise the language of the question. And as lots of faculties have announced that there are lots of giveaways for you guys, and there is one special offer going on. You can get 15% off on our Prepladder version X. So here it is option A. Next question. Now see this procedure. Okay, let me explain. Guys, can you see this? Yes, this is duodenoileostomy. Here it is the first part of duodenum, and this is eye, duodenoileostomy. You have seen that there is sleeve gastrectomy. So can you tell me in which bariatric surgery we are having anastomosis between duodenum and ileum? There is duodenal switch. So it is duodenoileostomy. This is the sleeve gastrectomy. So it is not gastric bypass. It is not only sleeve gastrectomy. It is not adjustable gastric banding because you are using a band. What is the correct answer, Mayank? You tell me.
Single anastomosis with duodenal bypass with sleeve
gastrectomy. So this is single anastomosis. There is duodenoileal bypass with sleeve gastrectomy. And guys, what is the name of this procedure actually? This is duodenal switch. What is the correct answer?
A.
Option A. Now this one, see, sometimes in the exam, if you see the image, not able to understand the image, doesn't matter. Read the question. During a laparoscopic cholecystectomy, surgeon carefully identifies the boundaries of hepatocystic triangle to avoid injury to important structures. Which of the following is not a boundary of hepatocystic triangle? It's very easy. You can see this is the liver. You can see this is the anatomy. This triangle is hepatocystic. So guys, here this is common hepatic duct. This is cystic duct. It is hepatocystic. That's why the superior edge is hepatic edge. How to remember? In hepatocystic triangle, the superior boundary is hepatic edge, and obviously which hepatic edge? Inferior hepatic edge. How to remember Carrot's triangle? Medial boundary is same, common hepatic duct. Lateral boundary is same, cystic duct, but superior boundary is cystic artery. So cystic artery is the boundary of Carrot's triangle, and cystic artery is
content of
hepatocystic triangle. So guys, which of the following is not a boundary? Common hepatic duct, yes, it's a boundary. Cystic duct, yes, it's the lateral boundary. Inferior border of liver, yes, it's a boundary. Cystic artery, not a boundary because it's a content. Very good. Content. Guys, see this? This is very, very important. See guys, this is sealed dressing, and here vacuum has been applied. So this is negative pressure wound therapy or vacuum assisted closure. Mayank will tell us about this question. Which of the following is incorrect regarding this negative pressure wound therapy or vacuum assisted closure? Man, how much pressure we apply here?
Minus 130,
Minus,
120.
very good, approximately minus 125. Now redressing done after 4 to 7 days, yes. Increases proliferation and protein matrix synthesis, yes. Now see, option D, it is correct or incorrect?
This option is correct. It
Correct.
can be continuous or intermittent.
The vacuum can be applied continuously or intermittently. This is also correct. This is also correct. This is also correct. You told correctly how much is the pressure? Minus 125 mmHg. So what is the option which is incorrect, guys? Option B, that is incorrect. So it is option B, that is incorrect. Clear? Option B, okay guys? Clear? Now keep sending your options and your feedbacks, and the Google form is shared with you guys. Please mention the exact language and options, right? Now this question, 65 years old patient is on mechanical ventilation for ARDS. It's related to anesthesia. Suddenly the patient becomes hypotensive, tachycardiac and absent breath sounds on the left side with tracheal deviation to the right. Why there is absent breath sounds?
Like most probably the patient has developed tension pneumothorax.
Tension pneumothorax. There might be tension pneumothorax. Why? Because it can lead to injury to the lungs. Tension pneumothorax, and you know in tension pneumothorax what happens? There is shift of mediastinum to opposite side. The air is going to collect in ipsilateral hemithorax. Patient will be having hypotension because of compression of inferior vena cava, superior vena cava. So it decreases the venous return. That's why there is decreased cardiac output. So obviously it's not because of high tidal volume. It's not because of oxygen toxicity. It is not because of endotracheal tube malposition. Obviously what's the correct answer?
Barotrauma.
Barotrauma due to high airway pressure. So this is the correct answer. Correct answer. Okay. Okay, next step पूछा था. Okay guys, you can share. Right. Now see this question. Question number 12, 40 years old male presents to emergency department with severe respiratory distress. Can you see the BP? Hypotension. There is tracheal deviation to the right, distended neck veins and absent breath sounds. Guys, some of you might be confused that that question was there or this question was there. Okay, you please send your comments. Clear? Okay. Now see here, these findings are suggestive of tension pneumothorax. What is the most appropriate immediate next step? So you can see here, patient is having hypotension, patient is having tachycardia, distended neck veins. Findings are suggestive of tension pneumothorax. Guys, any patient of trauma is coming to you. What protocol we have to follow? We have to follow A, B, C, D, E. So Mayank, what do you think? What you should mark in this case?
Airway, breathing and circulation.
Obviously, we have to go for airway, breathing and circulation. And in breathing, since patient is having tension pneumothorax, so in breathing, after you assess the airway, if there is no obstruction of airway, in this case, we have to put a wide bore needle since the age of patient is 40. Fifth intercostal space in anterior axillary line. Clear? And what is the treatment of choice? All of you know, it is ICD insertion. So what is the treatment of choice, guys? It is ICD insertion. Okay. So correct answer here, it is C. Okay. Now which of the following is not a recognized cause of recurrent renal stone formation? Guys, I want to ask all of you this question, that these options were there or not? Hyperoxaluria, hypercalciuria, hypocystinuria and hyperuricosuria. Junaid, yes guys, tell me, this question was there or not? Okay, it was hypercystinuria. Okay, so it was not hypo. Very good. It was hyper. It was hypercystinuria. So this was hypercystinuria. So all of you know that hyperoxaluria, it leads to recurrent stone formation. Hypercalciuria, it leads to recurrent stone formation. Hyperuricosuria, here you can see patient is having gout, which stone will be formed? Obviously uric acid. Hyperoxaluria, hypercalciuria, obviously which one? Calcium oxalate. So it is not hypocystinuria, it is hypercystinuria. So it is hypercystinuria. So guys, what is the correct answer here? Correct answer is option C. So option C, it is correct. Now guys, see this question. This is very easy question. I don't think that this kind of language was there, but there was one question related to follicular carcinoma, right? So there was one question related to follicular carcinoma. Yes, please update the language, improvise the language, right? Now see this, a 50-year-old woman presents with slowly enlarging painless mass, means thyroid nodule. See, she has no history of radiation exposure. Why this history is important? Because if there is history of radiation exposure, especially during childhood, papillary carcinoma thyroid is a, one of the malignancy which is caused by childhood exposure of radiation. On examination, nodule is firm and it was mobile. Thyroid function tests are within normal limits. Ultrasound shows solid lesion in the right lobe of thyroid. FNAC is performed, but it is inconclusive. You are having the hint. Hemithyroidectomy is done, and histopathology reveals capsular and vascular invasion, right? I don't think so much information was there, right? Okay, histopathological examination was given, right? So whole thing was not there, right? Some of the findings were there. So obviously if FNAC is not able to make the diagnosis on histopathological examination, if there is capsular invasion, vascular invasion, obviously what's the correct answer?
Follicular thyroid carcinoma.
Follicular thyroid carcinoma. Guys, there are chances of improvement in the language, so please improvise the language, fill the Google form and send it to us. Okay? Okay, so somebody is saying that, sir, it was follicular carcinoma and there was X-ray of metastasis. Guys, see the question. Sometimes this question was asked previously also. Patients who are having follicular carcinoma thyroid, these patients are having pulsatile secondaries. Pulsatile secondaries are to the flat bones. So what are those flat bones? Ribs, there is ribs, vertebra, pelvis, skull. Most common site is thoracic vertebra, but you can have metastasis to skull. So if there is skull secondaries, right, what? It is because of follicular carcinoma, because what kind of secondaries are there? Pulsatile. Next question. A 35-year-old patient presents with history of diarrhea associated with blood in stool. For several weeks on examination, patient is febrile. There is abdominal distension and tenderness. So abdominal distension and tenderness, a CT scan shows grossly dilated colon with loss of hostrations. Laboratory investigations reveal leukocytosis and elevated inflammatory markers. Based on the clinical and radiological findings, what is the most likely diagnosis? Mayank, tell us what is the diagnosis?
They have given us features of toxic megacolon and lead pipe colon. So the diagnosis is ulcerative colitis.
Guys, features are of toxic megacolon, there is lead pipe colon, chronic case, absence of hostration. So obviously the diagnosis suggests ulcerative colitis. So it is ulcerative colitis. Clear? Ulcerative colitis. Okay. So Ankit wants to say that, sir, skip lesions were not there, pancolitis involvement was there, right? So you please send your recall. Obviously this is done quickly. So on the basis of language of the questions we got from the students, this was made. Guys, the original recall, I mean based on the exam, based on the questions which were asked in the exam, we will be having very soon. So thank you very much, and again I am going to repeat that there will be giveaways for the students who are going to contribute maximum in the paper, and you are going to get 15% extra off for your Prepladder version X. So thank you guys for your participation. Best of luck.
Okay, hi everyone. Yeah, so I hope I'm audible and visible to all of you. Yeah, so if I'm audible and visible, kindly give me a quick confirmation so that we can get going with the session. I know that you're not in any position to hear anything excess of the recall. You just want the question and answer and no explanation. I totally understand that. So if I'm clear here, then let me know so that I can start the session. Yes, great. So when I'm audible and visible, now let's begin the session with the questions that were asked. So the first question is absolutely simple. Which of the following is not seen in JNA? An absolute easy question, a recurrent question that you see in every exam. I know all of you know the answer. What is it? Quickly answer. Recurrent epistaxis is a feature. Unilateral is a feature. Exclusive to adolescent males is a feature. But what we do not see is or do is biopsy to diagnose under anesthesia. Whether it is local or general, we don't do for JNA for diagnosing JNA. So this has to be your answer. D, absolutely true. So we'll go to the next question. So we have a patient here who's a middle-aged lady who's coming to you with choking while eating fish and has symptoms of coughing and hoarseness of voice with a foreign body sensation in the throat. Now there is a inflammation that you see on the pyriform fossa. So what nerve supplies this region, right? So we have to answer this question very easily because we know that the pyriform fossa, we've learned smuggler's pouch. It is an area where it can cause referred otalgia. We've learned all this. So we know that the nerve supply to the pyriform fossa is via the internal laryngeal nerve, which is a branch of the superior laryngeal nerve. External laryngeal nerve is not sensory. It is motor to cricothyroid. Glossopharyngeal nerve is sensory to oropharynx and not hypopharynx where the pyriform fossa lies. And recurrent laryngeal nerve is sensory below the level of vocal cords and motor to all the muscles of larynx. So I think this is sorted. Let's go to the next question. We have a 4-year-old boy who's suffering an ear infection and has tonic spasm of the limbs. What is the likely diagnosis? So here I think they have also given you that the child had a lockjaw, if I'm not wrong. So if there was lockjaw, inability to open the mouth, let me know in the chat box if that was given. Yes. So if they have given you lockjaw, if they have given you spasm of the limbs, then the answer has to be tetanus. Now your question will be, ma'am, how can an ear infection in a 4-year-old boy be because of tetanus? See, if the child has had an infection, an ASOM, where there was a perforation of the tympanic membrane, there is every possibility that the child can have the Clostridium tetani bacterium entering through the perforation into the middle ear, and that can cause tetany. And the word lockjaw, inability to open the mouth, and spasm, these two words are enough for us to go towards tetanus. Meningitis can cause high-grade fever, which is not mentioned. You can have altered consciousness or sensorium, which is not given. And that is why we rule out that. Bisol's abscess is an abscess in the sternocleidomastoid. Sigmoid sinus thrombosis will present to you with hectic picket fence type of fever. There will be papilloedema, all of those features. So with this, we are sure that the answer is tetanus. Now, why not meningitis and sigmoid sinus thrombosis? See, where is fever given in your question? The key highlighting features for both these conditions is fever. It's not given. So when there is no word of fever, you are not going to take the rarest possibility. When they have given you spasm of the limbs, the word spasm itself prompts. Okay, lockjaw was not given, spasm was given. Spasm itself is a prompter towards tetanus. Okay, in meningitis, they can have seizures, they can have convulsions, but there cannot be spasms. So please understand that. Okay, great. So some of you telling fever is given, neck rigidity is given. If fever, neck rigidity is given, then the answer is meningitis, no doubt about that. But anyways, we'll take the consensus and come back to the final recall on Monday, where I'll be discussing again everything in detail, right? So now let's go to the next question. Which of the following conditions may require a cochlear implant? So what is cochlear implant? It's an implant which goes inside the cochlea. So whenever there's a sensory neural hearing loss where the cochlea is not functioning, you're replacing it with an implant. As simple as that. Now, can we use it for middle ear problems like otosclerosis or fixation of stapes? No. Because in middle ear problems, you cannot use this in otosclerosis or fixation of stapes because you have to repair the middle ear cause, or you can give a hearing aid. But if you need to do a cochlear implant, there has to be a congenital deafness, yes, severe to profound sensory neural hearing loss, which is the most common indication. In ototoxicity, yes, because ototoxicity will cause hearing loss and that can be severe to profound. You can rehabilitate with various methods based upon how much is the hearing loss. So if it is severe to profound loss in ototoxicity also, you do. So the correct answer will be option A and B, which is congenital deafness and ototoxicity. For middle ear issues, you will not do a cochlear implant. Let's go to the next question. A 45-year-old man complains of early morning vomiting that occurs after turning in bed. Yes. So now here I want to know that turning in the bed was given. Along with that, did they give you vertigo, which was sudden in onset, lasting for minutes? Because I think some of you mentioned that it was given, some of you mentioned it was not given. Whatever said and done, if there is any positional cause that is provoking vertigo, that's provoking vomiting, then the answer has to be simple, which is BPPV. In Meniere's disease, you can have vertigo, you can have vomiting, you can have nausea, but it doesn't occur with positional change. So the key feature after turning in bed prompts to you for BPPV. So with this, I think we are finishing with the ENT recall. There was a question on neonatal stridor, if I am not wrong, and I have seen Meenakshi ma'am do this, so I'm not covering that. There was a question on thyroid malignancy, which I have seen, even the general surgery, Dr. Pritesh sir and Nikita ma'am do it, so we're not going to do the overlap question. Purely ENT were 5 questions, so I think that they were pretty easy, simple questions. It just required you to apply logic. 3 out of the 5 were absolutely straight questions. 2 were a little bit twisted, and you just needed to understand those questions, right? Yes. So anything else you want to tell me in the chat box regarding any other questions that were given to you? Let me know in the chat box or leave it as a comment after the video, so that when we come on Monday, we will have the full complete recall with the explanation to make sure that you have the best learning possible with us. So Venkatesh Prasad, why not vestibular neuritis? Vestibular neuritis, there will be history of upper respiratory tract infection first, followed by vertigo, which is a long-standing vertigo for days and weeks. And here there is usually no association of vomiting, which is given in your question. And there is no positional, effect on vomiting or vertigo. Got it? So in the rigidity wala question, there was fever, fine. So if fever है, अगर neck rigidity है तो meningitis answer करो, अगर fever neck rigidity नहीं है तो tetanus answer करो, but अगर spasm दिया गया था, please check. If there is spasm, the answer has to be tetanus, because in India, where the socioeconomic conditions are bad and where the children are prone to get infected with contaminated soil and whatsoever, there is a possibility of tetanus, which is rare, not a common possibility, but it is there. But if the word spasm is given, then it has to go towards tetanus, right? Yes. So I think yes, so I think all of you think ENT was easy, good for all of you.
Discussing a very, very important subject, forensic medicine. The paper was moderate for forensic medicine and few very, very important questions asked. But the first question is the very much controversial question. That's a very much controversial. What is the minimum age at which a woman can give valid consent for medical termination of pregnancy in India? If the question is asked about at what age she can give valid consent, yes, the answer will be, anyone who can give me the answer? What is the answer here? If this question is asked, a woman can give valid consent for medical termination of pregnancy, here answer is 18 years. 18 years. So very simple question. If it is not consent, if you are asking, then your answer can be 16 years. Like for what is the minimum age for MTP, that could be 16 years. Okay. So if the valid consent is asked, the answer is 18 years. Again, I am telling you, it's a controversial question. Valid consent, the answer will be 18, and minimum age for MTP, the answer will be 16. Okay. Yes, MTP can be done. Minimum age, the answer will be 16. Next question. This is a very simple question. As per the MTP Amendment Act, opinion of 2 registered medical practitioners is required for the termination of pregnancy at which gestational age? That is very simple. 2 registered medical practitioner. Yes, here answer is 20 to 24 weeks. We require 2 registered medical practitioner at this age of the MTP. Okay, below 20 weeks, we require 1 doctor. Yes. Now, which of the following feature is characteristic of chronic mercury poisoning? Now, number 1 option, hyperkeratosis and Mees line, this is arsenic poisoning. Lead line visible on the X-ray, that's lead poisoning. Mad hatter or intentional tremor, that is A, because mercury is used. Actually, the history was given about the thermometer and this all kind of history was given. So you can get that question also. So Mad Hatter is the answer of chronic mercury poisoning. Basophilic stippling of red blood cell is seen in lead poisoning. So your answer is option C. Again, I am telling you, if consent was asked, the answer will be 18. If consent is not asked, the MTP can be done at any age, like it is below 18 also, that is a 16 also. Now, gastric lavage treated with silver nitrate test. Actually, this question is asked about the silver nitrate test that gives black color in which of the following? The option A is malathion, that's organophosphate. The option B is mercury. Yes, thermometer factory was given, that is also a right question. That means it's a mercury poisoning, okay. So anyways, it's a silver nitrate test gives black color in which of the following? The first option is malathion, second is mercury, third is aluminium phosphide, and fourth is barbiturates. Now, malathion is an organophosphate, mercury it's not giving. Yes, it is aluminium phosphide, absolutely right. Everyone is right here because aluminium phosphide forms phosphine gas. And this phosphine gas reacts with silver nitrate, gives black color. So here answer will be option C. Now, which of the following types of poison and their corresponding examples? The poisons are given A, B, C, D, metallic irritant, organic irritant, CNS depressant, deliriant. And the examples given are opioid, lead, cannabis and croton. Now you can see the metallic irritant is lead. Yes, very simple. Organic irritant is croton or croton. Yes. CNS depressant or any kind of depressant, that will be opioid. And deliriant is cannabis. Yes. So you can see it is A2, B4, C1 and D3. So here correct answer is option A, that is metallic irritant is, yes, metallic irritant is lead, the organic irritant is croton, the CNS depressant is opioid and deliriant poison is cannabis, okay. So anyways, if cocaine is given, that is also deliriant. We can remember the deliriant poison by cafe coffee day, that's a cocaine, cannabis and datura, cafe coffee day, these are deliriant poison. So we can remember by that trick also, very simple. Now a mother brings her daughter to the police station that the 30-year-old man has sexually abused. The mother claims her daughter is below 18, while the girl herself says she's 18-year-old, okay. Which of the following joint X-ray help for the age determination in this case? Okay, doesn't matter cocaine or cannabis, whatever it is, cocaine is also deliriant and cannabis also deliriant. And here the question is, what is the age estimation X-ray for 18 years of age? Here option given are elbow and shoulder, sternum and medial end of clavicle, wrist, medial end of clavicle and pelvis, and skull and sternum. My dear friends, here anyone who can give me the answer, which is the very important X-ray, that she is 18 or above 18? Yes, anyone? Yes. Is it long bones? Yes, 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 long bones. Yes, someone told B, sternum and medial. No, medial end of clavicle fuses at the 20 to 25 year of age. That is ruled out. Yes, that is ruled out. Medial end of clavicle. Sternum you can get. Wrist, medial end of clavicle and pelvis, option C. Yes. And skull and sternum. These options are okay? Tell me dear. These options are okay? Yes. Anyone? Yes. The best answer from these options, I'll go for elbow and shoulder. Elbow and shoulder. Now see, if you see the wrist, that is also okay. Okay, but the medial end of clavicle is not the right answer here. It is 20 to 25, it is fused. Okay, and pelvis is a broad term. We can't say like the pelvis is a single word, that there are so many things in the pelvis. So okay, so if you get the question answer here, medial end of clavicle is not required here. That fuses at the age. Yes, pelvis is okay. I am telling you, pelvis is okay and wrist is okay, but medial end of clavicle fuses at what age? It is 20 to 25 year of age. So there is no need for medial end of clavicle. So here, like we can go for elbow and shoulder. The first answer, the best answer is this one. And if you want to go further, the second answer will be this second one, this one. But why not D? The skull. Skull is a very broad term, my dear friend. There are so many sutures, and sternum has so many fusions. So we won't take the bone which is having so many fusions at different age. So the best answer you can go for elbow and sternum, and the second, if you want to pick, that answer will be C. Yes, shoulder is a broad, but we can take the upper end of humerus. Yes, upper end of humerus will be sufficient. That is 18. 18, 16, 18. So it is generally at 18 years, the 16 and 17 year, that will be 18 year. So we can easily take this one. So elbow, wrist, 18, 16, 16, 17 generally it is fused. So if it is not fused or if it is fused, it can be below 16 and 17. That's why the best answer will be elbow and shoulder. Yes, you can take. Now, according to the BNS, which of the following is not classified as a grievous set? Yes. Which of the following is not classified as a grievous set? Grievous set is 116 BNS. Yes. Yes, 116 BNS. Okay. Now, which is not classified as a grievous set? Pain lasting for 5 days, elbow dislocation, emasculation, fracture. Everyone knows dislocation and fracture are grievous set. Emasculation is a grievous set. Yes. Definitely. The pain lasting for 5 days, my dear friend, the pain lasting for 5 days. In grievous set, it is written, the severe pain for 15 days or more, that will be a grievous set. So here the answer goes the option A, which is not a grievous set, which is not a grievous set. Which of the following statement is incorrect? The cannabis causes less withdrawal symptom. Opioid withdrawal rarely leads to, the question asked is incorrect, which is incorrect. The opioid withdrawal rarely leads to mortality. Yes, opioid withdrawal can lead mortality. Opioid are used as a painkiller, everyone knows, like we have opioid as a painkiller. Alcohol at low doses causes stimulation and high doses it causes depression action. Very important, sir. So alcohol has two actions, the stimulation and depression both. So this is the correct one without any doubt. This is the correct one. Now the option which are left, option A and B, cannabis causes less withdrawal symptom. No, my dear friend. Here this is absolutely incorrect. The cannabis has many withdrawal symptoms, as we know the cannabis withdrawal. Okay, the opioid withdrawal rarely leads to mortality. It is not incorrect. The incorrect is what, my dear friend? Option A. Option A. Now, sir, which of the following notation system, we are coming to a very, very important topic, that is a dental formula, and we have many notations like Palmer notation, Hardrap method, universal method, or FDI method. And this I told you very, very importantly in the class. If it is written like right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant, if it is written 1 to 8, 1 to 8, 1 to 8, 1 to 8, this method is none other than Palmer notation. This is Palmer notation. If we write down 1 to 8, 1 to 8, 1 to 8, 1 to 8, it's a Palmer notation. If we write down plus for upper teeth and minus for lower teeth, it's a Hardrap. If we write down 1 to 16 and 17 to 32, that would be universal or Cunningham method. And if we add the number of quadrant as a 1, 2, 3, 4, it will be FDI. And if we add the number of quadrant as the 1, 2, 4, 3, it would be modified FDI. Anyways, it is Palmer notation. Yes. Now the triad, this is a very important question. The triad of abrasion, contusion and laceration is the most diagnostic of which of the following injury? Firearm injury, the bomb blast injury, the road traffic accident and the strangulation. My dear friend, this is a Marshall triad. This is a Marshall triad. What is Marshall triad? Marshall triad means the flying missiles hitting your body, the flying objects are hitting your body. That is a secondary blast injury, and these are seen in bomb blast injury. This is secondary blast injury. That is a Marshall triad. Yes. If it is a punctate laceration, okay, my dear friend, this is abrasion, contusion and punctate laceration. The answer will be, it's a bomb blast. We have 4 types of bomb blast injury. Number 1, the primary because of air compression, the secondary because of the flying missiles, the tertiary because you are falling over the ground, and the quaternary, the surrounding heat, burn or flame causes injury. That is a quaternary blast injury. So here answer is bomb blast injury. Now, so my dear friend, so this is all about for important, yes, the contusion is not mentioned or mentioned, doesn't matter, my dear friend. This is all about the few important questions which are asked in your today's INI CET exams, and only 2 questions which are controversial. Again, I am telling you, my dear friend, listen. The MTP consent, if the consent word is given, the age is 18 years. And if consent word is not given, that it could be like 16 or 18, because the minimum age for MTP, that could be 16, 14, because MTP can be done at any age. The second question is all about the age of 18 or below 18. You have two important controversy, because like we can remember shoulder, elbow and wrist. These are shoulder and this particular elbow is given, that and or shoulder or wrist is given. Wrist is right, elbow is right and shoulder is right for all, my dear friend. The only controversy is in C option. The medial end of clavicle is mentioned. That is fused. That is fused at the age of 20 to 25. Okay, my dear friend. So wish you all the best for your exam result, my dear friend. Good luck. Goodbye.
Hello guys, this is Dr. Jambukeswaran, Orthopedic faculty from Prepladder for you. Am I audible and visible? Can you please give me a thumbs up sign so that we can proceed? Hello? Hello sir, yeah, we got ortho questions today. Remembering anything now? Okay, right, excellent. Okay, yes sir, okay, right. Shall we start with the first question? See guys, totally we have 6 questions. I guarantee I will finish within 5 minutes. Okay. And one good thing is all the 6 questions already we have discussed. It is there in our video and in our notes. Very simple and straightforward. Okay. So we'll move on to the first question. According to World Health Organization, which of the following is the recommended diagnostic test for spinal tuberculosis? This was an asked question. 4 choices they had given. It is X-ray, CT scan, CB-NAT, culture and sensitivity. The classical textbook of skeletal tuberculosis. Okay, our SM Tully. We are the pioneers. Foreign books are not the pioneers. We are the pioneers. As Professor SM Tully's books very clearly says that the gold standard test for skeletal tuberculosis, including your spinal tuberculosis, is culture and sensitivity. Okay, so MRI is not given in the choice. MRI is not given in the choice. When MRI is given, the book says that, yes, culture and sensitivity. Yes, you are right. Vineet, Dayal, you are right. Culture sensitivity, you are right. Okay, yes. Okay, you see, the book says clinical plus MRI is a good investigation. Directly, you are taking a biopsy and doing culture and sensitivity in the classical selective medium. Your Jensen and Lowenstein-Jensen medium is the gold standard. That's the word in the textbook. So the right option should be culture and sensitivity. Okay, we will move on to the, is it according to WHO, not our textbooks? No. WHO, it is given in SM Tully. It's a textbook only. It's a textbook of orthopedics. Yes. We will move on to the next question. A patient presents after a fall. It takes time and delayed treatment if we do culture. Doesn't matter. Okay, your doubt is Sachin. Your doubt is that will it take some time? Yes, it will take at least 72 hours. Doesn't matter. Okay, so CB-NAT, see many questions, nurse world, many are asking a question, why not CB-NAT? CB-NAT is cartridge based nuclear amplification analysis test that is primarily for your pulmonary tuberculosis. It is not a very good investigation for skeletal tuberculosis. So I'll move on to the next thing. A patient presents after fall on outstretched hand. The X-ray is normal, but there is fullness in anatomical snuff box. What is the next best step in management? Hey, exactly the same thing I had given in our video. You just watch our video. In YouTube it is there. In our main recording video is there. In our notes is there. And this was a repeat question from previous year question paper. See, when you are clinically suspecting a scaphoid fracture, treat that as a scaphoid fracture. You are clinically, there is fullness and tenderness in the anatomical snuff box. Clinical test like your Watson's test is positive. You are clinically strongly suspecting a scaphoid fracture. You are taking an X-ray. X-ray clearly doesn't show the fracture. Consider that as a scaphoid fracture and put the patient on scaphoid cast, which is called Bowler gauntlet cast. It is there in our video and in our notes. Okay. So you just, after 2 weeks, repeat the X-ray, repeat the imaging. Definitely, if fracture is there, that will show you a healing fracture line. If it shows a healing fracture line, continue that for 6 to 8 weeks. Okay. Even after 2 weeks, it's proving negative. No harm in removing the cast and leave him free. Okay. So that is the right answer, choice C. We'll move on to many of you have answered. Congratulations, man. Vinit Dayal, you have answered. Harshit Sagar, iPad B. All of you have answered. Excellent, man. Good. We'll move on to the third question. A 10-year-old boy presents with pain and swelling around the right knee. For the past 2 weeks, there is no history of trauma. On examination, there is localized tenderness over the distal femur. No history of trauma. Okay. So this is a cold condition. It can be infection. It can be tumor. X-ray reveals sclerotic changes in the metaphyseal region. So this is very important. Some problem in the metaphysis suggests you have chronic osteomyelitis because they had mentioned something about sequestrum and involucrum. Okay. Laboratory investigation shows mild leukocytosis, elevated ESR. Which the twist here is, which of the following is the least expected organism? No question like this? Yes, there is a question like this because I got from 3 different sources. This question was not there. No, this question was there. What is the, yes. Okay, Lalit Yadav, you are telling there is no question like this. Okay, there was, because I got from 2 different sources. Is there. Yes, Anand Dasari is giving. This was there. The twist. See, guys, please focus now. Focus on this. Again, we are going to have on 19th. You focus on this. You see, the twist is usually they will ask you which is the most common organism. Most common organism of osteomyelitis, everyone knows it is Staphylococcus aureus. It is not in the choice. The twist is least expected causative organism. The Streptococcus pyogenes is an expected organism. Escherichia coli, which is an enterobacteriaceae, is an expected organism. Mycobacterium tuberculosis is a very much expected organism in our country. Klebsiella pneumoniae is the least expected, and that should be the answer. That should be the answer. Okay. If somebody has zest has given most, if it is most, if Staphylococcus aureus is not there, second best answer is Streptococci. Okay, second best answer is Streptococci. We'll move on to the next question. A patient presents with low backache. MRI reveals the characteristic Honda head sign. This is what students have fed me. MRI, usually MRI, it is not the investigation which shows Honda head sign. It should be your technetium 99 bone scan. Okay, I don't know whether they had given bone scan or not. I don't know, but that is from book. It should be the bone scan. Even if it's MRI, Honda head sign, directly the answer is bilateral sacral insufficiency fracture. Bilateral sacral insufficiency fracture happens in elderly individual because of osteoporosis. The main risk factor for bilateral sacral insufficiency fracture is osteoporosis. Second important predisposing factor is rheumatoid arthritis. Okay, so these 2 things. So directly the answer is your bilateral sacral insufficiency fracture. Yes, we'll move on to the next question. A 17-year-old boy presents with a progressively increasing swelling over the tibia along with fever. Radiological examination reveals something such as of Codman's triangle and sunburst appearance. What is the most likely diagnosis? Obviously, it is very straight. You see, if they had given Codman's triangle, many differential diagnoses are there. What is Codman's triangle? Elevation of the periosteum. Elevation of periosteum can happen in osteomyelitis, myositis ossificans, scurvy, osteosarcoma. But they had added sunburst appearance. The only diagnosis is osteogenic sarcoma. Straightforward answer. Okay, good. Yes. Okay, yes. Okay. Then comes the last question. A 78-year-old female sustained an intertrochanteric fracture. Which of the following is the best management, they had asked? Okay, boot and traction is not the best. It's an outdated old school of thought. Prosthetic replacement, they are meaning hemiarthroplasty or your totally replacement. This is also not wrong because this is for neck of femur fracture. Internal fixation with screw was a choice. Internal fixation to screw is a vague choice. they should have given dynamic hip screw. Then we may consider. But again, the word is best. Best management, whether it's a stable fracture or unstable fracture, the best management, the current treatment is proximal femoral nailing, PFN, proximal femoral nailing. So that should be the right answer. Guys, okay, yes, Labanya Lahiri has answered it. Yes, we have answered. And many have answered. Even they give dynamic hip screw. The best is proximal femoral nailing. I will vote for proximal femoral nailing. So that completes the ortho MCQs. And most of you from the response itself, I am seeing, guys. Okay, Sai Kumar, everyone has answered that. Okay, so from the response, I think you all have rocked. Okay, I love you guys. Okay, we'll stop this session at this level. Again, we'll meet for a detailed discussion if you want on 19th. That's day after tomorrow, 19th, 3 p.m. Okay, so until then, bye. Okay, so see, Akub Boss Bashir, you are asking why not hemiarthroplasty? Hemiarthroplasty is head sacrificing surgery. That is the best treatment for neck of femur fracture, not for intertrochanteric fracture. Not for intertrochanteric. The question asked is IT, intertrochanteric fracture. Should try to conserve the original head. Okay, because avascular necrosis is not a complication of intertrochanteric fracture. The intertrochanteric fracture, the complication is malunion, not non-union and avian. So that's the right answer. Okay, love you guys. Thank you so much. We'll meet again. Okay, bye-bye.
Hi guys, good to interact with you today. So let's get started. Just wanted to inform that we have our chat champions and 3 lucky winners on the screen. So do check out your names there. And I have with me Dr. Abhilash. He's from AIMS Delhi. Hi doctor, how are you?
Hello sir, I'm fine.
So what we will do is try and analyze the paper. Doctor, your feel regarding the paper while I'll just bring the questions on the screen. What is your take, since you've already been you have already gone through the, I would say that the fire.
Sir, this question seems more like factual question.
Yeah,
Either you know or you don't know.
Absolutely. But I think like you, since you've been through fire, like your overall take regarding the paper would be?
I think medicine was pretty difficult, sir.
Yeah, medicine was a little tricky, I would say. And some subjects, I think it's a mixed bag one, so I think we can get started. So the first one talks about the earliest presenting symptoms in a patient of multiple sclerosis. What I have explained in a routine video as well, and I would like to say that yes, the characteristic manifestation is obviously optic neuritis, but then at the same time, I mean, I agree that optic neuritis is an important thing, but the commonest manifestation is what I have explained is the sensory loss component. So what we need to figure out is if anybody has any comments with respect to change in the options, I would just wait for a few seconds while you can just comment the answer, please. Comment on any change in the options, and then subsequently, like I can go ahead, right, with marking the answer to this question. So yes, guys. Any comments with respect to the change in the options? Sensory disturbances, ataxia, vertigo and facial palsy. It did not mention optic neuritis. I understand that that's going to be the commonest manifestation, but that was not there. Okay, so I think Abhilash, we can go and mark the correct answer for this one. The correct answer is option number A, that would be sensory disturbances. And what we thought was, since we were having time at our disposal, we thought that we come out with some references as well. And though you can check out in the actual video, the same data has been discussed. So it was more of a one-liner, and it's just that, I think in this question, it was just that optic neuritis is not there. That is something that's going to shock everybody. Exactly. But yeah, I mean, because there are plaques in the cerebellum, so they can be ataxia, they can be vertigo, then cranial nerves can be involved. So it could be a facial palsy occurring in a patient as well. So I think we are sorted for this particular question, and let's move on to the next one. This again, Abhilash, your take on this question?
Same, sir. It is also a factual question.
Yeah. One liner. And I think the issue with this one is like, the commonest clinical manifestation during progression of SLE, because every time we read about SLE, photosensitivity is something that's always gonna come in our mind. I think you can also comment in the chat box, was it nephrotic syndrome or was it lupus nephritis? Because I personally think it will be lupus nephritis, but then lupus nephritis can result in development of nephrotic syndrome manifestations as well. But anyway, you can check out the data, you can check out from the main videos as well, that the main manifestation, like what I have said, and I'll repeat once again, is that the disease is characterized by musculoskeletal manifestations, right? It's gonna be muscle pain, joint pain, that's gonna be the initial profile of the patient. So it's a table from Harrison from where the data has been picked up. And as far as lupus nephritis is concerned, agreed that it is one of the common causes of mortality, but that would be something like 60% of cases. But overall, if you look at the data, yes, we do get multiple manifestations, but right on the top is going to be like the arthralgias and then subsequently the myalgias, and you can see a very close anemia component. I mean, it's going to be what's going to happen in this case is anemia of chronic disease. So I think we are sorted for this one also. If anybody has any comments with respect to change in options, yep, great. Most guys have got this one right also, so that's a great answer. Okay. Okay, nephrotic doc, lupus nephritis, no? Then like if I go back to the previous one, since yeah, I understand, doctor. Like most patients when they come to us, no, they'll already be suffering, right? So yeah, if he says complication, I'll think in terms of nephrotic syndrome, but it comes to manifestation, then we showed you the commonest manifestation that occurs would be musculoskeletal problems. Doctor, like yeah, I mean musculoskeletal is the one that we are commenting on. Okay, so pulse seen on Frank-Starling law, I can say like this, that with respect to Frank-Starling law, what's going to happen is in left ventricular failure, the left ventricle is going to contract relatively weak. So there would be a weak pulse. So more blood would be present in the left ventricle, the end diastolic volume will be more. And because end diastolic volume is more, the next beat of the heart is going to be more powerful. So the statement that I've said is alternatively weak pulse, strong pulse, weak pulse, strong pulse. That is what is technically called as pulsus alternans. So I think that is again an easy one to identify. I mean, the remaining options could be ruled out. Option A is for hypertrophic cardiomyopathy, pulsus paradoxus is for tamponade and constrictive pericarditis. And as far as pulsus parvus, I think it's written parvus only. I think it was complete parvus at tardus, as somebody commented earlier in my personal group. So I think it was for valvular aortic stenosis. So I think we can work out the data, and Dr. Pranjan, I think you can comment regarding what you think is the wrong language for the question. Otherwise, I think that most guys are agreeing to the data that we are saying. Okay. Mitral stenosis corresponds to which wave of the mitral stenosis corresponds to which wave? This is more of a conceptual question. Abhilash, your take on this one?
Sir, if we know that mitral stenosis causes end diastolic murmur, we can decipher the answer with
yes. So we all read about like mitral stenosis contributing to a mid diastolic murmur, and then it is associated with a pre-systolic accentuation. I mean, that is the data that we have. And basically when the heart is relaxing, then the atria will be contracting. So for this, the answer is not going to be ST segment or the T wave, because ST segment and T wave is where rather the heart would be contracting. So it's going to be like, the end of the T wave that I draw is always going to be the second heart sound. So this is going to be the P wave. In fact, the main thing is pre-systolic accentuation is a component. I'll just wait for a couple of seconds for your comments with respect to like if you feel that it was pre-systolic accentuation that was present. Bisvariance, Gagan, is a feature of hypertrophic cardiomyopathy. No? That is a feature where they would be like jerky pulse, right? Though it's for the previous question, but still I'll just quickly explain that. Pulsus bisvariance in Harrison is written as a jerky pulse because there's a left ventricular outflow tract obstruction. Frank-Starling law is when you stretch the heart contracts with more force. So as I said, logically weak pulse because the heart is contracting weaker, and then subsequently what's going to happen is that because more blood will remain behind in the cavity of the left ventricle, so the next beat will be relatively stronger. Yes, Abhilash, any right? I think
agree.
That standard statement right from physiology, Genong is where we have been reading regarding pulsus alternans. Okay. Okay, guys, fine. Yes, guys. So I think everybody could pick this up. Cool. I mean, I'm getting excellent answers for this one. That is the P wave. So great, man. You guys are doing a tremendous job. I mean, I did think that some people will fall for the trap of the examiner, as me and Abhilash were discussing. But I mean, you guys are brilliant chaps. So you've done a great job. Okay, let's move on to the next one. Okay. Yes. Okay. So this one is regarding septic shock. Patient is having a blood pressure of 58 by, I think there's some error with the values there, right? So I'll just correct that, right? I think this is gonna be 30 or diastolic is gonna be lesser. And then after receiving 3 liters of crystalloid, the mean arterial pressure still remains on the lower side. So I think there can be some discrepancy with respect to the mathematical values for this particular question. You guys can let me know. But yes, I mean, I'll say what I love to say, that the preferred vasopressor for patients who are going into cardiogenic shock and septic shock is NORAD. It's norepinephrine that is always used, and the reference is right in front of you. I mean, you have already given fluids to the patient. You can see the mathematical value there also. It got a little occluded, 65 with my marking, but if the mean arterial pressure in the question was 58, which is less than the threshold, then the next step for management would be norepinephrine, which would be given to this patient. So noradrenaline. Your take on this, like if you would have got a question like this, what would be your thought process? How would you solve it in 20 seconds?
Sir, it is ICU management question, so
okay,
the next step would be noradrenaline.
Okay. So I mean, this guy is a brilliant chap. I mean, to get rank 2 is not something very easy, but I mean, you make it so simple, right? I was sitting with you and discussing, so I think keeping things simple is of paramount importance, rather than making it hi-fi or trying to make it I would say rocket science. So that's what we strive for. Okay, fine. Let's move on to the next one. This, guys, again, we would like inputs from you guys. There was a fever, headache, vomiting, and a photophobia with neck rigidity and Brudzinski sign. So I understand that there was okay, hydrocortisone was there. Okay, doc, I'll take a note of that, the hydrocortisone part, but then for the main management of the patient, it's going to be noradrenaline also. Okay, 30 ml per kg of fluid was given. Agreed, doctor. That was 3 liters of fluid given. So we'll modify that in the subsequent part. When we publish the question in the app, we'll change that to 30 ml per kg. In fact, that is line to line from Harrison, right? The initial, like the snapshot that we showed you, that was showing 30 ml per kg initially. Okay, great. Okay, there is no fever, there is a sudden onset headache. So that is what we were debating, right? So let me just rule out, okay, fine, agreed, no fever present in this case, agreed, okay, fine, let me just strike that off. And then there's a headache, vomiting, photophobia with nuchal rigidity. Let me know regarding presentation of, no, it's not normal pressure hydrocephalus, guys. It is not normal pressure hydrocephalus. Okay, CSF examination was normal, fine. That's a good hint. If you say CSF is normal, then less likely to be a possibility of a bacterial meningitis. And see, even a hydrocephalus, okay, CT scan shows no hemorrhage. Okay, hydrocephalus is present, but there is no hemorrhage. Okay, so great. So we are arriving at a very good input, I would say, though I'll just squeeze that information there also. I'll show you a snapshot from Harrison, guys, for solving this question. We agree that the CT scan of the brain shows no hemorrhage, but there is evidence of hydrocephalus. There is no presence of fever. The CSF is normal, so that goes against the diagnosis of bacterial meningitis. Normal pressure hydrocephalus, everybody knows, right? Wet, wacky, and wobbly, so that is ruled out. Viral encephalitis will not have meningeal signs, so we are stuck between bacterial meningitis and subarachnoid hemorrhage. Now, if we don't have fever present, the CSF of a patient is normal, unlikely to be bacterial meningitis, and I know that the question in your mind would be, how the hell can it be subarachnoid hemorrhage? Then what I can say is, I'll just show you a reference for the same, like we did keep it just in case, right? In majority of cases of subarachnoid hemorrhage, you would be having is a presentation. In fact, he's a radiologist. He can give a better take on this. I mean, majority of cases, the CT scan is going to be having findings, but he says if the scan fails to establish the diagnosis, then subsequently lumbar puncture should be established in a patient. Lumbar puncture should be done in a patient. So considering the fact that if we go by the wordings that you were saying at the moment, where there is no, no fever present in a patient, without fever, like, having meningitis would be unlikely, and CSF findings again being normal is unlikely. Yeah, I agree that, in this particular case, ideally there should be presence of at least xanthochromic CSF, if not, RBCs in the CSF. So I would say like a widely debatable one, we can like go on and on about this question the whole day and not arrive at a diagnosis, right? The radiology person and me will keep on fighting regarding what could be the diagnosis. What's your take, Abhilash, regarding this? Finally, what should we go ahead with this one?
Sir, if there is no fever and there is a term sudden severe headache, subarachnoid hemorrhage will be more likely
as a possibility. Maybe the amount of blood loss would be relatively lesser, and that is why, like even Harrison says, 95% cases CT would be normal, but in the remaining cases, considering the fact, then it goes in favor of subarachnoid hemorrhage in a patient. So, okay guys, we will rephrase this question if required subsequently. Let's move on to the next one. A 58-year-old male with complaints of burning micturition. Prostatic examination is normal. Pus cells with sterile. I don't want to say the diagnosis. Culture is showing no growth. Abhilash, would you like to rule out the options for this one?
Yes, sir. Since there is no growth in the culture, we can rule out bacterial prostatitis. And for granulomatous prostatitis, to call it as granulomatous prostatitis, I think we would need a biopsy at least. And moreover, prostate examination was also normal. We would get a tender boggy prostate
and perineal pain, some kind of discomfort.
So all those options should be ruled out, and more likely answer, at least by ruling out, we can arrive at sterile pyuria, if not by diagnostic criteria.
Yes. So we'll go by option number D for this one. At the moment, the way it is framed. Moving to the next one, I think this was a long stem one, and the question presented with shortness of breath and a pedal edema in a hypertensive patient. You can see that the ejection fraction of the patient is 60%. There is a grade 2 diastolic malfunction. So the technical term for this would be a heart failure with preserved ejection fraction. And considering that if a person is having a preserved ejection fraction, there are only limited drugs that would be useful. Now, because my patient is having shortness of breath, I need to use at least diuretics in a patient. That is why, if I read perform coronary angiography to rule ischemic cardiomyopathy, this is not going to improve the condition. See, hypertension is the reason for the manifestation of this patient. So we need to control first the hypertension component. I think that would be the initial approach. And I think what pharma people love to say, and it's all over, you see that gliflozins are prescribed left, right and center for cardiorenal benefit. So I think even if I am not aware of the term preserved ejection fraction, reduced ejection fraction, if there's a question where I'm going to get a question on heart failure, gliflozins and SGLT2 inhibitors would be favored. Digoxin, guys, increases the oxygen consumption of the heart, so that is ruled out. Ivabradine is used for heart failure with reduced ejection fraction. It is only when the person is having a reduced ejection fraction that there would be a low cardiac output, there would be a compensatory tachycardia. So to conserve oxygen, I can be using ivabradine. So between A and B, a more logical sense here is treat the shortness of breath by giving diuretics and then use SGLT2 inhibitors for management of this patient, because he has himself written the word preserved ejection fraction. So this is what we would prefer at this particular point of time. This is a reference snapshot from Harrison. He has mentioned regarding ARNI, he has mentioned against SGLT2 inhibitors. So I think we are backing the data. Like he himself said, digoxin is ineffective, right? Or he's mentioned beta blockers to be ineffective. So if we back the theory with data, it becomes more logical and more rational to say the information. Okay, they love heart failure. They love heart failure. Okay, Dr. Abhilash, your take on this. How would a radiologist approach this question?
Sir, I would have ruled out the options and arrived at the right answer. Cardiac failure will cause congestive hepatomegaly, so it can lead to right hypochondrial pain. We all know cardiac failure causes initially PND and then progresses to orthopnea. So at last we'll arrive at non-pulsatile elevation.
Because non-pulsatile, because you see the standard is that non-pulsatile will always be a feature that is encountered in cardiac tamponade. I've explained this that every time you read non-pulsatile elevated JVP, it's either going to be superior vena cava thrombosis or it's going to be a cardiac tamponade. So I think we are sorted. We have a radiologist who's solving questions for us today. Great. Okay. I am really enjoying this collaboration, doctor. Okay. So a question based on spirometry, though it begins with a smoker. Let me just check out if you have something to say with respect to. Okay, let's move on with respect to the options for this one, right? Smoker presents with FeV1 FVC ratio of 65% and a RV TLC ratio of 141. RV is more, guys. RV more means like there's gonna be air trapping, and considering that he's a smoker, I think we have to think in terms of COPD. Even the FeV1 FVC ratio of the patient is turning out to be less than 0.7, so that goes in favor of obstructive airway disease. And considering that there is a air trapping present with RV, normal RV TLC ratio for those who would be interested in knowing is 120%. Here, because the value is 140, it's elevated. So considering that there is an increased residual volume, we need to go in for air trapping as the best answer for this one. And for the remaining options, what you can see is decreased lung compliance and all the stuff would be with respect to restrictive lung disease. Doc, any inputs you would like to share with respect to the current question?
I would have gotten it with increased residual volumes, and I would have thought of air trapping with that.
Okay, great. Okay, fine. Fine. We have a very interesting question. This one is like super intelligent. Parkinson disease patient presents with oropharyngeal dysphagia and recurrent episodes of aspiration pneumonia, and then there is a development of bronchiectasis. Now, when you listen to the discussion of bronchiectasis, there are two things that I've said. One is cystic fibrosis, and then is non-cystic fibrosis cases. You see, pneumonia is causing Parkinsonism is causing recurrent microaspirations, and that is the reason for development of bronchiectasis in this person. So I need to stop this oral feeding. So if you look at the options, high frequency chest wall oscillation therapy, that will just dislodge those secretions. It's not gonna help on a long-term management. It's not gonna, like I would say, it's not gonna treat the manifestations of a patient. So option number A is like, I would keep it as, okay, this may be the answer, it may not be the answer, like we can consider this. N-acetylcysteine is gonna be just thinning out the secretions, right? It's not gonna, because long-term management with N-acetylcysteine is like, we are not doing anything for the patient. So one option I'm ruling out here. Then is macrolide therapy. I think if you're thinking in terms of macrolide therapy, I've explained that for cystic fibrosis induced bronchiectasis, it is macrolide, so ciprofloxacin that should be given. But since this condition is non-cystic fibrosis based bronchiectasis, we need to go in for a PEG tube placement. That would be, we need to ensure that the feeding does not go the conventional way. We need to go in for placing a tube. That could be a gastrostomy or maybe even a jejunostomy in a patient. So we'll go the way the question is framed at the moment. We'll go with option number C for the best answer for this particular question. Any take Abhilash, yours for this one?
I would have gone with macrolide therapy, sir, since I did not know the distinction whether it could be used in cystic fibrosis, non-cystic fibrosis. So I would have gone with macrolide.
Okay. Fine. I get your point. Okay. The next one is doc, long term. Macrolide and prokinetic is another option. Okay, doc, we'll do that. Okay. Doc, less likely, no? We need to reduce the chances, right? We need to reduce the chances of that. So aspiration pneumonia would be higher if I'm directly feeding a patient as compared to going out, because there's still a lower esophageal sphincter present. That is some barrier, right? I mean, the sphincter is going to be acting as some barrier to prevent the chances here. So I agree that macrolides are the ones which we are reading about cystic fibrosis, but this would be a non-cystic fibrosis based case. Okay, so they love diabetes, they love septic shock. Another one up here, I think the pharmacologist would have talked about it. The most appropriate antibiotic for management of this patient would be meropenem, right? Okay. Oh, another interesting. I think they were after sepsis and they were after intensive care management. Though the situation is of a ventilator-associated pneumonia after cardiac surgery, and then serum procalcitonin is sent, he says which of the following regarding procalcitonin is correct. Now, procalcitonin, guys, is a test which would not be diagnostic of infection, but at the same time, if you are going to monitor procalcitonin levels in any patient in intensive care unit, if the level is falling, that means that a patient is responding to treatment. So it is not going to help you with the choice of antibiotics. It will not help you determine the source, because we know the source, right? It's already a ventilator-associated pneumonia. It does not differentiate bacterial from a fungal case. Procalcitonin, all it does is it tells you whether patient is responding to your treatment or not. And it helps us decide the duration of antibiotic therapy. We do have a reference from Harrison. Doc, if you can just shift that slide, I can just bring that to focus. Yes. So the standard line from Harrison says this fact that it is used for de-escalation of therapy. But what it basically means is that it would help you decide whether you need to continue with the antibiotics or whether you need to discontinue the antibiotics in any patient who's been admitted in a hospital with septic shock. So I think there were 3 questions based on sepsis and septic shock. Okay. My God. Okay. Then is multiple sclerosis. Okay, so there are 2 questions on multiple sclerosis. Again, a very interesting one. He says, which of the following statements is incorrect, right? So majority patients will develop optic neuritis during the course of illness. Makes sense. I mean, that's a pretty logical statement. Oral steroids for acute relapses, I know you will say that IV are given, but we can give IV also and we can give oral also. And the references again from Harrison, he says that any of the 2 can be used, even the oral steroids can be given. Guys, this is not the answer to this question. If you can just erase this, yeah. Okay. I'll just go back to the previous one. Yeah. Just a sec. Okay. So the statement number A is correct one, guys. Patient is having optic neuritis, majority of patients. IV steroids are yes preferred, but then oral can also be given in a patient. Fundus is normal because this is retrobulbar neuritis, man. Retrobulbar neuritis is behind the eyeball of a patient. So fundus has to be normal in a case of multiple sclerosis. There may be evidence of papillitis because the optic nerve inflammation is present. But I think optic neuritis is like retrobulbar involvement. So that is why the fundus is normal. So 2 statements I think we can rule out immediately between the 2. Now, can I give oral steroids or not? The reference of Harrison is very much there. Let's read C. Abhilash, your take on this one, option number C there. Color perception, depth perception is proportional to visual loss.
Loss of color perception and depth perception can occur even in the patients who doesn't have loss in visual acuity.
If you listen to me speaking here, I have said that patient is telling you that I am not able to see the color of my dress. But as such, I mean, otherwise her vision is fine. So visual acuity can be normal in a patient, but at the same time, the color vision of a patient and the depth perception can be compromised. So there is a disparity between the 2. Here it is written that this is proportional to the visual loss. This is not the case, guys. So we'll go by option number C for the current question. It will be option number C here. Okay, fine. Can be
erase.
Yeah, erase. Yeah, and fine.
I think we skipped a question.
Yeah, we just skip a question. Okay. Okay, a 58-year-old male presents to the PHC for a routine checkup. The blood pressure of the patient is 2 times elevated. I mean, the cutoff for hypertension, guys, you know, is already revised by American Heart Association. And though there is no comorbidity in a patient, these values are substantially high. So we have to treat the patient. Just quickly, let me know. Okay, the age group of the patient is 45 years. Okay, Kinogarde. Okay, fine, doctor. I'll take that. We have to treat this, guys. I can say like this. I would not be giving IV antihypertensive therapy, and I'll not be referring this patient for a further evaluation since there is no comorbidities present. So I think C and D can be ruled out. We're left between only 2. I mean, if I wait for treatment to be started, there is gonna be left ventricular hypertrophy. So I agree that the age was on the lower side. Then preferably we would have given AC inhibitors in a patient. But in real clinical practice, you will notice that sometimes we might be using 2 drugs, that could be calcium channel blockers and ACE inhibitors as well. So considering that the way the question is framed, I think we'll go by option number B for management of this patient. That is, at least treat the guy. I mean, he needs management of hypertension because there are 2 separate independent readings where both systolic and diastolic blood pressure of the patient is elevated. C and D were ruled out. I'll say that again, quick 15 seconds, because I mean, one is extreme intervention, second one is no intervention. The best we can do is just refer. So we would like to intervene, right? So yes, guys, we'll go with option number B for this one. And then is a patient with seizures who presented who is on 2 drugs, right? Carbamazepine and erythromycin. Doc, your take on this question? I think there is a side effect that's coming up because of the drug interaction. So if you guys can quickly comment regarding option number D for this question, if we know there could be some twist. Otherwise, we'll come up with the answer. Okay. Yes, guys. I think we'll go by Doc. Your take on this? Any interactions you want to comment on?
We all know that erythromycin inhibits the CYP3A4 inhibitor, CYP3A4 enzyme, which metabolizes the carbamazepine.
Yes.
Because of that, there can be carbamazepine toxicity, which in turn can lead to ataxia, which is a well-known side effect.
Yeah, well-known side effect. So I think we move on to, I think this is a surgery one, but anyway, Muir-Barclay formula is basically for burns, right? And in burns, the best colloid that we'll be using is albumin for the patient. So answer for this question would be option number D. This I remember from my Bayesian love in my undergraduate days. So I think now, I don't think so. Now they don't talk about Muir and Barclay, they talk only about the Parkland formula. So I think this is from the older version of the book, Bayesian love, that they might have picked it up, because I don't think so that the current version of Bailey mentions about it. Okay, so yes, I think we are sorted for the discussion for today. Okay, we have one more. Okay, this one, guys, we do not have any clues regarding the language of the question. So if you can just help us out there. Somebody commented about option number A, packed RBCs. Doc, doesn't matter, right? I mean, if you are gonna be having colloids, and then for colloids you will have to use albumin in the patient. Okay, so if you can comment about the last one that we have here, RA Tejas, if you can quickly, medulloblastoma. Okay, that is, okay, my handwriting today is going haywire. So anyway, I'll take that at meningioma. Okay. Doc, as far as I know that for stomach cancer, I mean, it's mainly gonna be, for all others people can be fat, but for stomach cancer I think it would be, but still I think we need more credible references for this one, and we need to also figure out meningioma versus the medulloblastoma part. So this one, guys, I'll not comment on the question at the moment, and I would not personally have answered. Would you have answered it, Avilash?
No, sir, no, definitely not.
Okay, so I mean, like, in your opinion, how many questions should be attempted in this paper, since you went through the entire thing today?
Sir, around 190 will be a safe bet.
Safe bet, right. And in your time, how many did you attempt?
I attended around 192, 93.
193. Okay, but the strike rate of yours was super high, right?
Yes.
And how many corrects in yours?
Mine was 163, if I'm not wrong.
Okay. Tremendous, man, tremendous. You are appearing so humble, so nice, and I mean, you're making it too light of the achievements that you had. But anyway, man, it was really nice, fun interacting with you, and I mean, these guys gave us an opportunity to do this collab. So I think we are sorted for the questions at our disposal. Yep, I think, yes. Right, so what we do is, right, okay, yeah, fine, okay, thank you. That question was lost.
A very good evening, everyone here. Dr. Azam here, your faculty of anatomy at Prepladder, and I hope your exam is done. And now we are going to do the paper analysis of INI CET May 2025. And now we are going to start with the anatomy questions which are asked in your exam. Now, which of the following is not a boundary of hepatocystic triangle? This is like one of the questions which has been asked previously also. Now, in the hepatocystic triangle, if you're observing here, it is between the common hepatic duct over here, and then the cystic duct over here, as well as the inferior border of the liver. So if you look at this option here, the hepatocystic triangle, yes, what are the boundaries of this one? Cystic duct, common hepatic duct, and the inferior border of the liver, but not the cystic artery. And that was the question asked here, not a boundary. So the answer here will be the cystic artery here, guys. Okay. Moving on to the question number 2 here, which of the following muscle is or are supplied by the superficial fibular nerve? We have learned this in the lower limb very clearly. Wherever you're going to get the word as fibular, nothing but your peroneal nerve. So basically they're asking you which muscles are supplied by superficial peroneal nerve. Now, I told you many a times in the upper limb and the lower limb, our golden rule to remember with the help of compartments. Now, when you study in the leg region, there'll be like 3 compartments. One is the anterior compartment, another one is the posterior compartment, and then you'll be having the lateral compartment. And lateral compartment of the leg will be supplied by superficial peroneal nerve. Superficial peroneal nerve. And we know very well in the lateral compartment of the leg, you'll be having 2 muscles, peroneus longus and the peroneus brevis. Extensor digitorum longus, no, this is not present in the lateral compartment. That will be present in the anterior compartment, which is supplied by deep peroneal nerve. And then tibialis anterior is also present in the anterior compartment, and that is also supplied by deep peroneal nerve. So superficial peroneal nerve will be supplying to these 2 muscles present in the lateral compartment of the leg, that is peroneus longus and the peroneus brevis. Fine. Some of the options the students are telling here is peroneus tertius is also given. Please remember, peroneus tertius is also present in the anterior compartment only. It is supplied by deep peroneal nerve. Fine. Fine. Now moving ahead with the next one. Yes, what is the primary action of the muscle originating from this structure? My dear friends, I'm telling you, muscles of mastication is one such topic which is definitely asked in the INI CET exam. They won't get tired of asking the questions on muscles of mastication. And now it has to be declared like copyright of the INI CET there. Muscles of mastication, definitely the question will be coming from there all the time. And yes, of course, this time also they have asked. In the exam, what I got to know is there was an image given here. And in this image, this mandible was not given there. And only the skull image was given. And the arrow mark was actually on the pterygoid plate, onto the lateral pterygoid plate. Now, on the lateral pterygoid plate, we know that from the lateral surface of that one, lateral pterygoid muscle is going to get originated from there. Now, if the lateral pterygoid muscle is beginning from there, now what is the action of that one? So please remember, lateral pterygoid muscle is actually going to help in, number 1, protraction as well as the depression of the mandible. Protraction as well as depression of the mandible. Lateral pterygoid will help in this one. And we have learned that with the mnemonic also, L for lateral pterygoid and L for lowering the jaw. It is helping in opening the jaw, lowering the jaw. Fine. Now these 2 options, fine. But one thing, what I got the feedback from the students is that the options were not given as coupled here like this, like protraction and depression, elevation and protrusion, not like that. Individual options were given. Now, lateral pterygoid muscle has got both the things, like protraction as well as depression. If individual options are given, please go for depression of the mandible. Depression of the mandible is more better answer when compared to the protrusion, guys. So yes, of course, Dr. Sheikh, of course, Dr. Nil, Doctor, yes. Separate options were given, then you can actually mark depression. That is the right answer. Fine. Because lateral pterygoid muscle is the only muscle helping in the depression of the mandible. Fine. After this one, the next thing, which of the following muscles are supplied by deep branch of the ulnar nerve? This is another favorite area or the part from where the INI CET examiner will always question you. That is about the nerves, ulnar nerve, median nerve and radial nerve. Definitely one question will come from here. Now ulnar nerve, when it is entering from the forearm into the hand, it is going to pass superficial to the flexor retinaculum. Ulnar upar, ye upar se pass hota hai, superficial to flexor retinaculum. Now after entering the hand, it is dividing into superficial branch and deep branch. Superficial branch will be just supplying to one muscle here, that is palmaris brevis muscle. Palmaris brevis muscle, and that is just a subcutaneous muscle. And the superficial branch is also supplied to the skin, covering the 1.5 digits on the medial side. We know that. Remaining everything else will be taken care by the deep branch. So deep branch will be supplying to the 4th lumbrical. Of course, the 3rd and 4th lumbrical in the hand is supplied by ulnar nerve. Dorsal interossei, all the interossei are supplied by ulnar nerve only. Adductor digiti minima, yes, of course, one of the hypothenar muscle that is also supplied by ulnar nerve. Now, the question here is, flexor carpi ulnaris is also supplied by ulnar nerve, but remember, it's not in the hand. It's not by deep branch. Yes, it is actually in the forearm. Okay. So which of the following muscle are supplied by the deep branch of the ulnar nerve? Yes, multiple correct answer. A, B, C, all of them are supplied by deep branch, except for which one here? Flexor carpi ulnaris. Flexor carpi ulnaris. Fine. Opponent's digiti minima is also given there. Of course, no problem. You can actually tell me the options which were given there in the exam. If you are able to recall that one, I will actually include them, and we are of course going to come up with a separate recall session. This is just a quick analysis of the paper over here. Fine. Dr. Shipra, I got wrong. This is a simple question over here. I think we have learned this n number of times. Next one. A 40-year-old man presents with a history of fishbone impaction in his throat. He complains of discomfort and difficulty in swallowing, but there is no difficulty in breathing and phonation. On examination, the foreign body is suspected to be lodged in the pyriform fossa. Pyriform fossa. It's a direct question now. The moment you see this word here, pyriform fossa, I hope you have learned this in the ENT also. Which of the following nerve is primarily responsible for sensory innervation of the affected area? Of course, it will be internal laryngeal nerve. And internal laryngeal nerve, here the option internal branch of course, it is a branch of which one here? The superior laryngeal nerve, guys. Okay. Next one. What is the primary action of this muscle attached to the area marked here? Now observe this diagram very carefully. In this diagram, it is sacrum here. And in this area marked here, the muscle that will be attached here will be the piriformis muscle. Piriformis muscle will be attached here onto the sacrum. Fine. Now, what is the action done by the piriformis muscle? It is actually helping in lateral rotation of the thigh. It is going to rotate the thigh laterally. Number one action. Fine. Now, here it is given as internal rotation of the thigh. So this is gone here. And this piriformis will not at all be helping in the extension and flexion of the knee. It has nothing to do with the knee joint actually. Fine. It is present near in the pelvic region, in the hip region there. So it has nothing to do with the knee there. Now, in the recall session, I'll show you with the screenshot from the Gray's Anatomy also. In the Gray's Anatomy, I'm telling you the exact words as they are given. Piriformis muscle is helping in lateral rotation of the thigh. Along with that, it will also help in the abduction of flexed thigh. Abduction of flexed thigh. So from there, we can mark this answer as the correct answer. So piriformis, you can remember two functions: lateral rotation of the thigh as well as abduction of the flexed thigh. Fine. Yeah, Dr. Kavisha Agarwal, tibialis anterior is not in the question. Fine, noted that one. I'll come up with a neat and clean recall session with all the wrong things removed from there and the right things included in that one. Fine. So Dr. Zuko, I told you the right answer. Exactly as the words are given in 42nd edition of Gray's Anatomy, I told you. So according to that, we can answer here. Piriformis, I repeat again, it will be helping in lateral rotation of the thigh as well as it will be helping in the abduction of flexed thigh. Abduction of flexed thigh. Fine. Which of the following nerve is not involved in the sense of olfaction? Now this type of questions, I think the moment you look at this question, you'll be like a little bit confused over here. Yes, which is not involved in the olfaction. So you need to go for these type of questions, before your INI CET exam or NEET PG exam, many times, many faculties will be coming up with the ideas like how to solve the question. One of the way how to solve the question is by elimination method. You need to eliminate here. Fine. If you observe here, out of all the four options, my dear friend, hypoglossal nerve is actually purely motor nerve. Purely motor, it is supplying to the muscles of tongue. All the muscles of tongue except the palatoglossus, we know that very well. So if it is like purely motor nerve, yes, of course, it cannot have that sensory function at all. It cannot have that one. So that should be the right answer here, according to me. Now, apart from that, if you're going to discuss the remaining options here, olfactory nerve, yes, of course, it will be involved in the sense of olfaction. Primarily, it is involved there. Vagus nerve, it is also a bit involved, but not directly. Indirectly, it is involved actually. Okay, now when like there will be some irritation over here in the nasal mucosa, like for the olfaction, whenever there'll be like irritation, all via reflexes indirectly, it will be involved there. Fine. And ninth nerve, as such, there is no role. But out of the options which are given here, the best option that you can select is the 12th nerve. 12th nerve is actually the purely motor nerve over there. Fine. Okay, fine. You can let me know the options. I'll be including that one. Fine. These are the options that I've got here. According to these options, 12th nerve, for sure, it is not involved in the sense of olfaction, my dear friends. Moving ahead, I think this is like a repeat question. It was also given in one of the PG exams before also. Identify the part of the respiratory tract based on the image given below. Now, for your reference, what I have done here is I have given you the exact similar image over here. This here is actually the continuation, my dear friend. You can clearly see this is the terminal bronchiole here. And that is going to continue into the respiratory bronchiole. And further, those respiratory bronchioles are going to continue into the alveolar duct and the alveoli. So therefore, the moment you look at this image here, yes, it is the terminal bronchiole and the respiratory bronchiole over here. But now in this question, identify the part of the respiratory tract based on the image given below. In this, the arrow mark, I was actually waiting for this one here. arrow mark here, my dear friend. Can anyone tell me where was the arrow mark mentioned? Was the arrow mark given here or the arrow mark given here? So according to that, you can actually mark the answer here. Yes? Respiratory bronchiole. Okay, Dr. Vidhi Shetty is telling respiratory bronchiole. The arrow mark was given over here. So fine, we'll go ahead with this answer of respiratory bronchiole over here. Perfect. Okay. Fine, fine, fine. Now the next one, my dear friends. Yes, that is the reason why I'm showing you the comparative image here, exactly the comparative image, so that you can easily mark the option over there, whatever arrow mark was given over there, guys. Okay. Next one, match the following. Now please look at this image here. I was actually informed that there was a cadaveric image given from the male reproductive system. There was a cadaveric image given. Okay, pseudo stratified lining with cilia. No cilia was there. Okay, okay, fine. Fine, fine. We'll look into that one. Now, this cadaveric image was given. This is something interesting over here. The image was tough. Yes, yes, yes. Sir, इससे भी गंदा वाला diagram था. Okay, okay. You can actually share the diagram with me, the image with me, whatever you have come across, whatever the worst that you have come across. Triangle shape image was given. Okay, fine. So in this image, actually what happens here, the urinary bladder, then below the urinary bladder here, the prostate gland. So A here will be actually the prostate gland here, my dear friend. And then above there, there will be urinary bladder. So going into the urinary bladder, the B here will be the ureter here. And then C here will be the vas deferens there, and the D will be the seminal vesicle. This is how you can actually match this image. Okay. If some other cadaveric image is given, please DM me, send me that image. If you can find a relatively close image to that one, then we'll add into the recall session, my dear friends. Okay. Worst of the worst image was given, Sam saying. Shruti Chaurasia, thank you, thank you. Dr. Amit Kumar is saying terrifying image was given. Fine, no problem. So there was a question based on like match the following there, giving the male reproductive system structures. So prostate gland, the seminal vesicle, vas deferens, and ureter, these were given there. Fine. Now moving ahead with the next question here, the pain derived from the structure from dura mater indicated by the arrow is referred to what? See, in this diagram, the arrow mark that is shown here is actually your posterior cranial fossa, the posterior cranial fossa. Now, in the posterior cranial fossa, the dura mater over there will be supplied by what there? It will be supplied by the cervical nerves, upper cervical nerves, C1, C2, and C3. Upper cervical nerves, C1, C2, and C3. Now, from that same nerves will be actually also supplied to the skin covering the occiput, skin covering the occipital region over here. Fine. And this is one of the classical examples of your referred pain, my dear friends. So therefore, the pain derived from the structure, which is supplying to this dura mater in the posterior cranial fossa, will be supplying to the skin covering the occipital region over there. So that will be referred to the back of the head. This should be the right answer. I hope you have marked the same answer over there. Okay. I repeat again, the dura mater, the dura mater here will be supplied by the upper cervical nerve, that is your C1, C2, and C3. C1, C2, and C3, and that will also be supplied to the skin over the occipital region over there. And that is why, remember, it is one of the classical examples of your referred pain, and that pain will be actually referred to the back of the head here, my dear friends. Didn't get time to answer this one. Thank God it's true. That's really nice. So by this, my dear doctors, we are done with all these recall questions from here. Anatomy questions were like relatively easier. As usual, INI CET examiner. As usual, the important questions or the important previous year topics has been given there, muscles of mastication and the ulnar nerve and all. So thank God this time, whatever hard work we have done, that is paid off, my dear friend. So that is all about the recall questions of the anatomy. I hope this is done. If you're able to recall any more questions in options or some images that has to be corrected, please let me know, drop me a message and I'll try to include them in the recall session here. Okay. So thank you all the best for your results.
Hello student, very good evening to all of you. So I hope the INI CET exam went well for all of you, and I wish you all the best for your result. Now today here I am going to discuss the MCQ that has been asked in physiology. So we are not going to discuss the detailed version of the explanation. We are only going to discuss the answer of the MCQ, and I'll keep my session as brief as possible. Now, if you look at the total number of questions in physiology this time, they have asked total number of 8 questions, and if you look at the questions, most of the questions are stereotype question, means either they are the repeat questions or they are from the core topic of the physiology. So when I will discuss the question, you will understand that the questions which has been asked in physiology was very easy, mainly they are the repeat questions or they have been asked from the core topic. So now, without wasting much of the time, we are going to discuss the questions directly. So the first question, the question has been repeated multiple times in INI CET, and this is a signature question of the INI CET, the calculation of the tetanizing frequency. So whenever the question is about the tetanizing frequency, we all know that you have to divide this 1000, that is 1 upon the contraction period. So the contraction period that has been given here is a 40. So if you divide the 1000 upon 40, so answer will be C. So answer of this question is C. So I believe you should not have any problem in this questions, because the question is directly asking about the tetanizing frequency, and you have learned this tetanizing frequency calculation 1 upon contraction period, right? So this is the first question. Second question. So this is a question which is, you can say, new question, but this is from again the core topic of the physiology. We read about the cell to cell interaction, cell to cell junctions. So this question about the cell to cell junctions, and they have asked about the tight junctions. So I told in my classes repeatedly that the tight junctions is the most apical most portion of the cells junctions, right? So answer of this question will be apical. There is a little bit controversy here that apicolateral, but even the apicolateral is not going to be the answer. The answer will be apical, because the tight junctions is present in the apical most portion of the cell, and if you look at Genong, the apical is the best choice in this question. So answer will be apical question, no such question, okay? So if you recall the other option or maybe the correct question, you can tell me, so we can discuss later on apical, right? Next question we are going here. So which of the following brain region is primarily associated with the processing of the explicit memory? So again, repeat question, or you can say a core topic of the physiology, the explicit memory or the declarative memory or the implicit memory. This has been asked in INI CET multiple times. So again, I believe you should not miss this question. Whenever we describe the explicit memory or the declarative memory, we say that this is the memory which is processed at the level of hippocampus and the medial temporal lobe. So best answer of these questions will be hippocampus, although some role of the prefrontal cortex is also there, but if you have to choose only single best answer, then hippocampus was the answer. Even if the thalamus is only the option, even if the cerebellum is in the option, they are not going to be your answer, because by definition explicit memory or the declarative memory, they are processed at the level of hippocampus, the conscious processing at the level of hippocampus. This is the line, this is the language which is given in the book. So answer of this question is hippocampus without any confusion. Next question, if you look at IGF-1 and IGF-2, that is the insulin like growth factor 1 and growth factor 2 are structurally most similar to which of the following? So whether this question is they are structurally most similar to, or whether the question is about the IGF-1 and IGF-2 receptor are structurally similar, in both of this question the answer will be, what will be the answer? The answer will be insulin, because we all know that the receptor of insulin, IGF-1, IGF-2, they have the similar kind of feature, and this structure of even the IGF and IGF-2 will be similar to the insulin. So insulin, option number A is the answer of this question, right? There is a question, okay, so you can send me this question later on if you remember Sadhara question. So this is insulin, pretty simple question, so you have marked correctly, I believe. Now again, so look at this question, which of the following is a feature of Bejol-Jeris reflex? So how many times this Bejol-Jeris reflex has been asked in physiology INI CET? Multiple times, okay? And most of the cases, you know, you have to differentiate between Bejol-Jeris reflex and Bain-Beach reflex. So this is a common question, repeat question in INI CET, and we all know that the Bejol-Jeris reflex, the feature is severe bradycardia will be there, severe hypotension will be there, along with that coronary vasodilation and hypoventilation followed by apnea, okay, apnea followed by hypoventilation will be there. So even this hypoapnea or apnea will also be the feature. So A, B, C all are correct about this Bejol-Jeris reflex. Tachycardia is not seen, so generally this is seen in the Bain-Beach reflex, you know, I feel you will be able to recall that. So A, B, C all are correct, so A, B, C are correct, so answer will be the option number A. So again the repeat question, I think you have marked it correctly, yes, okay. So now the next question. Next question, which of the following is an example of feed-forward mechanism? So again, the feed-forward mechanism is a pet question of INI CET in physiology, right? And in my classes also I have given multiple examples that the heart rate increment before the starting of the exercise. So if these are the correct, if all these options are the correct according to you, or if you recall some other options, because some of the students are saying that exercise was also in this option. So please try to recall. If you recall correctly, please give me the options. Otherwise, if these are the exact option, so vasoconstriction in response to cooling. So this is a feedback kind of response, right? Increase in heart rate on standing from supine position. Sometimes you may make mistake here that increase in heart rate even before the start of exercise is a feed forward example. But increase in heart rate on standing from supine position, this is not a feed forward, this is a feedback kind of system. Increase in cardiac output in response to anemia, this is also a kind of feedback input, right? So only option that is correct here is the temperature regulation or thermoregulation. In my class I repeatedly told you that thermoregulation has both feedback and feed forward control system. So the feed forward control system is that even before the dropping of your core body temperature, the thermoregulatory system try to increase your body temperature, and that is a typical example of the feed forward control system. So if thermoregulation was given in the choices, then it will be the answer. But some of the students are saying that rather than this thermoregulation, the exercise was also given in the choices. So exercise, the heart rate increment even before the start of the exercise, that can also be an example of feed forward control system. But if these are the options, then I'll go for the last option, that is the thermoregulation, that is the feed forward control system. Now we are coming to the next question. So this is the next question, which of the following is not a mechanism of action of antidiuretic hormone? So this is a little bit tricky questions, and you can say this is a little new type of question in INI CET. So ADH, we all know that this is responsible for the absorption of the water from the collecting duct. So increase water permeability in the collecting duct, this is a function of the ADH, right? So this is true, okay? And increase absorption of urea in the medullary collecting duct, this is also a true option for ADH. So these two are the actions of the ADH, there is a known action, right? But if you look at the option number B and option C, both of them are not the action of the ADH. So the option B, increase absorption of urea in the descending limb of loop of Henle. There is no absorption of urea in the descending limb of loop of Henle. There is a little bit secretion of the urea in the descending limb of loop of Henle. So it is not true statement. And option number C also, decrease absorption of NaCl in the ascending limb of loop of Henle. So again this NaCl absorption is also not a feature of the ADH. So if these are the exact question, anybody, could you recall the options that where both B and C option were there in the question? If you are able to recall, please give me, because otherwise in my choice I will go that B and C both are not the actions of the ADH. But even if I have to choose between B and C, I will go for this C option, because initial reabsorption is never a feature of the ADH, right? You know, initial reabsorption is a feature of the aldosterone hormone, but not for the ADH. So this is an action of, option A is an action of ADH, option D is an action of ADH, there is no confusion in that. And B and C, both of them are not the functions or actions of the ADH, but if I have to choose only one, then I will go for the option number C. So descending limb of loop of Henle, water reabsorption. No, again that is also not correct. C was not in the question. Okay. Okay. So I believe C was a different kind of choice. So not decrease initial, increase, even if the increase in initial reabsorption also, that is also not a feature of the ADH, because initial reabsorption is increased by aldosterone but not by the ADH. So between B and C will be the answer. But you have to recall correctly. But for the time being, I am choosing that initial is not an action of the ADH, so option C will be the correct answer, okay? And now we are going for the next question. So this is basically a question of mixture of the physiology and medicine, okay? So which of the following best explain the development of hyponatremia in a hypovolemic patient with diarrhea, right? So we know that a patient who is suffering from diarrhea, the hypovolemic hyponatremia is a feature, okay? We know that. And what is the cause? Cause is that in case of diarrhea, the hypovolemic hyponatremia, the severe neurohormonal activation occurs, because of which the ADH level increases in the blood. and ADH absorb water from the kidney. So whenever there is a diarrhea, the volume will be decreased, and that decrease and the volume will increase the ADH secretion. That ADH will reabsorb water from the kidney. So what will happen? The sodium loss will be there and water loss will also be there in the body, but there will be lesser water loss in comparison to the sodium loss, because of which there will be hyponatremia. So if I have to choose only one option from this, then I'll go for the option number C, that is the non-osmotic release of antidiuretic hormone from the hypothalamus, and that will causes the hypovolemic hyponatremia in case of severe dehydration. So I believe this was the option. Again, I am requesting you, please try to recall this option correctly, particularly the last two questions, because these are the two new questions. Otherwise all the questions were the repeat questions and the question from the core topic. So this is all from my side. I believe these are the questions which was asked in the physiology. Okay. So if you could recall other questions or other any options which are not correct, so please let me know. I'll correct the options. Okay. So anything else? So thank you so much.
Hi everyone. Am I audible and visible now? Yes. So how has the exam been? I know you're all anxious, right? You're all anxious to know how others have felt about the exam. And so let me start with what I've observed from students. Okay, so I conducted a poll among my students, asking them how they felt about the paper. So the first question to them was, how did you feel about the paper? Was the paper moderate, difficult, or easy? And as you can see here, yeah, good evening, Hasna. As you can see here, 66% of the students said that the question paper was moderate. So you have got all your questions right? Great. So many of them have told that the paper is moderate, and I also feel that the question paper was moderate. Some of them have felt that the paper is difficult, probably because there is always a twist in all INI CET paper, right? In every INI CET question, there is always a twist, and every choice can be asked as an MCQ. That's the only difference between what you can expect in NEET PG and what you can expect in INI CET paper. So generally, the question paper was moderate. And then the next question to them was, how many repeat questions did you see? And 48% of students said that the repeat was less, and 29% said that that was average repeat, and 23% said that there were more repeats. And what is my verdict on this, right? So because I've been seeing MCQs on all subjects since morning. So I would say my verdict is yes, the exact repeat was not observed, but repeat topics were observed. There were many topics which were asked as repeat topics this time. Okay, so yes, there were repeat questions. And my third question to them was about specifically biochemistry. Repeats are present in biochem, right? Yes. So my question was, how did you feel about the biochemistry part of the question? And 55% of them said it is moderate. And what is my verdict on this? Yes, biochemistry questions were also moderate, because as I said, most of the topics were repeat questions. There was only one question which I would call as a twist. Yeah, when I say twist, this has never been asked before. And if you ask me as students, are you expected to know that question? I would say no. And even if you had not answered that question, will your rank be affected? Your rank will not be affected. So we call it as a curve ball, right? So one of the MCQs was a curve ball, and that was about a graph. Right, so the graph showed about the time along x-axis, and then resonance response along y-axis. That graph you're not expected to know. Even if you did not answer that question correctly, please take it from me, your rank will not get affected. So overall, biochemistry questions were moderate. So how many questions were there in biochemistry? Totally, there were 12 MCQs. And out of the 12 MCQs, what I found interesting is there were no MCQs on vitamins, 0 questions on vitamins. And as expected from genetics, there were maximum number of questions. There were 4 questions on genetics. And then 2 questions on inborn errors of metabolism, carbohydrate metabolism 2, lipid metabolism 1, amino acid metabolism 1, ABG 1, and then 1 analytical biochemistry MCQ. Yes, Zwitterion we have already learnt, right? I've showed you that graph on glycine titration curve and how to find out the isoelectric pH. That exact graph was shown. So overall, this is exactly as expected. The only difference that I've observed this time is there were no MCQs on vitamins. Okay. So what are the questions? Let me start with the curveball, the analytical biochemistry MCQ. So this is the question. Name the graph and mention its applications, right? So the right answer here is plasma resonance, and this is a graph that is used to find out antibody affinity. It is used to find out kinetics related to antigen-antibody reaction. And this graph is called as SPR. Yeah, this graph is called as SPR, which is basically used to find out whether the antibody that is chosen has got adequate affinity for the antigen or not. So for ELISA, we need antibodies, specific antibodies. After we create those monoclonal or polyclonal antibodies to find out if there is any specific affinity, this is the graph that we draw, wherein along x-axis there is time and along y-axis it is resonance units. Okay. Yes. Yours is right. Very good, Parmar. Even if it's wrong, as I said, your rank is not going to get affected. Okay. So that is this graph. And then the next one. A woman with a strong family history of breast and ovarian cancer is being evaluated for BRCA1 and BRCA2 mutations. Which of the following is the most appropriate test to detect multiple mutations at different codons in these genes? And before I tell you the answer, okay, let me tell you the answer first. Did you all see this choice? Next generation sequencing or digital droplet PCR? If you had seen this question, that is the right answer. Hi, Priyanka. Yes, yes, it's a busy schedule. So I'm meeting you all from Belgium, right? So I've come here to Belgium for attending a conference, and I'm representing the Association of Medical Biochemists of India in Belgium. And despite that, I was super curious since morning to know how the question paper is, and I was always online getting to know all these MCQs, finding out the right answer. So hi to you all from Belgium. Yeah. Yes. So what is the right answer here? The right answer here is next generation sequencing or digital droplet PCR. Okay. So why am I saying that this is the right answer? Why not the other 3 choices? For this, you will have to understand that thousands of mutations are possible in BRCA1 and BRCA2. What kind of mutations are they? They can be frame shift mutations, they can be transitions, they can be transversions, insertions, deletions. So when there are multiple mutations, what is the effect that they cause? It's a functional defect they cause. There is no changes in the level of gene expression. It's only a functional defect. In that case, can you use quantitative PCR? Quantitative PCR is used only when there is differences in the level of gene expression. That is not we are observing here in this condition. That is why it is not qPCR. And then RT-PCR or reverse transcriptase PCR, as I told you, is used only when you're trying to find out an RNA. Are you trying to detect a defect in RNA or are you trying to defect in a DNA? We are trying to find a defect in a DNA. And that is why it is not RT-PCR or reverse transcriptase PCR. Northern blot, it is used only for RNA expression. Here it's we are trying to find out DNA differences. And that is why what is the right answer? No D. So what was the choice D? Whatever the choice D was, that is the right answer because all these 3 cannot be used. It is either next generation sequencing or it is digital droplet PCR. One of these 2 choices would be the right answer. Or if it's exome sequencing. Did you see exome sequencing? That can also be the right answer. Yes. So in that case, the right answer is exome sequencing. Okay. Gunavalan, did you see choice D as exome sequencing? Then that's the right answer. Yeah. Good. That's nothing but next generation sequencing, right? Yeah, it's another term for next generation sequencing. So the answer is choice D. Now, which of the following techniques are correctly matched with their uses? Didn't we discuss this in the rapid revision session? In LRR session, I told you this, right? So southern blot is for DNA identification. I even told you South Indians love dosas, right? So southern blot is for DNA identification. North Indians love roti. So northern blot is for RNA identification. Western blot is for protein identification. So the right answer is choice D. Yes. After how many cycles of PCR? I would say this is a very interesting question. After how many cycles of PCR are we expected to have half the number of copies as found after 26 cycles? All that you need to know is in PCR, the number of products that you get is 2 to the power of n, where n is the number of cycles. So at the 26th cycle, how many copies will you get? You will get 2 to the power of 26 products. So when will you have half this number? The one cycle before that, right? In one cycle before that, you would have 2 to the power of 25 products. That is 1/2 of this. Do you all understand this? So what is the right answer for this? The right answer for this is choice C, or 25. Okay. So it's an interesting question, right? All that you're expected to know is the number of products at the end of n number of cycles is 2 to the power of n. So in the previous cycle, you will have half the number of products. Okay. The next one. For Mycobacterium species differentiation, technique used is or are, right? And this is a multiple right answer type MCQ. So Mycobacterium species differentiation, we have Mycobacterium tuberculosis. Apart from that, we also have ABM species. Remember, Africanum species. And we also have non-tuberculosis Mycobacterium. And for differentiating all these strains, we are dependent on specific sequence-based differences. And to find out sequence-based differences, yes, you can use RFLP. You can use polygotyping. Polygotyping is all about the differences in the spacer sequences that are observed in the genomic sequences of Mycobacterium tuberculosis. So polygotyping can be used. Mycobacterium interspersed repetitive units can be used. And have you all heard of line probe assay? Yeah, line probe assay is actually used to find out drug sensitivity, to find out whether there is resistance to rifampicin, to find out whether there is resistance to INH. But actually, line probe assay is a hybridization technique. And this hybridization technique can be used to find out specific sequence variations, which is the hallmark, right? It's a landmark principle behind how to find out species differentiation. So the answer is all 4. Chromosome analysis was in the option instead of line probe assay. So even if it's chromosome analysis, that can also be used. When you say chromosome analysis, it's basically DNA differences. Do you all understand that? So whatever we are detecting here, species differentiation is DNA analysis, right? So the right answer would be all 4. Even if it's mutation analysis or chromosome analysis or DNA analysis, you can choose that. Shelby, if it's a wrong option, I would recommend that you give me the right option. Yeah, because we have Miru. Miru is a principle, which is Mycobacterium interspersed repetitive unit-based differentiation. Polygotyping can be used. RFLP can be used. And then if the last one is chromosome analysis or mutation analysis, that can also be used. And this we have discussed so many times, right? A child presents with, what was your right answer? A child presents with fatigue and hepatomegaly. Liver enzymes are elevated. Ketosis was significant. This is one key feature. The other one is after feeding, blood glucose levels rise, but there is no rise in glucose after overnight fasting. So what do you think is the right answer, everybody? The answer is choice A, glucose 6-phosphatase defect. Because glucose 6-phosphatase defect is von Gierke's disease, right? So how did I exclude all other choices? This is not phosphofructokinase 1 defect, because in that case, there should have been hemolysis. They have not given you anything related to hemolysis here. And in phosphofructokinase 1 defect, there is no reason for hypoglycemia to present. That is why it is not choice D. This is not muscle phosphorylase defect because muscle phosphorylase defect presents only with muscle or exercise intolerance. It can present with fatigue, but it does not present with hepatomegaly. Now, how do we differentiate von Gierke's disease and liver phosphorylase? The classical statement here is, even after overnight fasting, plasma glucose does not increase. When you say overnight fasting, it is 12 hours of fasting. So after 12 hours of fasting, gluconeogenesis will be switched on. So if it is only glycogenolysis defect, plasma glucose level would have increased. So even after overnight fasting, if there is no increase in plasma glucose, then what is the right answer? The right answer is glucose 6-phosphatase defect. Okay. So the answer is choice A. Severe hypoglycemia was given. That is another clue. The third clue is ketosis. Yeah, maximum ketosis, significant ketosis observed in glucose 6-phosphatase defect. Choice D was debranching enzyme defect. Even if it's debranching enzyme defect, there will not be severe hypoglycemia and you will not see ketosis. And after overnight fasting, if there is no increase in plasma glucose, all these would point towards von Gierke's disease. Do you all understand that? No, it is not glycogen phosphorylase defect. As I explained it just now, if it's glycogen phosphorylase defect, after overnight fasting, plasma glucose will increase. Do you all understand that? This is the classical clue. There is no rise in glucose even after overnight fasting. What is that? That is classical of von Gierke's disease. Okay. Liver biopsy shows glycogen accumulation and options. Arpita Patel, had it been a debranching enzyme defect, they would have mentioned that liver biopsy reveals amylopectin or alpha-dextrin or limit-dextrin. They would not say it is just glycogen. Do you all understand that? Yeah. A child presents with hepatomegaly and a cherry red spot on the macula. Neurological regression is also noted. These findings are suggestive of a lysosomal storage disorder. What is your right answer, everybody? The right answer is sphingomyelinase defect. Yeah, the right answer is sphingomyelinase defect, which is Niemann-Pick. Okay, so why am I excluding all other choices? What is galactocerebrosidase defect? Beta galactosidase defect, what is it called as, all of you? Krabs disease. And why am I excluding Krabs disease? Krabs disease, what is not seen? Cherry red spots are not seen. What is the mnemonic again for no cherry red spots? No cherry red spots in KGF. So Krabs disease, no cherry red spot. That is why it is not choice D. Okay. Yeah. Startle reflex was normal. Yeah. That by itself would exclude which condition? Hexosaminidase A defect. If it was hexosaminidase A defect or Tay-Sachs disease, startle reflex cannot be normal. And the other reason for why I'm excluding Tay-Sachs disease is they've told you that there is hepatomegaly. What have I told you? Tay-Sachs disease, no organomegaly. So hexosaminidase A defect or Tay-Sachs disease can be excluded. Aryl sulfatase A defect, which is metachromatic leukodystrophy. So metachromatic leukodystrophy does not present with cherry red spot, does not present with organomegaly. It presents only with neurological regression. And that is why what is the right answer? The right answer is sphingomyelinase defect or Niemann-Pick disease. Are you clear? Yeah. So the right answer is choice C. So this we have discussed so many times, right? Cancer cells take up excess glucose because the answer is lactate is produced even in the presence of oxygen, right? We know this is Warburg effect. So what is Warburg effect? Even in the presence of oxygen, neoplastic cells prefer to use glucose. What is the reason I told you? The reason is when it uses glucose, many of the intermediates can be used as building blocks. And when it uses glucose, the ATP production can be faster. Though the ATP production is faster, this is not an optimal way of generating ATP because the number of ATP that is produced is less, right? Because the number of ATP that can be produced is less, neoplastic cells will have to use more and more glucose. All glucose get converted to lactate, producing only 2 ATPs. So what is the right answer, all of you? The right answer is lactate is produced even in the presence of oxygen. Okay, so how about NADH-NAD ratio? No, right? There is no NADH-NAD ratio which is high because it is aerobic metabolism. And though there is oxygen, it uses glucose and glucose becomes lactate. Whenever glucose becomes lactate, NADH would become NAD. Okay, and do you see high GLUT2 transporter? No, we see high GLUT1 transporter. Which transporter is present in neoplastic cell? It is GLUT1. No, increased metabolism instead of absence of oxygen. If it was increased metabolism of pyruvate to acetyl-CoA, that is a false statement. Because we know in neoplastic cells, pyruvate become lactate. Pyruvate does not become acetyl-CoA, it becomes lactate. Got it? Yes. So the right answer is lactate is produced even in the presence of oxygen, and that is why cancer cells take up excess glucose. So is this the question that you are discussing, that you are asking me about? NEET PG 2025, after a high carbohydrate meal, weight gain is explained by all except. The answer is mitochondrial carnitine. Right? Why is it mitochondrial carnitine? Malonyl-CoA will be formed. Why will malonyl-CoA be formed? When there is carbohydrate meal, glucose is high. Glucose goes through glycolysis. Glucose becomes pyruvate. Pyruvate becomes acetyl-CoA. When acetyl-CoA is formed, acetyl-CoA enters into fatty acid synthesis. Which enzyme converts acetyl-CoA into fatty acid? Acetyl-CoA carboxylase. So we know choice C is responsible for the weight gain. When acetyl-CoA carboxylase acts on acetyl-CoA, it becomes malonyl-CoA. So yes, malonyl-CoA is involved in high weight gain. And then tricarboxylate transporter is involved in fatty acid synthesis. Because pyruvate dehydrogenase complex converts pyruvate into acetyl-CoA in mitochondria. Fatty acids have to be synthesized in cytoplasm. So acetyl-CoA should be transported from mitochondria to cytoplasm. That is done by tricarboxylate transporter. So which is the right answer here? The right answer here is mitochondrial carnitine, which is not involved in weight gain, because carnitine is involved in fatty acid oxidation, not in fatty acid synthesis. So what is the right answer, all of you? The right answer is mitochondrial carnitine. So this MCQ we have discussed so many times. In the given glycine titration curve, calculate or identify the pH at which molecules exist in a Zwitter ion form, right? So I've told you to look at this graph wherever there is a very flat line, right? Do you see a flat line here? Whenever you see a flat line, that is where it is called as pK1. Right? So when you look at glycine, glycine has got two functional groups. One is an amino group, the other one is a carboxyl group. So you have pK1 and pK2. And only around pKa, there is maximum buffering capacity. What do you mean by buffering capacity? Even when you add sodium hydroxide, there is no change in the pH. So this is the point where you have pK1. So which is pK1 here? 2.2. That is the pK of carboxyl group. Again, there is a buffering capacity that you observe here, wherein even after you add sodium hydroxide, there is no change in pH. So pK2 is 9.6. That is the pK of the base, that is amino group. What is Vetter ion form? That is a form that exists at isoelectric pH. What is isoelectric pH? How do you calculate isoelectric pH? It's an average of pK1 and pK2. So tell me what is the average here? 2.2 plus 9.6 by 2, which is 11.8 by 2, which is 5.9. What is the average of 5.9? 6. What is approximation of 5.9? It is 6. So what is the right answer? The right answer is choice B. So all that you need to know is whenever you look at the titration curve, you see the point where you have a flat curve, right? Wherever you see a flat curve, that corresponds to pK1 and pK2. What is isoelectric pH? Average of these two pK values. So here it is 5.9, which can be approximated as 6. Okay. A very simple ABG question, right? Ascent to high altitude causes. When you go high altitude, you hyperventilate. When you hyperventilate, you wash away carbon dioxide. So which pH will you observe? Alkalotic pH. Carbon dioxide is a source of an acid. When you get rid of a source of an acid, you observe alkalotic pH. So it is respiratory alkalosis. Right? So in contrast to what we were all expecting, right? We were expecting about compensation. We were expecting about anion gap. Is it high anion gap, normal anion gap? Some of the students were even asking me about delta ratio. In contrast to all those expectations, it's a very simple ABG question. They just asked you what happens when you ascend high altitude. It is respiratory alkalosis. So to summarize, out of the total number of questions, which is 12 in biochemistry, image-based questions were 2, right? The one graph question which I showed you, right? So that graph nobody is expected to answer. And apart from that, the other MCQ was very simple. It's a titration curve. And there were 4 case-based MCQs. 2 were on inborn error of metabolism. And then one, I told you, it is like on having carbohydrate-rich meal, what happens? And then BRCA1, BRCA2 mutation in a family with high incidence of breast cancer. Right? That's all. 4 case-based MCQs. And one, I would call it as a conceptual MCQ, where it was about how many copies were found. Right? PCR, how many copies? It's a conceptual MCQ. But apart from that, 5 were one-liners. Okay. So to summarize this session, what I would like to tell you all is, what is done. So don't overthink. Yeah, don't fry your brain thinking about how many MCQs have I gotten right, how many MCQs have I gotten wrong. You have done your best, right? So this by itself is a milestone in your life. Being able to prepare for INI CET, being able to face INI CET exam with confidence, coming out of the exam hall and looking at an analysis, paper analysis by itself is a milestone. So pat yourself back for what you have achieved so far, right? And for those who are here for attending the next NEET PG exam or the next INI CET exam, take it from me, INI CET is not, it is not as tough as you all think. It is not a high-hanging fruit. Okay, all that is expected is clarity in thought, clarity in concept, right? Learn all topics conceptually and go through all previous year questions. Out of the 12 MCQs that I discussed today, 11 concepts have been already discussed. It is just that the way they ask those questions is always tricky. Right? For example, high carbohydrate meal. I would not expect a question on tricarboxylate transporter. They've given you that. That by itself is an MCQ. So all that is expected out of you for you to be able to crack an INI CET exam is to learn the entire subject. When I say the entire subject, all 19 subjects conceptually, in which case you will be able to crack the exam. Overall, the paper is moderate. If you feel that the paper is moderate, you have high chances of getting a good INI CET rank. Yeah. So thank you.
So very good evening everyone. Welcome to the psychiatry analysis of the INI CET today. So in total, the questions which we were able to gather were around 8 questions from psychiatry. So what we're going to do in this session is, I'm going to show you the questions. I'm sure some wordings might not be the same. So I would want you to just write down in the chat box any changes in the question as well as any changes in the option. Of course, we'll come with again a better recall. So the point here is to get all the questions and try to see what possible answers were there. So let's talk about the first question. Now see this question, I'm sure this question would not have been very difficult. Which of the following is not an essential symptom of depression according to ICD-10? So we had talked about the symptoms of depression with the mnemonic SIGE CAPS. Now very important to remember in this SIGE CAPS, one is low mood, yes, that is the option. There is decreased interest, the interest is low, that is also in the option, and yes, low energy was also an important criteria in ICD-10. So yes, loss of confidence and self-esteem, that is the right answer here. Also remember, in DSM-5 as well as in ICD-11 now, there are 2 essential important criteria, that is low mood and loss of interest. So earlier, even low energy was one of the important features of ICD-10 for depression. So the right answer here is option D. I hope all of us got this answer correct. Let's move on to the next question. So again, psychopharmacology is one topic which we are expecting question. So this was the question. A 40-year-old female with bipolar disorder is planning to conceive. She is planning for pregnancy. Which of the following drugs you will avoid? Very important, they have mentioned due to neural tube defects. The options are valproate, oxcarbazepine, lamotrigine, levetiracetam. I'm sure all of us would have got it correct. The right answer here is valproate. So please remember valproate. Also remember, even carbamazepine can cause neural tube defect. If that was given in the option, still we will go with valproate. So there are more incidents with valproate. So the right answer here is option A. I hope all of us got this correct. Right, let's go to the next question. Now we have got 2 questions, very similar questions. First of all, let me know if there were 2 such questions. The question is, which of the following is an incorrect statement? So let me know if there were 2 questions like this. So I'll show both the versions. If both were present, we'll try to answer them. So we have to tell the incorrect option. So option A is cannabis causes minimal withdrawal physical symptom. Yes. The physical withdrawal symptom with cannabis we know is yes. Although yes, earlier it was believed that it does not cause physical dependence, now we know that mild physical withdrawal symptoms are present. Opioid withdrawal rarely results in death, that is also a correct statement. Remember, opioid intoxication may cause higher risk of mortality. Buprenorphine is used in opioid withdrawal treatment, yes, that is also correct. We use in the management. Flumazanil used in long-term treatment of alcohol dependence. This is an incorrect option. Yes. So this is the right answer. Let's go to the next question. Now there is another similar question. Just let me know if there were 2 such questions. Yes. So we'll try to answer this also. Again, the question is which of the following is incorrect. Now this question is in fact slightly controversial. Now option A is cannabis can cause self-driven repetitive behavior. Just let me know if this was there in the question. So just let me know if this was there in the option. We'll come to this. Volatile inhalational agents are toxic to humans. This is correct. This is correct. Opioids are commonly used as analgesic. This is also a correct statement. Now let's move to option D. Alcohol acts as a stimulant at low doses and a depressant at high doses. Just let me know if this was the exact wording of the option, because if this was the exact wording, the answer may change. Please remember, alcohol we know is a CNS depressant. Alcohol is a CNS depressant. The initial excitatory effect which occurs because of alcohol is because of disinhibition. So we say alcohol is a CNS depressant. So if this is the statement, had they mentioned that initially it causes excitation and later on it causes depression, that might have been considered as a correct answer. If this is the exact statement, this I would say is incorrect. Now cannabis use causes self-driven behavior. Again, this self-driven, they have not mentioned what they mean by self-driven. Is it that the person is trying to procure drug, repetitive taking of drug, or is it some kind of symptom like obsessive compulsive symptom? That is less common with cannabis. But still, if this is the exact wording, then here we may choose alcohol. Alcohol, we know it's a CNS depressant, but initially in the lower doses it may cause excitatory effect because of disinhibition. Again, the answers may change if the wordings may change. So let me know if this was the exact wording, then we are with the correct answer here would be option D. Now let's see this question. Again, a very interesting question. Now again and again we are seeing questions being asked from MSc. A patient with schizophrenia says, Hanumanji is celibate, I am also celibate, so I am Hanuman. Now what is this example of? Now very interesting, very important, let's try to understand. Now sometimes when such question come, try to rule out the option. Is it neologism? No, it is not neologism. So remember, it is not neologism. Is it verbigeration? Some of the students said that verbigeration was given, where there is repetitive phrases, words are repeated. No, there is no such repetition, or there is no word salad. Loosening of association, again it is not there. Please remember, in loosening of association we have discussed that the person may say certain words which are not making much sense. Here the words which he spoken, the sentences which he is speaking is absolutely right. So here it's an example of autistic thinking. If you remember, in schizophrenia we have discussed 4 A's. One of the A is autism. The person may have autistic thinking, fantasy thinking, or illogical thinking. So this is an example of autistic thinking, where the patient, this is actually syllogism, where the patient is using 2 statements and then is coming to the conclusion. So here the answer is autistic behavior. Very important, even if you're planning for other exams like NEET PG, such questions may be asked. So even if you don't know the answer at the first go, try to rule out the option and then you'll come to the correct answer. I hope this is correct. Yes, this was verbigeration. So option again B is also incorrect. So here the answer is, it is autistic behavior. Let's come to the next question. Which of the following psychoactive substance is a new rapid acting antidepressant? In fact, very important, we have talked about, even in RR, we have talked about S-ketamine, we have talked about S-enantiomer of ketamine, and even in the version next video you'll see we have talked about that ketamine is one of the drugs which has a rapid onset of action. Usually the conventional drugs which we use for management of depression, you will see that it takes time. But ketamine is one of the drugs which is having a rapid onset of action. In fact, S-ketamine, which is approved for depression, it is used as a nasal spray. So remember here, the correct answer is ketamine. I hope this is clear to everyone. This, I would say yes, it's a direct question they are asking. Now see this question, again this is a more of a psychopharmacology question, also discussed in pharma. Imipramine, which is an antidepressant, it's a TCA, diphenhydramine, which is an antihistaminic drug, are given together to a patient. Why is this combination irrational? I'm sure now all of us know the right answer. So we know both of these drugs, that is imipramine, which is TCA, and diphenhydramine, they both have anticholinergic action. So this is the correct answer. Let's go to the next question. Again this question you will see, management of mania, management of bipolar disorder might be asked. So see this question. Which of the following drugs are used in the treatment of acute mania? Now we have talked about this. In the management of acute mania, we have antipsychotics, we have lithium, and we have valproate. So these are the important drugs which we use in the management of acute mania. If one drug is asked, then I'll choose antipsychotic. So there is multiple options are there. So let's see. Yes, haloperidol, it's an antipsychotic. Valproate, yes we can use. Lithium, yes we can use. So the answer is 1, 2 and 3. Please remember amitriptyline, which is an antidepressant. Again, such question may be asked. In fact, if a patient comes to me who is earlier having depression and was on antidepressant, and now he has developed mania, we have talked about this, that the first step we do is we stop antidepressant, because the antidepressant can elevate the mood. The mood is already too much elevated. So the first thing is we'll stop antidepressant. So of course, we'll not use antidepressant in the management of acute mania. So the right answer is that these 3 drugs, 1, 2 and 3, can be used for acute mania. So these were the questions which we have got. Let me know in the chat box if any changes you have, so that we can again modify and we'll come back with a more accurate form of recall. So this was from my side. Again I'll say the questions were not very difficult. Some of the important points you should remember is drugs are very important if you're planning for NEET PG. Again, substance is very important, and also try to rule out the option sometimes to get to the right answer. So this was about the psychiatry recall. So thank you very much, and may God bless you all. Thank
Hello students, good evening. And as I could see, I think you did your paper really well. So Can you hear me? Is my voice audible, and can you see me? I'll wait for a few thumbs up. Okay, so how was dermatology, people? I think the dermatology questions were quite easy and there was a significant overlap with other subjects. So how did you fare in your dermatology questions? Were they easy or do you think it was quite difficult? Wonderful, wonderful. Yes, I think Derma was quite fair, and I think they cover the most of the questions which were there were from the most sought after topics. And in fact, most of these topics were told to you when we gave you a video on what important topics you should be studying just before the exam. And now, as I always say, Derma is very image based, and whenever we teach, we give you a lot of images. And so I felt that in dermatology, they had almost given you images for most of the questions, and that was quite a pickup for the answers. So that image based thing was something which I think has been there for quite some time, and it's staying. Most of the questions, I think, were from the important covered topics, and there were a few repetitions, but there were few questions which we still need to have a proper detail. And so those were probably something new. So as we walk down this session, I would want you to tell me some of these questions. You can tell me what is wrong, what options do you think were there, and if any other questions you think were there. So, great. So, this was the first question that I have, and I think this was discussed by Dr. Preeti as well. A patient reports a history of genital ulcer and presents with this papular brown rash involving the palms. What next investigation would you order? This image has been shown to you hundreds of times in all rapid revisions, in the main lectures, in all the questions that we give you. This is the rash of secondary syphilis, and we know that we are talking about syphilis here, and the test that is done for syphilis is VDRL, which is a serological test. So I think it was quite a giveaway, and the image was something which you would have seen hundreds of times. I hope you agree with me. Right? So was this question the same? So if there was any change in the question and options, I would want you to give me the details. I'm not covering the questions and options in details because there's a recall session on Monday when we will be doing that. So whole idea is to analyze the paper here. So this, I think, was a very easy question. The next question, again from genital ulcer. So if you remember, we told you genital ulcer disease is a must, and there was a chart, and the 5 genital ulcers disease were covered in great detail. So here something like a biopsy of a patient was given presenting with painful vesicular lesions and superficial erosions in the genital area. Very frankly, I don't think so you needed an image for this one. Genital area, painful vesicular lesions, superficial erosions. I think we have discussed hundreds of times that it is herpes, and the treatment for herpes is acyclovir. So again, a very, very straightforward question, right? Yes, you're all right. So I just wanted to know that had they actually given you a biopsy image, and what was the biopsy image that was given? Did they show you some coilocytes? Did they show you some MNGs or what? So if you can help me out there, that what was shown on the biopsy? The image was bad, thank you. So thankfully, even if the image was bad, the question was self-explanatory and you did not need the image, right? Okay, so you're telling me that probably multinucleate giant cells were seen. Again, that is something which was a direct hint at the question. Now, this is one question that I'm still struggling with, and I would need your inputs because I am not quite sure that what the exact question was. Or if you could help me out with the image. Probably you got a patient's image who presented with asymptomatic plaques on the neck region with no systemic symptoms. And you were asked which investigation would you order. Now, this is a very, very insufficient information that I have to give you the correct answer. But if you can help me out on what image was actually given. So, okay. Great. So you are as clueless as I am. It was a lesion on the neck and velvety. Okay. Okay. So help me out. Was it a dark lesion, pigmented lesion, an erythematous lesion, or a bluish lesion? Could it somewhere fit in the spectrum of cutaneous tuberculosis? In the neck, X-ray option was there. See, so since the question is very, very insufficient, so probably here we have to talk about, we will be discussing this in recall. I'm just willing to ask you about the options that which were there. So it can be tuberculosis, Kaposi, if it is velvety, dark, it can just be acanthosis nigricans. Left lateral neck erythematous lesion was there, looked like central clearing. Pink lesion with cluster of folliculitis. So I think more or less all of you are pointing towards a lesion on the neck, which was probably erythematous, had either folliculitis or scaling. So if something like that was given, I would go more in favor of TB. And so there the investigations would focus more on finding out the underlying focus of TB and skin TB. Is that right? Okay, but some of you are also telling me that it was probably Kaposi sarcoma, which changes the scenario. Kaposi sarcoma, you do HIV biopsy, you do not need a TB workup for that. So, okay. So, okay, we'll get back to this question in more details during the recall session. Till then, thank you all for your inputs. Keep giving me the same, and we'll try to figure out the exact question by then. Next question, also discussed in pharmacology, which are the treatment options for scabies in children? Now, I'm not sure whether the option said child or whether it said infant. Now, ivermectin is an oral drug not given in less than 6-year-old. So if I had an option here in a child, I would say A, B, and D, because all topicals can be used in scabies. But you have to help me out here, whether it was the treatment of choice or whether it was infant or a child there. Okay, so some of you are saying infant, some are saying child. Perfect. If it is an infant and they had asked you treatment of choice, my answer would be different. It would be permethrin. But if it is like what all can you can use all topical application creams, not GBHC in infant, which is not there in the option. So ivermectin will not be used. Rest of the topicals you can use. If neonate, then permethrin only, or if they'd given me option of precipitated sulfur. Okay, so A, B, and D was not an option. So what was the option? It's infant. So most of you are saying that it was an infant. And okay, and did they say treatment of choice or did they say what all can you use? Okay, so all right, if neonate was there, again, so things would vary. So, okay, we'll get back to this question in more detail. I think we'll have better options and answers by then. So ABD was not used except. So we can use everything except, okay. So if it is a child, we can use everything except ivermectin. In fact, child more than 6 years, you can even use ivermectin. Infant, we will not use oral medicine. Right. Which of the following are side effects of topical steroids? Very easy question. Again, skin atrophy, hypertrichosis, acne, blue discoloration. So all three ABC are side effect of corticosteroids. We have studied them. So topical corticosteroids again was not a difficult thing. I think the only difficulty in INI CET is when they give you such confusing questions and the options are not accurate. We do not know whether it was ABD, ABCD or what. So like in the previous question, but in this, I think ABC would be the answer. Blue discoloration is usually not seen with topical corticosteroids. I know, Dr. Ansh, multiple correct answers. So INI CET is, that's why it's INI CET, because of multiple options that you have. So that makes the exam, I think, more confusing. Otherwise, the questions are more or less straightforward. Now, here again, I need your help. So here, there were few statements and I had to tell which is the correct statement. So first option, stratum corneum. Okay, which are the ones seen? Okay, neonate was written. So neonate we are going back to the scabies question. In the neonate, were the options similar? I am not getting any other choice for the options. Were the options same or different? You have to tell me that. Now I'm moving on to the next question. Which statements are correct? Stratum corneum is the first cellular layer of the epidermis. That's true. Regeneration of, I think here in this question, I need your help. I don't think so. These are the exact options that were there. So can you help me out here? So again, this is a question from very, very basics of dermatology. We've studied about layers of epidermis. We have given this to you in notes, in rapid revision. So all of this has been covered. In fact, this is the first topic that we've always covered in dermatology. And statements were these only. Acellular. Where was acellular given? In which option? So stratum corneum is the first. Okay, so you mean to say stratum corneum is the first acellular layer of the epidermis. Regeneration of epidermis occurs from the level of hair follicle and sebaceous glands. Okay, and what about the option 3 and 4? Dermis and inner hypodermis. Where is dermis and inner hypodermis? So dermis and inner hypodermis is derived from endoderm. I think that is what you mean. Epidermis is derived from ectoderm. Okay, 1, 3, 4 option was there. So scales were seen in which condition? Are we talking about this condition when we say scales were seen in? Okay, options are correct. So some of you are saying it's showed first acellular, some are saying it's cellular layer. That changes the answer. Dermis and inner dermis were derived from endoderm. Okay. I think this was a little tricky question, as I could see, because they have the options that have been given have slightly been modified. Again, wait for the recall session. We will discuss all these options in great detail. But I felt that this was the only difficult question in dermatology. Rest of them were easy. These KB's question was a little confusing depending on what were the real options. Otherwise, I think that's the end of dermatology questions. Any questions you think that we have missed, you're most than welcome to tell us, and we can then discuss all these questions in great detail in the recall session. This apart, I think rest of the questions you would have done very well. And so I'll wind up the dermatology paper analysis session here. And thank you so very much for your inputs. Relax and just enjoy your night today. Thank you so much.
Hello, guys. I won't be taking much time of yours, right? We'll start with this anesthesia. So the first, basically, couple of questions came from anesthesia. The first question that came was, a 50-year-old male patient who underwent lower abdominal surgery under general anesthesia. Vecuronium was administered as a muscle relaxant during the procedure. At the end of surgery, which of the following is the most appropriate agent to reverse the effect of vecuronium? Remember, guys, in reversal agents, we are having many reversal agents. The most commonly used reversal agent is neostigmine. But again, while teaching also, I told you that neostigmine is most common. But for vecuronium and rocuronium, we are commonly using a reversal agent called as sugammadex, which is a newer reversal agent, right? It doesn't mean that neostigmine cannot be used. But here, sugammadex was not given in the option. So what you have to do is, you have to exclude the options. So look over here, guys. Baclofen and dantrolene sodium are directly ruled out. Why? Because these are centrally acting muscle relaxant. They cannot be used for reversing the effect of vecuronium, right? Next, we are left out with two options. One is neostigmine, other is atropine. Remember, neostigmine can be used for reversing the effect of vecuronium, but atropine can never be used. What we do is, when we give neostigmine to the patient will have bradycardia. So what you do is, you either mix neostigmine with glycopyrrolate or either with atropine and give to the patient, right? So the right option over here is what? It is neostigmine. Next. Again, this recall question, this is not properly recalled. There was some MCQ regarding sodium thiopentone. Sodium thiopentone, why it is regarded as rapid acting or ultra short acting drug, right? Some true or false was given, guys. So regarding sodium thiopentone, remember, sodium thiopentone is regarded as an ultra short acting barbiturate due to some reason. What is the reason, guys? Due to rapid redistribution. When you give sodium thiopentone, after going into the brain, then it gets rapidly redistributed into the fat and the muscle. Due to that, it becomes an ultra short acting barbiturate. Okay. There were many statements out of which was about sodium thiopentone. Again, guys, please recollect what statements were there. I just got this MCQ. Okay, I know the MCQ was not straightforward like this. There were some statements and they asked you some true or false, but I wasn't able to recollect all the statements. Okay. Right. Next, guys, regarding lumbar puncture. Redistribution option was not there, sir. Redistribution. Okay. Anyways, you just recollect. We are just having having this discussion, guys, based on the exam experience and all. It will take 1 or 2 days to get the exact wordings. The whole question was not about sodium thiopentone. Okay. Anyways, all right. Next question was regarding the lumbar puncture. Again, this is again a controversial question. Why? Because some of the students were saying this was the options were not right and all. But still, which of the following statement is false regarding lumbar puncture? PDPH is commonly seen in young females. Yes, post-dural puncture headache is commonly seen in young females. Why? Because repeated cesarean sections and repeated spinal injections that can lead to a cause of PDPH. Next, meningitis is not a common complication of lumbar puncture. Yes, meningitis is not a common complication unless and until you perform lumbar puncture. You perform it in a very shabby manner. Yani ki you are not performing lumbar puncture in a strict aseptic precaution. Then only meningitis will occur. Next, lumbar puncture must be done in patient with subarachnoid hemorrhage with a normal non-contrast CT. Yes, but which is the false, guys? Option D was not there. Platelet less than. Acha, someone is telling more than 10,000. Some are telling female was given but old. If at all PDPH was mentioned, just look over here, guys. If at all post-dural puncture headache was mentioned and he asked you about old females, then that's a wrong option, guys. Then your answer becomes this. Okay? Lumbar puncture is safe in thrombocytopenia? No, it's not safe in thrombocytopenia. Again, I have not got the exact wording. What was, because some of you are saying lumbar puncture was contraindicated. Some of you are saying safe. Some of you are saying more than 10,000 or less than 10,000. Okay? So we will have this detailed analysis on all the questions, guys. हाँ, अगर एल्डरली फीमेल था तो वही ऑप्शन होगा अभी. एल्डरली फीमेल में पीडीपीएच बिल्कुल नहीं होगा क्योंकि एल्डरली फीमेल में यूजुअली नहीं होता है. यंग फीमेल्स में रिपीटेड स्पाइनल इंजेक्शंस, रिपीटेड सिजेरियन सेक्शन की वजह से होता है. ओके, प्लेटलेट काउंट अगर लेस देन 10,000 है बोले तो स्पाइनल लंबार पंक्चर इज नॉट सेफ. व्हाई? बिकॉज रिमेंबर, स्पाइनल एनेस्थीसिया के लिए भी मैंने आपको पढ़ाया था. व्हाट if at all the platelet count is less than 80,000 as per the practical guidelines and as per the book guidelines. If it is less than 50,000, we cannot do a lumbar puncture. It will cause spinal hematoma. Okay. Once again, guys, again, it was just a rapid recall. We'll have a detailed recall on 19th. Okay. Till then, if you are getting any questions, if you are able to recollect any questions, you can connect me. You can connect to me on Instagram, or you can just post on the Prepladder group, right, about the questions. We'll go through it. On 19th, we'll be having a detailed discussion on the questions. How C correct? Lumbar puncture can be done in patient with subarachnoid hemorrhage with normal NCCT. It can be. Why it can't be done, guys? Sir, one statement was about alcohol in low dose. Again, alcohol in low dose, whether it is cerebral stimulant and all, it's not related to our anesthesia. Okay, guys, I insist once again, please, if you are able to recollect any questions, please post it on Prepladder group, or please post directly. You can message me on Instagram. Okay. Right. Okay. Okay, guys. Sir, is LP safe for more than, remember, lumbar puncture, if at all the option was given, lumbar puncture for more than 10,000 of platelet count, can it be safely given? Then also it doesn't make any sense. Why? Because remember, for doing lumbar puncture, at least you should have a platelet count of 50,000. More than 10,000 means what? It's not given any basically या तो more than 50,000 देना था या फिर it should be less than 10,000 or something. The question still we did not get what is the exact wordings. ठीक है, ऑप्शन के वर्डिंग्स हमें अभी तक नहीं मिले हैं. जब जैसा भी मिल जाएंगे, we'll frame the question accordingly. Sir, it was with sodium thiopentone question. No, it won't lead to herniation. It won't lead to herniation. Why? Because the NCCT is normal. If at all in the question it was mentioning you the patient is having the features of raised intracranial pressure with subarachnoid hemorrhage, then it will be contraindicated. Contraindicated क्या? It is avoided. ठीक है भाई? ठीक है? So guys, this was the recall session. We'll meet you on 19th for a detailed recall for all the subjects. Okay? Till then, relax. Okay, guys. Bye.
As you can see in the image here, the stem of the lateral septum